here is that you can recommend to your refractionist to use the retinoscope, the horizontal streak. And we've done a study which was published. It adds a dynamic element to the entire process. So when you move it up and down, you can see, and you can even have antimetropia because it can move differently in each eye. And of course, the last point is you can use the digital cameras and nowadays the smartphones too to actually capture the reflex. And the one we've used in the past for some studies and we're using for another one is the one that was recommended by the ABCD program, that is the Alaska Blind Child Discovery, the Canon CP-TX1. And you will notice the important thing is that the flash should be vertically offset from the aperture of the camera lens. Whether it's above or below is not so important. It shouldn't be on one diagonal because then it will favor one of the eyes as far as the reflex is concerned. And the camera should have the red eye reduction feature, which can be switched off because you want the red eye, you want that red reflex. And you can see that these brighter crescents, like in this case inferiorly, they suggest myopia. And the different size in crescents can also tell you about anisomyopia. The crescents are reversed in cases of hypermetropia. And everybody knows this, that in strabismus, because the eye with the deviation is not looking at the ophthalmoscope light with the macula, the darker macula, the reflection, the reflex therefore is brighter and lighter in the deviated eye. Now, all this can happen very quickly because you just pick up the direct ophthalmoscope from a functional distance away, and you pick up all this information. Now, you can, on a good day, even look for accommodation. So you can see the picture on your left is the kid is looking at the camera, and the picture on the right, he's looking at a pencil which is close to him, and you can see that the accommodation has induced a myopia, and the crescents have come up. So not only can you check for accommodation, but you can even find out the effect of cycloplegia. That means when you do put cycloplegic drops, have the question is, have you attained cycloplegia? So one way to do that is to ask a kid to look close by. You shouldn't see any change in the crescents. And while you're doing Bruckner's, if you twist the head of the patient gently, then you can actually, see the movements also. So you can combine it for versions also, or the lack of them, limitations in cases of versions. I've also been using the Bruckner's. I've been suggesting it. If you switch it between two eyes, you can see them contracting and pick up RAPDs in a very interesting manner without getting close to the child. I picked this up from the Can Kids India, and of course we can pick up things like the retinoblastoma, retinal detachment, any vitreous veils. So that's important. Uh, and one should try using while you're doing the Bruckner's, if you just put on the Bagolini striated glasses, they make for very nice streaks. Sometimes better than these boxes that we are using, and the patient can immediately respond to you with an X or a suppression, and you can explain to the patient. This is from the Heinz website. They do say that as you can see, the pluses are more in the 3 to 4 meters distance testing. But I'm not, most of us will not walk away from a patient 3 to 4 meters to do that. Even from a functional distance, it works pretty well. The American Academy of Pediatrics has been recommending for quite some time this little poster, and it's a good idea to have it. Uh, but I've also been trying to push my pediatric colleagues in using their direct ophthalmoscope when the kids come to them, not necessarily for an ophthal problem. May come for immunization, for the well baby clinic, or for minor ailments. If all we can push with our pediatric colleagues is to pick up the direct ophthalmoscope and just scan the child's eyes, anything which is not symmetrical, if they refer to the ophthalmologist, I think we'll be able to intervene more timely in many instances. At the end, Bruckner's is, if you because of the ophthalmoscope is easy, it's very portable. It's very good for amblyogenic risk factors, particularly anisometropia and strabismus. You can combine it with the cover test, and if you do it monocularly, and if the patient is looking at the light, reaching out well to the light, you can even diagnose eccentric fixation. I've talked about accommodation, cycloplegia, versions, and RAPD. That's all in my talk today. Yeah.
Well, thank you, Dr. Mitava, for a very clear presentation about the Bruckner reflex. It is always said B for Bruckner and B for the best test to screen the infant, especially by the pediatrician as well as the ophthalmologist.
You may be even you may be even able to diagnose a microtropia through this, or you cannot.
Microtropia would be very difficult to diagnose.
Very difficult with this test.
It would be very difficult, yes.
Because there are many cases who have microtropia associated with amblyopia, because we do find no reason for amblyopia, and on careful 4D prism test we always can detect microtropia as the cause. I thought it may be easier through this to detect microtropia.
I can only say that if you need a certain level of responsiveness from a patient to diagnose. Even the 4-prism diopter base-out test is extremely difficult. That moment is so difficult to pick up, or the lack of that moment is so difficult to pick up. Much better is to go the Bagolini way, but you need to have a child who's understanding enough to be able to tell you that there's a little missing portion in the one of the streaks.
That
And
may be difficult. That may be difficult, yes.
Yes. But I still feel the Bagolini striated glasses test is a better way than the 4-prism diopter base-out test. And try it sometimes. Try it on your own eyes using an ophthalmoscope and the Bagolini. It works so well.
I think, sir, it works well because we know what is the responses. It's
Correct.
quite difficult for the patient for the first time to tell.
Yeah.
I mean, microtropia, definitely you have, this is definitely a good test. There's no doubt about it. But I think 4-prism is the clinching test that, this is definitely this. Because with Bagolini, sometimes, they may not understand what exactly we want them to respond to. So it becomes little subjective.
There are pros and cons. I'll agree with that. Absolutely.
So do we have next speaker with us, Dr. Amit Singhal?
Yeah, Amit is there.
So then I request him to start his presentation on prescription of spectacles in children. Dr. Amit.
Yes. Good morning, everyone. My topic. My slides are visible?
Yes, I can see them. Dr. Amit?
Yes, Amit. Yes, Amit.
Okay. My topic is prescription of the spectacles in the children. Now, how it is very different from the prescribing glasses in the adults. And prescribing glasses in the children starts from the very first, from the history and a proper examination, child behavior, family history, any history of congenital or hereditary disorders, and a thorough examination is required, which includes visual acuity, refraction, and strabismus evaluation. Now, while prescribing glasses, we have to difference between the risk and the benefit ratio. There is while we prescribe the glasses, child may not be accepted because of the emotional stigma. Glasses limits the physical activity and decreases their field, and cost is also another factor. But advantages are improved vision, comfort, it prevents amblyopia, and better binocular interaction. Now, deciding factor while giving glasses are magnitude of the refractive error, family history have to kept in mind, visual need, usually younger the child, their functional vision and the visual needs are less. Then we have to take care of the amblyopia, strabismus, accommodation, and other factors also into the mind. Cycloplegic refraction is must in the kids. It may be done with the homide, cyclopentolate, atropine, or even tropicamide. I personally prefer homide. Now we have to follow a chart or a standard while prescribing in our day-to-day practice. Many charts are available, American Academy of Ophthalmology, or recently we have from AIOC. And this chart now I've started following since last 1.5 years, and it's good. Other factors to be kept in mind are age, need, and other things. Now I'll be sharing few of the cases. Case 1, we have a 5-year-old kid with minus 2.5 diopter sphere in both eyes and no strabismus. So this is a straightforward case, and we have to prescribe full correction. Avoid prescribing overcorrection so that child doesn't get asthenopic symptoms. Now, same case if child is 2 years old, that is 2 years old with minus 2.5 diopter sphere and no strabismus. In that case, I'll observe and will not give the any glasses. Coming to case number 2, 2-year-old child with plus 3.5 diopter sphere on refraction and child is having strabismus, then in this case we'll give the full correction because child is having esotropia and we'll give the full correction. Similar case, if the same child with the same refraction without any strabismus, then in this case we'll like to wait and will not give any glasses, we'll just keep the child under observation. Coming to the case 4, 4-year-old child with no squint and plus 2.0 diopter sphere and minus 2.5 diopter cylinder at the 180 degree with both eyes. In this case, we have to prescribe the glasses and I prefer we'll give the cylindrical correction. Full cylindrical correction is advisable, but we can avoid giving full spherical correction in this case. Case 5. 3-year-old child with only 1 plus 1.5 diopter sphere, poor accommodation, and child is having history of Down syndrome. Usually in Down syndrome and child with poor accommodation, we prescribe even the minimum hyperopia, whatever they have. Coming to the next case, it is 6-year-old child with refraction of in right eye is minus 1.5 diopter sphere, left eye it is minus 6.5 diopter sphere, and child is having amblyopia also. Now, in this scenario, ideally we have to prescribe the full correction, but we have to judge between giving the full correction because it may lead to diplopia. So we'll put the glasses, lenses in the trial frame and we'll see for the child whether the child is comfortable or no. Personally, we can just do a slight under correction if child is not very much comfortable. Next case is 8-year-old child with both eyes pseudophakia and plus 4 diopter sphere. Now, in this case, child required even for distance and for near also, and will give the full correction with bifocals. Next case is 3-year-old child with both eyes refraction plus 12.0 diopter sphere, bilateral aphakia. Now, usually this 3-year-old child, they require more of near activities like playing with their toys, and so in these cases we overcorrect them just to make them good vision for the near. So we'll prescribe plus 2 in addition and we'll give them 14 diopter sphere in both the eyes. Coming to the next case, we have 3-year-old child with right eye refraction plus 2.5 diopter sphere, left eye is plus 5.0 diopter sphere. Now in this case we have to prescribe, but we can give plano because 2.5 falls within the normal category according to the chart, and left eye we can give plus 2.5 diopter sphere, and we have to look for any amblyopia and start the patching therapy if required. Now there are few cases where we have to lower our cutoff while giving the glasses, like as in case of ROP where we correct myopia early as it increases, or in case of the cerebral visual impairment cases where any hyperopia is prescribed as it magnifies and helps with the low vision. Now, other guidelines which we have to keep in mind while giving them the glasses is, or the frame must fit them correctly. It should be comfortable and durable. It should not hamper with the natural development of the nose, skin friendly, and safety wise it should be good. And most important, it should be correctly centered. The child face is different because they have a small face, low set ears, they have a flat nose and round cheek. Frame material, there is plenty of frame materials available, but any like cellulose acetate, propionate, optile plastic, metal frames are available. Whatever frame we choose, it should be smaller and stable on the child face, and it's most important, as I told, is center of the glasses. It should correctly match, the centration should be proper. Now bridge types are available, like keyhole or saddle types are preferred, but main important thing is it should not pinch on the nasal bone and it should not cause skin reactions. It should be a soft one is preferred. Coming to the temple part of the frame, usually they say it should snugly fit the ear, and in case of the smaller kid like less than 2 years of old, we prefer elastic band so that it fits on their head. Different kind of lens material are available, glass lenses or plastic lenses. Glass lenses are usually avoided because of the risk of the traumatic injury. plastic lenses are preferred, like CR39 polycarbonate. We have tinted glasses also, usually used in case of albinism, aniridia, coloboma. Then we can further classify them on monovision or multifocal. Now, common faults is while prescribing spectacles are lens decentration, tilting of the frame, tilting of the lenses, rotation of the lens within a frame, improper size, either the frame is too far or too near to the eye, and reading segment defects. Other kind of special eye wears are telescopic, crush glasses, clip-on glasses.
Exceeded your
To-
time. Could you be kind of wind
Okay,
it?
to conclude, prescribing eyeglasses in children requires art, and thorough examination is mandatory. Thank you.
That was very exhaustive. Dr. Amit, I have a query. I mean, have you
Yes, sir.
ever
Yes,
thought
sir.
of giving progressive lenses to kids, toddlers? I'm not talking about very tiny kids. Because my own experience is that whatever we do, particularly if there's a unilateral cataract we've operated, we are giving, even if you're giving bifocals to pseudophakic, monocular pseudophakics, we are giving them clear focus only at 2 points. I've been thinking that might not varifocal and or progressive work better.
Sir, progressive will work better, but usually child, in my experience, child does not tolerate progressive glass at the earliest. So usually what we do is in pseudophakic eye follow is, if the child require both distance and near glasses, we make them as separate glasses initially.
I do that too, right?
Initially, we give them a separate. So once they become used to for both distance and near activity, then we can go for the progressive.
Okay.
Your first two cases where you said that we wait to give glasses when the patient child is about 2.5 diopter minus.
Sir, in
I
first
would
case,
prefer one or two cases in the beginning you showed where you said you could wait. I certainly believe that you can wait, but I would prefer to give glasses so that the child can start getting accustomed to glasses. He may use for an hour, you may use it for 10 minutes or whatever it is. Otherwise, it will promote him for indoor and reading more than the outdoors.
yes,
Because
sir.
his distant vision may not be clear, and some part of this myopia may be sometimes due to hyper accommodation. Even though we say that the accommodation is
Yes,
weak,
sir. Above,
it could be hyper
yeah, above
accommodation
3.
also, right? So
Yes, sir.
I would prefer to give glasses maybe intermittently for a
Yeah,
period of
above 3
some
years, I
time.
told we'll give, sir. Above 3 years, I told we'll give.
Yeah.
Below 3 years, sir, we should keep in mind the process of emmetropization, because after giving glasses, we may hinder that, the normal emmetropization process. That is very, very important, sir.
Yes, sir.
I just wanted to make a quick comment about the use of progressive glasses in children. I think the major reason why we don't use them in small children is because the size of the glass is small, and the major advantage of progressive is that there is an intermediate segment which is around 16 millimeters, 1.6 centimeters. And when you make the glass too small, there is hardly any intermediate vision. So it works mainly like a bifocal. So that is one of the important reasons why we do not prefer to use it under 5 years of age, because it does not give the advantage of progressive. Only the cost is increasing. But otherwise, I think progressive is a good thing for children who are who have a bigger glass segment, because the major advantage of progressive is indeed the fact that there is an intermediate vision, and that is what we are all aiming for.
I think that's quite fine. Yeah, absolutely. Can we now invite Professor Khurana?
Amit, will you stop sharing your slides?
Yes, sir.
So my slides are visible?
Not yet.
Not yet.
Yes.
No, sir.
Yes.
Yes.
Now they are. The screen is visible now.
To me. Yes. Are they visible?
Yes.
Yes, sir. Yes, sir.
Yes, sir. Now it is.
Okay. Good morning, everyone. So I will be speaking on the diagnosis of amblyopia, which I don't think is a really difficult proposition. And we all know the amblyopia is
The
the
full screen.
Ajay.
Below and to the right, there's a little, button below and to the right, a little to the left of this.
This one,
Yeah, this one.
right
Good.
show.
Yes. Yeah, that's it.
So,
Perfect.
as we all know, amblyopia is the unilateral or rarely bilateral disease, decrease in best corrected visual acuity, and it is caused by foam vision deprivation and or abnormal binocular interaction for which there is no identifiable pathology of the eye or visual pathway. And for unilateral amblyopia, a difference in best corrected visual acuity of two Snellen lines or one log unit between the two eyes is taken as the definition. And for bilateral amblyopia, the visual acuity should be less than 20/40 in each eye. In infants and small children, fixation preference and preferential looking test can be taken into consideration. So those simple to diagnose, but sometimes it becomes difficult, especially when we are dealing with the small children. So we can have a 7-step approach, which will be systematically approach to diagnose the amblyopia. And the first step is always to confirm the presence of decreased vision. Is it really vision is decreased, especially in the small children? Then to rule out other kinds of decreased vision. Is it really amblyopia or some other disease? And then to ascertain the type of amblyopia. And the fourth step should be to note the common clinical characteristics associated with that amblyopia. And fifth step is to find out the amblyogenic factors associated so that we can manage accordingly. And similarly, to then grade the severity of amblyopia, it will also decide our management strategy. And of course, to note the prognostic factors for management and also telling to the guardians. So the first step is to know the visual acuity for children above 5 years or school going children. There is no difficulty, can use Snellen letters or any other alternative vision charts. But be careful that sometimes children are tricky, they can see with the other eye. That is the only you should be careful. Then for children between 3 to 5 years, we have various charts. You should be comfortable, whatever, but you must have at least in your clinic any one of these, and there should be one especially optometrist trained for it. The patience is required in checking the vision for these children. Similarly, for 1 to 3 year children, you can have either this dot visual acuity test or miniature toy test or marble game test. Again, here I will say that you should have a dedicated optometrist who is trained for such type of work. That is the only thing. Who should have patience, be friendly with the parents as mother as well as the child. And even lesser, you could use the preferential looking test or optokinetic nystagmus test, and must make an accurate assessment of vision in small children. Then for infants, this simple CSM method is quite useful. So that means that this is central steady and maintained fixation implies a good vision about 6/6. If there is alternate fixation, then good visual acuity in both eyes. And central but strong preference for the other eye, vision may vary between 6/9 to 6/18. And if it is central but not maintained, then vision less than 6/18 to 6/60. Unsteady fixation, even between 6/60 and 3/60. And if there is no fixation, vision is less than 3/60. So if we cover the one eye of the child, which is vision is less, definitely the child will resist. That is also a very good indication. So after having a level of visual acuity, the next step is to rule out any other cause of decreased vision. And though obvious reasons are there, but sometimes the subtle causes may be missed, and we have seen many cases being treated for amblyopia while it was not a case of amblyopia. So anterior segment causes, especially fine nebulae, etc. Then posterior segment causes, which usually often missed, are the macular hypoplasia and optic nerve hypoplasia. then cortical visual impairment and delayed visual maturation. These are the causes we must ascertain before starting the amblyopia therapy. So after this thorough examination, when we have ruled out the other causes, naturally we will be able to assign the type of amblyopia also. There is a refractive. In the refractive, it can be isometropic or ametropic amblyopia or an isometropic, then strabismic, refractive and strabismic combined, and then image degradation or stimulus deprivation amblyopia. So almost 90% of the cases are either due to anisometropia, strabismus, or a combined. So we are dealing mainly with this. So after this, the fourth step is to note clinical characteristics of the amblyopia. So it may be useful for prognosis also, for the progress of the treatment also, and of course for your academic activity and research activities. In addition to the decreased visual acuity, we should know the pattern of fixation, the crowding phenomena, effect of neutral density filter, decreased contrast sensitivity and stereo acuity. All these are important parameters and indicators for the management and prognosis of the amblyopia. So in this fourth step, the first is fixation pattern. Always note, we can do it either with visioscope or ophthalmoscope. The fixation is steady or unsteady, is it central or eccentric? If eccentric, is it nasal, temporal, superior or inferior, or there is no fixation at all? Next is the crowding phenomenon. We all know that amblyopia patients exhibit better visual acuity for single optotypes than for the letters in a row. And this poor visual acuity for letters in a row results due to the so-called crowding phenomena. Crowding phenomena occurs due to counter interaction between the neighboring test targets because of lateral invasion in amblyopia. Then neutral density filter test. A neutral density filter reduces overall luminance without inducing a color change. So a neutral filter profoundly reduces vision in eyes with organic amblyopia and will have no effect in eyes with functional amblyopia. Or even sometimes you can notice occasionally some slight improvement in the vision with functional amblyopia patients. Hence, it can be used to differentiate functional from the organic amblyopia. Then of course the contrast sensitivity is especially more for the higher frequencies, and it has been seen that contrast sensitivity improves during amblyopia therapy, and so it can be useful to monitor the progress. The contrast threshold becomes normal in strabismic amblyopia when luminance level is reduced, while the deficit persists in the anisometropic amblyopia. Then stereo acuity, presence of amblyopia can be detected by defective performance on various stereograms. The simplest test is two pencil test. It is clinically useful test and can be applied even when visual acuity recording is unreliable or not possible. So it can also use if you are having the database flight test, random dot stereogram test. In addition to these other characteristics like response in light to dark adaptation, critical frequency, ERG and EOG, etc., if you have for academic activities and for research, can also be useful. So after that, we have to note the various amblyogenic factors which are present, and depending upon these, whether there is light deprivation or a deprivation of foam vision, abnormal binocular interaction, and depending upon the permutation combination in different types of the amblyopia, we can see the severity of the amblyopia. And this severity we can grade depending upon the acuity of the vision. We call it a mild amblyopia if the vision is between 6.9 to 6.12, moderate amblyopia worse than 6.12 to 6.36, and severe amblyopia when it is worse than 6.30. So all these grading, etc., is important to start how the treatment we should start. And of course, we need to note the positive and negative factors for prognosis, which we should keep in mind while starting the treatment also and explaining to the parents also. So needless to say that the functional amblyopia will improve and organic will not. The amblyopia with central fixation will have a better prognosis, early recovery. Similarly, random dot stereopsis is present, chances are early recovery are much more. Similarly, shorter the duration of amblyopia, earlier the recovery, and younger the patient and motivated the patient, the better the results. So to conclude, I will like to say that the early identification and intervention during the critical age group ensures full recovery and restoration of the binocular vision. And some people have even recommended that for early diagnosis of amblyopia, The risk factor meek approach can be used with especially very small children, that we always monitor the qualitative fixation, then evaluate red reflex Bruckner test, which Dr. Amitava has very rightly highlighted in detail, then alignment evaluation by doing simple cover tests in the small children or Hirschberg test, and then compare the effective error if it's all over there with the cyclopedia. So aim is to do that, must be in mind that in small children we need to evaluate the vision. So my take home message will be that amblyopia diagnosis and management, especially in small children, is a challenging job, but it's very rewarding. We have treated many patients. Now they are parents and really grateful to us for giving vision to them in early childhood. So thank you very much everyone for patient hearing.
Good.
Thank you, sir.
I have an observation.
Yes, sir.
Do you really attach some significance to eccentric fixation or central fixation these days? Because I believe that we really do not bother much about it unless it is totally unsteady.
Of course,
Uh,
we don't take this into consideration,
because theoretically it's fine,
but we
but
do.
then in practice we don't really bother about it. What's the view of others? Maybe
I think
Amitava is able to.
for the managing it separately as we were doing the inverse occlusion, that we are not doing.
Yeah,
But
that's what I say. The time when we were doing Kappers and Bangerter's treatment for eccentric
you are absolutely
fixation
right. We
is
don't,
now gone. Is now gone.
that we don't do anything extra for the management. But we
Yes,
keep in mind
that's right.
that the eccentric fixation will take more time for recovery, and we can tell to the parents they should have patience and cooperate during treatment. That is the only importance.
Right.
And of course, during prognosis, we can keep on.
And about meridional amblyopia, do you uh, test meridional vision also? Because I had designed some charts at the AMU. I don't know, Dr. Amitava, if you are still using them or have abandoned them. We were recording meridional visual acuity in different axes and then were trying to compare that how much it is affecting the overall amblyopia. That was a good indicator at that time. I don't know now because I'm not doing this type of work at this time.
A good idea, sir. It should be propagated, I think.
Quite. I do want to say that very often when there is dense amblyopia with eccentric fixation and these things, it is quite futile, in my opinion, to have the patient or the child go through inverse occlusions. It doesn't make much of a difference. I'm sure everybody has tried it enthusiastically in everybody's earlier days. It is much better to give a frank and honest explanation and strongly recommend glasses, not, of course, for visual acuity of the other eye, but more importantly, for its protective role. You see, you need to now save that one good eye for the rest of the patient's life. And if you can do that, then I think the child will, people can do a pretty good thing with one good eye. So I do not necessarily, get after the amblyopia anymore so aggressively as perhaps in my earlier years. I'm now more conservative, more relaxed, and I make an effort, but I do also encourage parents to understand that one good eye is doing a great job. Very well covered, Professor Khurana. I really enjoyed your talk.
Thank you.
Yeah. Can we now have the next person, I think? Who's that?
Neelam Pawar.
Okay, Dr. Neelam, please.
Yeah. Are my slides visible?
Yes, it is. If you can go on to the...
Yeah.
Correct.
Yeah. Good morning, everybody. I will be talking on retinal nerve fiber layer thickness and optic nerve head parameters, implication of OCT in pediatric ophthalmology. The literature, there are various studies on evaluation of retinal nerve fiber layer in children using OCT.
The voice doesn't seem to be very clear. Is there... the voice doesn't seem to be very clear. The slides are fine.
Okay, fine.
Some speaker might be on or something.
Yeah, just let me check. Right now it is okay, sir?
Yeah, that's it. That's it.
So in literature, there are various studies on evaluation of retinal nerve fiber layer thickness in children using OCT, and measurements provided by each of the commercially available devices differ and they cannot be used interchangeably. So these are various commercially available OCT devices which are used in adult as well as in pediatric cases, and handheld spectral OCT like Bioptician and HH OCT devices have proved to be wonderful devices in children less than 3 years of age. So one should be well familiar with the proposed lexicon given by INCOCT panel, and during process of development there is centrifugal displacement of the cone receptors while there is centripetal displacement of inner retinal layers. So in children, both the traditional tabletop and handheld OCT have been in well agreement and they have good reproducibility of measurements of RNFL thickness and optic nerve head parameters. So like adult, children can also, pediatric OCT can also have motion and blink artifacts and segmentation error. So why pediatric normative data is required? Because there are no internal standards to compare the result, and adult reference OCT data cannot be used as such. So there are various studies on normative RNFL thickness in different ethnic population in pediatric population by Stratus OCT, and we studied and found global RNFL thickness to be 106.11 with a standard deviation of 9.5 in Indian children. And with spectral OCT, we found RNFL thickness to be slightly less, that is 94.46 with a standard deviation of 8.7 in another study. So in pediatric cases, OCT can be used for the quantification of optic nerve head parameters as well as qualitative assessment of these parameters for various abnormalities. Various studies have also shown that RNFL thickness can be similar in boys and girls, while few studies have shown it to be thicker in girls. And with increase in axil length, usually there is thinner retinal nerve fiber layer. There is something known as interocular asymmetry in children, that is, some amount of asymmetry is always seen, and any asymmetry of more than 9 micron in retinal nerve fiber layer should always be considered as suspicious and could be pathologic. So in cases of amblyopia, large meta-analysis has shown that RNFL thickness is higher in amblyopic eye compared to fellow eye, while OCT angiography has shown less vascular density at optic nerve head in children with amblyopia. In cases of pediatric glaucoma, OCT is not only helpful in diagnosis of glaucoma, but also in serial monitoring of glaucoma. So in glaucoma, in primary and congenital and juvenile open angle glaucoma, after surgery, there can be reversal of optic nerve head, but there is always true damage to the retinal nerve fiber layer. So this particular girl with GOAG was initially diagnosed in our hospital, but later on in follow-up, she went to different hospital. Analysis was done with different machines. And when she came back to us, there was a gross thinning of retinal nerve fiber layer. She was uncooperative on HFA, but the gross thinning of RNFL and fundus finding made us to plan, trap for her. This case showed a reversible. Initially, patient had 0.8 reversible of 0.8 cup, and post-trap, there was reversal with 0.5 CD ratio in both eyes. One should also know about the lazy wave or shift sign in papilledema versus lumpy bumpy contour of optic nerve head drusen. And optic nerve head drusen are usually seen as hyperreflective shadow in B-scan, while in OCT they are seen as horizontal hyperreflective lines with a dark inner space. If you see OCT of this child, it looks like to be papilledema, but actually it is a case of pseudoguanine, congenital epididymis, and in cases of IH, it's very helpful to diagnose and monitor pediatric pseudotumor cerebri, and OCT also acts as a visual prognostic tool indicator. So this particular child with IH came to us with squinting, had characteristic MRI of IH, and RNFL thickness was increased, and after treatment with acetazolamide, there was a decrease in RNFL. So OCT can be used as a standard in monitoring papilledema in IH cases. Lower RNFL thickness are also associated with lower visual function in eyes with optic nerve hypoplasia and optic disc. And see the RNFL analysis that is thinning can be seen in vigabatric toxicity. In children having history of ROP, there can be thinner RNFL compared to normal children. And in cases of optic neuritis, initially there is thickening of the peripapillary retinal fiber layer or OCT during the acute phase, and later on there can be thinning. As seen in this case of Leber hereditary optic neuropathy, initially there is thickening and of one eye, while left eye is showing the thinning that is going for optic atrophy. In cases of optic nerve glioma, OCT can be valid substitute when patients are unable to perform perimetry. In cranial stenostosis, OCT can provide adjunctive evidence for identifying neuropathy. On optic nerve parameters, ability of CNS development and pathology with larger vertical CDR ratio being associated with lower belly scales of infant developmental scores. So we'd like to share a few rare cases published by us with OCT. This is unilateral optic nerve aplasia documented with OCT. This child in right eye, no optic nerve had was seen, and OCT showed gross thinning of retinal layers and gross thinning of. Another case is of OCT documented optic atrophy, non-syndromic cranial synostosis, and lacunar skull. This particular child had vision of 6/6 with no visual complaint, and OCT revealed gross thinning of RNFL, which led to the decision of cranial expansion surgery. And till now, the child is in follow-up with us, maintaining a vision of 6/6. So another case with OCT documented optic nerve neuropathy in pycnodysostiosis and child with 6/6 vision. There is not much narrowing of the optic nerve. Child has not undergone any surgery. So future of OCT is that OCT has proven to be a good diagnostic tool in field of pediatric ophthalmology. Maybe future ethnic and pediatric age parameters will be incorporated, and more implication in diagnosis and treatment of pediatric optic neuropathy can be expected in future. Thank you very much.
Dr. Neelam, you are fortunate to be, I think, having easy access to an OCT, where you've done some great work in that. But
we are routinely doing so many OCTs, pediatric ophthalmology.
Quite. But most of us who are working in strabismus, at least, are not really, going for an OCT in these children. It doesn't seem to impact their clinical management. And sometimes we are pushing toward these investigations more because we want to publish something than necessarily providing utility benefits, or improving the quality of life of our patients. But there's no doubt that OCT does, yield a lot of information, and it makes for interesting, information for sure.
Yes.
Can I ask a question?
Of course.
Yeah. So what are the normal parameters? I mean, the machines usually have parameters for people above 18 years of age. I mean, how do you say thinning and thickening in children based on what the machine software has?
Yeah. That's why we are with all the published articles only we can say, because machine will never tells almost red and green color signals. But in progressive serial analysis, we can make out.
So our next speaker is Dr. Raman Mehta, and he will tell us about the visual assessment of children, the most important task to be done for pediatric ophthalmology.
Good morning, everybody. Am I audible clearly?
Yes, you are.
Go ahead.
Okay.
Go ahead.
So good morning. Very vast topic, and few portions have been covered by Dr. Amitava and Dr. Khurana. So I will try to skip those slides in between. So we need to acknowledge these facts that almost 3/4 of a child's early learning comes through vision. So that's why we have so much importance on visual acuity assessment in children. And over 1/3 of the adult cortex responds to visual stimuli, and basically visual information is used and processed by different parts of the brain. So that makes it important to know about the visual acuity in children. If you look at the burden of visual impairment in children in USA, it's estimated to be around 5 to 10%, while in an Indian study, 5.1% of children in school had a visual acuity of less than 6/12. We still don't have much accurate data about the visual acuity burden in the preschool children. So why do we need early detection is because it has an impact on the psychomotor development, cognitive achievements, and social and emotional development. And if there's a delay in identification and management, then it can lead to behavioral problems and enlarge the experienced intellectual disability. So when we are looking at visual acuity assessment, we are looking for refractive errors, we are looking for amblyopia. We are also looking for the normal visual development parameters, and all those children who had low vision, they can be instituted for low vision and rehabilitation. So the study in the Visions preschooler studies, it was a multi-center, multi-phase study done in 3 phases. And ultimately the result of the study was that even unaided vision was just as defective at detecting significant visual impairment than cycloplegic refraction and autorefractometers. So what would be the correct age? There is little agreement across states as to what ages to be screened and areas of vision to be evaluated. But the guidelines of the American Academy of Pediatric Ophthalmology and Strabismus and American Academy of Ophthalmology, it says that basically all routine visits, when the child goes to a health visit, it should be screened. So who are a priority for screening? The children with developmental delays, already who have a known family history of retinal disease, a history of prematurity, infection of mothers during pregnancy, family history of squint amblyopia, or whether if the child had a difficult or assisted labor associated with fetal distress. So these are the recommended eye examination frequency for pediatric patients who have asymptomatic or who had risk factors or who had some problem during the delivery time. So if we look at the definition of the visual acuity, it is in pre-verbal infants, it is defined as motor or sensory response to a threshold stimulus of known size at known distance. But in pre-literate but verbal children, it can be the smallest target of known size at known distance, which is correctly verbally identified by the child. So when we are looking at visual acuity assessment, there are different type of assessment which we can do. One is the detection acuity, recognition acuity, and resolution acuity. Why we are telling about this is because many of the tests employ different kinds of acuities, or some of them can actually test all the 3 together. So if you look at the review of literature, it is always said that the grading acuities adult-like by 4-6 years and letter recognition acuities by 6 years. Why it is important is because some children of amblyopia may have a little better vision with resolution acuity, and sometimes we may miss mild to moderate amplias if you are using only a resolution acuity test. So this is what I was trying to tell you. If you look at the normal visual development, these are the milestones of the visual development which we should be keeping into mind, because these are the milestones which are used in the test to find out if the vision is normal or not. Other function which we can correlate is basically the small saccades, large saccades, and the uniocular fixation. So when we are doing a visual acuity assessment, Dr. Khurana has already told that it is very important aspect to gain maximum cooperation, and the conditions in the examination room, the presence of an attendant, use of toys, listening to the child, what the child is trying to react, is all the things which they have to be, and a very communicative approach has to be there while gaining the visual doing that. So we'll go step by step now from in different age groups. So from birth to 3 months of age, Dr. Amitava has really covered well about the red reflex test, so I will not go into the detail. Then the other indirect methods by which we can assess visual assessment, visual acuity is by pupillary light response, eye popping, blink to a bright reflex, and fixation test. So pupillary light response is basically, it checks the afferent and the efferent pathway of the visual, and it is present by 29 to 31 weeks of gestational age. So sometimes if you have difficulty in visualizing a pupillary reflex in a very small child, you can use a 20D or a magnifying lens with an indirect ophthalmoscope, and you can have a look at the pupillary response. The blink to a bright reflight is also there by 30 weeks of gestational age, and the blink to a threatening gesture is by 5 months. When testing, you should be taking care that you're not brushing the air against the child's cornea, because that can elicit a blink reflex. The other thing is, very important thing is to check for an eye popping. By shutting down the light, you will find the child will be, if the child has vision, then the child's eye will close the eye, and immediately on opening the eye, the child is going to squeeze because of the illumination. So this is basically called as positive eye popping. So in next comes to this thing, next group of 3 to 6 months of age, and these are the tests for recognition acuity. But the commonly tests which we use are basically the box candy test, and basically when the child is identifying such a candy, we are assuming that the child is at least having 6/60 vision. So children in this age group are best when they perform alert, so it's better to call them in the morning or maybe after a feed. And other historical observational techniques which we can use is by if the child responds to a smile, or if you are finding a strabismus, nystagmus, or inattention to objects, then basically we are assuming that the child is having less vision. Also, constant strabismus in one eye indicates amblyopia, and alternating strabismus basically indicates the vision is good in or equal in both eyes. The fixation targets with the traditional technique which we use is the fix and follow, and it can be demonstrated by 6 weeks of age and by using a bright colored toy. And if the child, and we should be using the smallest possible target, and if the child is able to fix and follow, then we are assuming that at least good vision is there. This binocular fixation preference, Dr. Khurana has already talked about it, but I'll just look at a video and I can tell you that in the first video, if you see, the child is objecting to being covered the normal eye, but in the second video, when we are covering the strabismus eye, he's not giving any objection to that. So that means that he has poor vision in the strabismic eye, but not in the other eye. So the other thing is monoocular fixation testing, which Dr. Khurana has also told before only, but basically what we are trying to look at is as the quality of fixation, and whether the quality is good, fair, or poor, and whether it is central or eccentric, and whether it is maintained or sporadic. So this is the central steady method of rating fixation. Again, Dr. Khurana has already told, but by these methods, we can get a gross idea of the visual acuity in such cases. Now let's look at the pre-verbal children. So the test for resolution acuity in pre-verbal children are the optokinetic nystagmus, the preferential looking test, and the visual avert potentials. So optokinetic drum is basically an objective method, and it rotates at a revolution of around 8 to 10 RPM. It's a lightweight drum and with white and black stripes, and it is kept around 24 to 30 inches away from the child.
Dr. Raman, you have exceeded the time. Could you kind of wind up?
Okay, so basically this is based on the principles of saccades and pursuits, and it has been found that the correlation between optokinetic acuity and letter acuity is pretty good. The next are the preferential looking tests of Leah gratings and vanishing optotypes, and it has an excellent accuracy, and it basically checks both resolution detection and recognition acuity. In this preschool children, we are using the visual acuity chart guidelines, and out of this, Leah and Patty are the two charts which are widely accepted. So it's Leah pediatric acuity chart is there by Dr. Leah, and it has the phenomena. It takes into account the crowding phenomena, and their optotypes blur equally. So it works very well with non-verbal children. Now the last which I want to talk to you about is the children patients in nystagmus, where occlusion of one eye will lead to enhance the nystagmus. So basically, we use a +5 diopter lens or a Spielman occluder to decrease the intensity of the nystagmus. And about the children visual assessment in multiple disabilities, these are the preferential looking tests and VPs are the ones which we can be used. So VP is the one which has the earliest visual acuity compared to an adult. So it's a very accurate method of assessing the vision. Sweep VP is a new method of assessing vision in such cases. So the present literature actually supports the use of preferential looking and VP visual acuity techniques in multiply cataract children. So to summarize, vision and vision stimulus is necessary for the psychomotor and emotional development, and visual acuity assessment in infancy early child should be a compulsory part of pediatric examination, and early assessment with right techniques and right way can help in detecting visual disorders and prevent visual impairment. Thank you for your time and giving me some opportunity to present.
Thank you, Dr. Mehta, for a very comprehensive coverage, and the most important topic, as we have already highlighted in children, is the proper assessment of the vision. So our next speaker is Dr. Geeta Srinivasan. She will give us an update on amblyopia. Dr. Geeta, please.
Good morning, everybody. Sir, is my slide seen, sir?
Yes, yes.
Yes, yes.
Okay, I'll just carry on. Thank you. Thank you. Amblyopia, as we all know, is one of the most important causes of uniocular visual deprivation in childhood. Over the next few minutes, let's discuss some standard treatment protocols, what to do when standard treatment protocols are not beneficial, and our personal experience with some of the newer management modalities. As we all know that the prevalence of amblyopia is about 2 to 3%, and in certain select groups as high as about 5 to 6%, causing a severe economic and social adverse impact. It's defined as a monocular or binocular decrease in the best corrected visual acuity, either because of an abnormal binocular interaction or deprivation in periods of visual immaturity. While visual deprivation has the worst impact on vision, an anisometropic amblyopia has the best prognosis. The basic problem is with the striate cortex, which gets affected because of a problem either in the magnocellular and or parvocellular pathways. With that basic introduction, let's come on to the basic management of amblyopia, the mandate for today. The ultimate goal of amblyopia management is equal visual acuity. To start with, refractive correction has to be done. According to the PDIG study groups, a full correction is what has been validated as the correct approach. However, this is feasible only if there is no strabismus. Because once we do a full correction, it may lead to a delay in emmetropization, and that is not very favorable. Also, assess the success after correcting the refractive correction after about 18 weeks. And we find that about 94% of anisometropic amblyopia would tend to improve versus 79% in the strabismic group. Whereas a mixed amblyopia, we find that about 1/4 of them do not improve despite the refractive correction. So after about 15 weeks of so-called refractive adaptation, the time has come for the next stage of therapy, which is occlusion therapy. This is, of course, the gold standard, as we all know. And the PDIG studies have given us a clear mandate that 2 hours of occlusion would help in moderate amblyopia, and 6 hours of occlusion is quite suitable for treatment of severe amblyopia. Now, near activities I tend to do in my hospital practice. However, the jury is out on this, and some of them feel that near activities do not actually help in improving vision. Another thing, whether different types of amblyopia need different amounts of occlusion, there is no clarity on that issue as of now. One important point that I'd like to stress on, even in older children, 13 to 17 years of age, it has been found that they do show improvement with occlusion therapy if they have not been treated in the past. So please do try therapy even in this older age group. Recurrence of amblyopia, it is a known bugbear, and I haven't seen too much of it in my hospital practice, to be very frank, whereas literature is reporting as high as 13 to 24% of recurrence. Now, whether weaning is the issue over there is to be judged, because I definitely do a weaning in all of my patients, whereas some people feel weaning helps in preventing a recurrence, and some feel it has absolutely it makes no difference at all. Because there's one RCT which has done a full-time occlusion therapy in cases of a severe amblyopia, and they have found that even on abrupt cessation of occlusion, there has been no difference in the vision. So anyway, the prudent thing to do would be to follow up closely. Residual amblyopia, we do see. We can try plano lenses with atropine. I tend to prefer undercorrections with or plano lenses rather than atropine. I'm a little cautious with using atropine in my practice, though it is said to do very well. Now, the success of amblyopia treatment with occlusion is said to be roughly about 80% in most of the literature, and some have even suggested that it is only as low as 30% when it is treated by occlusion. This has probably prompted the need to look for other modalities of treatment. Now, problem with occlusion is lack of binocular interaction. Compliance, of course, is a huge bugbear, besides the emotional and the psychological factors. So coming to vision therapy as an alternative treatment. Now, vision therapy is said to cater to saccadic eye movements, smooth eye movements, fixation, hand-eye coordination, all of which are probably not handled as much with occlusion therapy. Our experience with the computerized program, which has come about in recent times, I'd like to share. Now, we monitored 15 children quite closely with computerized vision therapy. Majority of our patients were anisometropic amblyopes, hypermetropes, and our age group was up to 14 years of age, majority being less than 12. Now, what we found was that with this computerized vision therapy, the children showed a mean improvement in vision from 0.46 to 0.24 logMAR over 6 months, which was gratifying. And we found that out of the 15 children, 9 of them showed an improvement of more than 1 line in Snellen acuity measures, which was about 60%. The lesser the degree of anisometropia, the better the improvement. Mean contrast and stereopsis was also better in these patients by the end of 6 months. However, when we look at case-controlled studies, published literature, there is insufficient evidence of success with this modality alone. So what we generally do in our practice is give the occlusion therapy, and then if I find there's a residual amblyopia, that's when I talk about this as a modality of treatment. Perceptual learning, just to touch upon it for shortage of time, it has been generating a lot of interest in the recent past. Its basic premise is that a performance of a simple visual task in a repetitive manner will show an improvement in vision even in adults. The criticism for this is that only the task which is practiced will show an improvement, and not all tasks in daily normal living. Follow-up, of course, is needed, much needed. So we did try a few patients with this therapy, which is quite recent and which we are just about starting off with at our center, where we use these flankers with the target debors. I'll not go into detail for this. This is a computerized program. And these, we have enrolled about 7 patients so far, and 2 of them have just about started the therapy. Now, what we find is that after 40 sessions, now we find quite gratifying improvement as of now. This 13-year-old child with a hypermetropia of 2.25 diopters in her amblyopic eye improved from 20/60 to 20/25 with 40 sessions. All this is documented. And this is an adult 20/200 who improved to 20/125 after 40 sessions. So we are seeing some kind of improvement, definitely. enough for us to show more interest, enough for us to motivate more patients. As of now, cost is definitely a limiting factor, unfortunately, for us to give it on a larger scale. Dichoptic therapy, haven't done it very much, but then as part of the computerized vision therapy, which is the software, does do some kind of dichoptic therapy also. Not much experience in this. Non-compliance is a huge bugbear, even with dichoptic therapy. I see this even with vision therapy. The children get quite tired of the exercises, the repetitive nature of the fun that they are having initially. Binocular iPad therapy, etc., have also come up in a big way, where it's nothing but games which are improving the hand-eye coordination and other aspects of vision. Other therapies, refractive surgery, study ongoing, PRK, according to the ATS 19, they're still studying it. And liquid crystal display glasses, again, this cost was a limiting factor when we kind of decided to try it out. Pharmacotherapy, we know that atropine is beneficial according to validated and can be used as a first line if occlusion is not being done for whatever reasons. Levodopa carbidopa, which increases the dopamine, the PEBIG study found that it has absolutely no effect with 2 hours of occlusion also, whereas another study which used 3 times the doses of levodopa carbidopa has found a significant improvement in vision. Levodopa and citicoline are something we probably need to see how things would go on further follow-up. There are others, SSRI as well as donepezil, which are coming up, very early times to talk about them now. So in conclusion, early detection of amblyopia, as we all know, is extremely rewarding and is the key to prevention of vision loss for the future. And persistence, both of the doctor as well as of the patient, definitely pays rich rewards. Thank you.
Good.
Thank you, sir.
Seen you after a long time.
Yeah, we'll meet after COVID, sir. Thank you.
That was very exhaustive, Dr. Geeta, and a lot of novel and newer approaches that you have been experimenting and working on.
Thank you, sir.
Can I ask a question?
Yeah, please.
Who's
it, please? Sorry.
I appreciated your feedback on the vision therapy or binocular techniques.
Yes,
do you think using it in the residual setting is very creative? And I'm curious whether or not you think that those are the children that are plateauing because of lack of compliance, and this is a new, fresh approach that they'll buy into, or are you seeing it even improve children that are still under good compliance and are plateauing?
In my practice, I'm using it in both, sir. Initially, when we did the study in these 15 children, we did not do it with occlusion at all because we wanted to assess how this therapy was working individually. But now that I've seen that, yeah, it probably shows some result. I always tell the patients, you can expect that 60% of improvement is what we have seen. So I guide them on that and then tell them not to expect miracles because frankly speaking, I never use it as a first line. So I'm using it in residual either ways.
Thank you.
Thanks.
So our next speaker is Dr. Rajvinder Bhattal. She speaks on pediatric imaging, another important topic.
My voice is audible, sir?
Yes, sir.
Yes, it is.
My screen, sir?
No, we can't see your screen.
Yet not.
But I
Now,
can
sir?
see.
Yes.
Now screen is visible, sir?
Yes, please go ahead.
It is.
It's not moving. So it's moving?
It's moving also.
Okay, thank you, sir. My topic is pediatric imaging. So earlier hand-drawn sketches with qualitative descriptions were used to document findings. Development in ophthalmic imaging technology have revolutionized the delivery of ophthalmic care. But imaging in children is highly variable. The two most frequent barriers to perform imaging in children are cooperation and lack of sufficient data supporting the ophthalmic imaging in clinical practice. So anterior segment photography, so we have to sometimes struggle with the child and their parents to get the pictures for the documentation and for the proper workup. So the slit lamp biomicroscopy is used for anterior segment examination. So now these days the handheld slit lamp, they are also available to get information regarding the anterior segment. In the posterior chamber, that is for the indirect ophthalmoscopy, is usually used for the fundus examination. Especially it requires special training to examine the premature babies. So, but now the smartphone ophthalmic imaging is taken over. So recently the smartphone have been used extensively for capturing anterior segment as well as the fundus imaging. Why smartphones? Everyone has one. Excellent cameras, easy to use, high quality ophthalmic imaging, progression of disease and educational purposes, it can be done. Conventional photo on slit lamp, then modern smartphone camera everyone has, and we can good pictures with the smartphone. So I was using MRED cam, so I have a personal experience with using MRED cam. So we use condensing lens with the smartphone attached to the cost-effective, handy, mobile, non-contact device to capture the wide field and good bedside images. So only 3 instruments were used, that is smartphone and an MRED cam device and 20 diopter lens. So the images were, that is 500 to 600 kb's, resolution was good. So the technique is, first of all, we can store the patient's data, name, age, MR number and diagnosis, and follow-up pictures can be taken in that sequence only. For fundus imaging, pupillary dilatation is achieved. User holds the 20 diopter lens close to eye, and once fundus glow is visualized through the dilated pupil, slowly brings it back until a clear image is visualized. So we can take stills directly or freeze the video at desired image and take the snapshot. The images are easy to transfer electronically and to print. So I will be showing now some of the high quality images captured using the device will be shown now. So it was a case of Pusch's retinopathy. A 3-year-old child came with history of chest compression with the track side. He was referred for subconjunctival hemorrhages. But on seeing the fundus examination, there were hemorrhages present and increased foveal reflex. There was another case with the lapemia retinalis in a chubby baby. So the fundus examination, because of lack of RetCam in our institute, I was using MRED cam for taking all the fundus pictures in these babies. So another case which was referred for fundus examination in a case of leukemia. So current the gold standard method requires the indirect ophthalmoscope and plus 20 diopter lens. Nowadays, the digital fundus photography is used in ROP screening to facilitate the consultation in difficult cases, and it also helps in taking the documentations for the medical legal affairs. However, it is not easy to take a fundus photograph of a newborn without a professional equipment such as RetCam. But the RetCam, it is costly, unaffordable, and it is not easily portable every time you want to take the picture for documentation. But MRED cam or the smartphone based devices, they are inexpensive and portable and easy to use. So these are the few pictures taken in a cases of retinopathy of prematurity, pre-laser and post-laser. So it helps in taking the pictures for the documentation, for monitoring the disease, and to see for the progression or the regression of the disease. And we can monitor the progression of the retinopathy of prematurity and its effect of laser during the treatment. So this is another picture taken during when the child have the AP-ROP. So satisfactory images for staging and determining the need of treatment in ROP resource poor setting. So it plays an important role in teleophthalmology also. So for the documentation purpose, and we can directly communicate with the other ophthalmologists and in the teleophthalmologies, and it plays a role in medical legal affairs to document the cases. So another pictures taken in a cases of retinal detachment presented in a case of a child. So it is a young child with the lattice with holes and retinal detachment. And it is another case, shaken baby syndrome. He was a 9-month-old baby with the history of seizure he was referred to see the optic disc edema. But on examination, he was found to have the extensive pre-retinal hemorrhages, and later on found to be a case of shaken baby syndrome. And these are the pictures taken on the follow-up visits of the patient. So this is another case of documentation of disc failure in a patient of Rasmussen syndrome, that is chronic focal encephalitis. The partial optic atrophy is there. So another case, that is 13-year-old male child unconscious admitted in PICU with a history of roadside accident. MRI showed the subarachnoid hemorrhage and fundus findings, the pre-retinal hemorrhages were there. And another case which was referred, which was in the OPD with the history of photophobia. He was put on nitrofurantoin for the history of urinary tract infection, and he was found to have bilateral disc edema. So we documented it with the MRET cam because the non-availability of the fundus camera. After that, we can follow them on the fundus camera also. Another child that is who presented with the that is who was referred for the corneal opacity, and he was having iris coloboma, both the eyes with the corneal opacity right eye, and he was a case of CAD syndrome, and we can see the tongue tie also in this case. So it was a case of multiple sclerosis, that is with the choroidal coloboma, the pathological myopia. And it was an interesting case of that is coloboma with the iridolenticular coloboma, and we can see the iris processes. In this case, there was a lot of nystagmus. We first fixed the eye with the help of the Goldman 3 mirror, and then we were able to see, take some pictures of the iris processes, and also the butterfly coloboma was captured with the help of after fixing the eye, because there was a lot of nystagmus. And this picture was taken on the slit lamp only with the help of Goldman 3 mirror. And because of high nystagmus, we were not able to take so many pictures of the OCT, but we can see the hump sign in this picture. And on the bone B scan, we can see the retinal detachment, funnel shaped retinal detachment in the right eye, and with the coloboma, and the start of the retinal detachment in the left eye also. So this is a case which was admitted in the PICU department, and he was on the fundus examination was done before a lumbar puncture, and we could see the choroidal tubercles. And later on, he was diagnosed having the tuberculoma, disseminated tuberculosis. And later on, we follow these tubercles on the OCT pictures also, and we can take the sequence documentation for the documentation purpose. So wider need in developing countries. So, and that is when they don't have expensive instruments, so we can take help of these cheap instruments for the documentation purpose. And teaching institutes, especially for PG examination, when they are sent for fundus examination in various ward rounds, for the ROP screening, diabetic screening, and glaucoma screening. And it also helps in communicating with various ophthalmologists in tele-screening. So we can...
We're running out of time.
Thank you so much. So that is retinal exposure for the smartphone was wider, 1 order of magnitude less than that of indirect, which is safe. So this innovation is cost effective in a boon in documentation purposes. Thank you. Thank you so much.
Okay, that was very nice and very exhaustive. But we are supposed to wind up by 10:30, and I think
I am stopping my share.
No, I know. Yeah, can we just move on to Dr. Nishi Gupta? Yeah, Nishi, you need to unmute yourself. You are not.
Yeah. Can you hear me now?
Yes, we can.
Yeah. Good morning. I work as ENT surgeon in Dr. Shroff's Charity Eye Hospital, and that's the reason I got interested in lacrimal work. And I'll be talking on role of the cryoendoscopy in refractory congenital nasolacrimal duct obstruction. So the cryoendoscopy is the intraluminal visualization of the lacrimal drainage pathway using a miniature 0.8 mm Karl Storch endoscope, which is coupled to a high definition camera unit. Then helps us in complete visualization of the lacrimal pathway from the nasolacrimal duct till the punctum. That's a patent nasolacrimal duct which is seen from inside. This is at the level of valve of Hassner. This is the mid part of the nasolacrimal duct, and that's the most important area, which is also known as valve of Krause area, which is the bottom of the lacrimal sac, and we can see this patent proximal opening of the nasolacrimal duct, and that's the lateral outpouching, which is invariably found in the intraluminal visualization of the lacrimal sac. This is also the most important area where the occlusion occurs in Pando. And also it is important to identify this area so that if we can visualize the normal anatomy, we would be able to pick up the abnormal anatomy also. Lacrimal sac looks pinkish from inside. This is common canaliculi where we can see these variable folds. That's one of the canaliculi, and that's the punctum. So why do we need cryoendoscopy? This is because the most common cause of epiphora in children is CNLDO. And if we look at the normal nasolacrimal duct on the left side, on the right side, this is the inferior turbinate, and we can see free flow of dye through the nasolacrimal duct opening. That's the distal opening of the nasolacrimal duct. But what happens in membranous CNLDO is that when the dye is flushed through one of the punctum, as the inferior turbinate is lifted, we can see this dye getting collected below this intact membrane over the valve of Hassner. So this is the most common presentation in CNLDO, and we can see the probe that is passed through one of the punctum below this membranous obstruction, and it can be recanalized with the help of Bowman's probe alone. So, so far it is all good, but what happens in cases where we lift up the inferior turbinate and we fail to see any nasolacrimal duct, and the mucosa can be seen tightly draped along the vault of the inferior meatus. In such cases, when the probe is passed through one of the punctum, we fail to visualize this probe into the inferior meatus. So that's one situation where we need to find out what has gone wrong, because patient can undergo multiple probings. And if the probe is forced in this condition, it will end up into a false passage. So what are the defects that we expect in such situations? These are the congenital NLD defects, the schematic diagram. It shows a membranous bulge here. That's the most common presentation. We might be having some dicryoliths, which cannot be seen without an intraluminal visualization. And these two are the NLD malformations where there is a possibility of false passage. So let's have a look at the high definition dacryoendoscopic intraluminal visualization starting from the membranous CNLDO. This is the left side. We can see the canaliculus, the upper canaliculi, which is, this is the wall of the canaliculus. And as the endoscope is negotiated, it's a little difficult with learning curve. We can see the common canaliculi here. This is one fold, that's another fold. And as we go inside, we reach the lacrimal sac can be noted by some regurgitation of the secretions here. And that's the sac, which looks pinkish. And as we go further, that's the bottom of the sac. And we've started seeing the nasolacrimal duct here. These are some secretions, and a constant flow of saline, which is flushed from the side port, helps us in locating the NLD opening, because once we are inside, it initially becomes difficult. We can see that saline getting accumulated over the membrane, and that's a close look of the membrane, which is punctured and leading to a successful canalization. So this is what happens in membranous CNLDO. But if we have a look at dacryoendoscopy in this malformed NLD, we can see that this is the bottom of the malformed NLD, which we will see in this dacryoendoscopic picture. That's the bottom of the sac. We have started seeing the nasolacrimal duct with some organized secretions. As we go further, we have to keep expressing these secretions to obtain a clear view at the tip of that miniature endoscope. And that's a blind bottom nasolacrimal duct, which is so clearly visible. And that's the lateral outpouching at the valve of Krause area or the sac duct junction. So this end is blind, and probably this is what we feel when we do a probing, and that's a true bony block. These patients will not respond to probing, and we need endoscopic DCR. So this is another case of dacryolith where this intraluminal, we can see the cryo.
It's dacryolyths.
I think we've lost, she has lost connectivity, I think.
Maybe. I lost it when my internet went off for a few minutes in the last lecture.
Yeah. That is the situation in India.
Mm. We have a standby generator in the society. It starts within a minute, but then it takes a couple of minutes for the internet to reboot.
To Khurana, maybe we can go to Dr. Eric, because we're running out of overall time. And I'm sure Dr. Eric has some very exciting stuff
Yes,
to
sir.
share with us.
I agree with you, sir. I think because of short of time.
Dr. Eric, could we have you, please?
Let's hear from Dr. Nishi for that.
Okay. Can you see my slide?
Yes, sir.
Yes, sir.
Okay. All right. I will try to be efficient. I know we're behind. I do thank you for this opportunity. I will say hello, good morning, even though here it is evening. Namaste. I know I saw Sat Sri Akal and Salam Alaikum for anyone that's all there. I have very much missed my time in India. I was supposed to be there again in the March. I've spent many, many trips, and I look forward to meeting many of you. I certainly say hi to many of my friends, Dr. Sharma, Dr. Dadea, Dr. Kakar, so many people. But I wanted to just, one of the things I enjoyed teaching on is pediatric cataract. I know we have many people here that are not necessarily cataract surgeons, but we all prize ourselves in taking good care of children's eyes. And so much about pediatric cataract surgery is identifying certain conditions, but also managing things afterwards. And people that believe that they can do well with children's eyes just because they're a good adult surgeon, they might be good at the procedure, but they need all of us in the pediatric eye community to take care of these children because of the associated challenges. And there have been, over time, a number of reports and details on how to look for risk factors and associated problems. I'm trying to advance my slide. I threw this in just a minute ago, the importance of a red reflex, the importance to diagnose these children early and identify abnormalities that might be associated. And some of these eyes we could spend too much time talking on. What I wanted to point out to people is around the world, there are more and more good trials and registries to isolate and to help us fine tune our attention to the children that are going to have the most difficult time with cataract surgery. And certainly what is the advantage of these in terms of multi-center efforts? When we team up, we have more numbers. We can look for ones that have randomization, and how we do things similarly will help us find results. Protocols are good, and sometimes the real world description is good. And so I listed right here the group of all of the current multi-center trials and registries in pediatric cataract. And we're not going to go through these in detail, but just to point out that the top two are both the infant aphakic treatment study, a group of doctors in the United States that did surgery on infants. And at the same time, they collected TAPS, and these are the toddlers in their same group. So those two are actually the same surgeon group. And let me just highlight a number of these. This is the infant aphakic treatment study. These were at various sites, but the infants were defined as 1 to 7 months old, and this was randomized. So the surgeons didn't control which eyes got a lens versus no lens. The next one I'll just touch on briefly is the TAPS. Again, this is the same group of doctors that looked at their children that were up to age 2 and older then, and including the bilaterals, and 3 registries I've had an opportunity to be involved. In Britain, in New England and Britain, they had this study called IOL under 2. And these were all of the cataracts performed with 66 investigators, probably doing things differently, but sending in their data for the infants. Dr. Vasavada did a beautiful study comparing, again, children in the first 2 years of life getting a lens versus not getting a lens, and he did this randomized. Dr. Lee did this for one eye, getting randomized to a contact lens or an IOL. Again, most of this is focusing on children in the first 6 or the first 2 years of life because they're the most difficult. The biggest group currently called PDIG, we've talked about them today already on other for amblyopia, but they have a cataract registry coming out. This will be coming into the press shortly, their 5-year data. And then also just coming into the data is a Swedish study. What I wanted to do today is to pull together all of these because they all have information and just summarize what they tell us. What are the common threads? And certainly in vision, we have to remember that when people report vision, we don't always know about what they're doing with refraction, what they're doing with amblyopia, how much are they patching, is patching even happening? And the IATS is one that did have a protocol, the rest are more groups. And the takeaways here is number one, as we all know, when you have a problem in one eye, the vision is often worse than if it's a bilateral process. So children with bilateral cataracts do better than with a unilateral cataract. And we still have a ways to go to I'd say, to help these children with unilateral cataracts. I'll go to the next slide and say, what is the next? Intraoperative complications. Cataract surgery in babies is difficult, and that we have to recognize that there are things that happen in surgery. One of the interesting things about these studies is when they're done prospectively, usually more information is gathered. The charts retrospectively, a lot of the little trouble in surgery isn't documented. So be aware or be cautious on retrospective data and whether or not they are documenting all the intraoperative complications. Adverse events. It seems like children in less than 6 months of age, certainly 3 months of age, in all of these studies have higher risk. The risks that are quite severe, like retinal detachment and endophthalmitis, are still low, but we have more things to look for in this younger age group. And what are those things? The biggest problem, if you send a child off for cataract surgery and they come back to you for amblyopia care, is visual axis opacification. And obviously when you put a lens inside the bag and the bag doesn't seal off and make Sommering's ring, the cortical regrowth cells go across the lens and have a high rate in these young infants and children of needing further surgery. So this is one of the reasons why people are doing what's called optic capture or other techniques to try to let the bag seal. But visual axis opacification is the biggest reason why I tell families you might need more than one surgery. Glaucoma. This is what we all worry about. And I think all of the studies point to the fact that the glaucoma risk meaningfully drops after 6 months of age. You might even say 3 months, but when you look at all of these studies, the ones that really narrow in the data and don't just group everyone under age 2, but when you look at the data closely, it looks like the kids less than 6 months of age are at the highest risk. Just yesterday, the infant aphakic treatment study published, and it came out in the press, their glaucoma data. And what it seems like is every 5 years that these children are watched, the glaucoma rate goes up. And now when you combine glaucoma and glaucoma suspect, these group of babies that had surgery in the first 6 months now have an incidence of 40%. So this is a lifelong problem. And the longer we watch these children grow up, the more they might have glaucoma. Strabismus. We all love to care for children with strabismus. And certainly we've found that unilaterals and younger age in these studies tend to be the ones that develop strabismus. Most are horizontals, some verticals later. And I would caution us to chase after these at a young age because it seems like they have more guarded success and might be better off waiting till closer to school age, or maybe when psychosocially it's more important. And refractive error is a big discussion all by itself. These eyes are growing, and when we put a lens in, they're still going to grow, and we get a big myopic shift. So putting a lens in the first year of life can be successful, but we know that we have to plan in a special way for the myopic shift, or for us taking care of them later, deal with the myopic shift in a variety of ways. This shows the data for the TAP study that I help lead and with each, as age happens up to age 2, the degree of the myopic shift gets less. So this is a table that's probably the biggest takeaway. And I put in red the documents in all of these different studies showing that when you put an intraocular lens in the eye, the risk is higher for adverse events and visual axis opacification. Not so with glaucoma, but the adverse events rates managing the lens is higher. And yet when you get beyond the first 6 months, you'll see in green that the rates drop once they get to be older than 6 months. They're not gone, but they're certainly lower. So especially be cautious in how we consent and care for children under age 1, and even more so less than age 6 months. So that my takeaway would be there's many studies out there and that help us determine these risks. The highest age groups, the first 6 months. Glaucoma is a risk potentially with microcornea and the younger age group. An intraocular lens can be a good choice, but does not protect glaucoma or help their vision. But it is a good choice when contact lenses are not available. And we all need to pay a special attention to look for visual axis opacification while we manage amblyopia and refractive error. This is one of my favorite pictures from when I was in India last, and I just thank you for this opportunity. Sorry if I didn't go fast enough.
What's the name of your village in India?
Of my village? My village is in the United States. I am at the Mayo Clinic in Rochester, Minnesota, but I have so many friends in India. I first came about 40 years ago, and I try to take a trip every year or every other year. I've been to Tamil Nadu and Varanasi and Delhi. I missed my trip this last spring to come and see Dr. Kokar and Dr. Sharma, and I look forward to coming again because I miss you all very much.
Thank you, Dr. Botham, very exhaustively clearing the concept that it is not only that we should operate, but we should follow these cases and these trials. And picture is really not so rosy. And I remember the example of one of our, that was in early 90s, and I was also a young just lecturer, and one of our HOD medicine, the grandson has a unilateral cataract. They went out from north to south to get operated, and throughout the whole family was truly exhausted with the best efforts. And in the end, there is a deep amblyopia still. So the carry-on message from your review of the various studies is that it is not only the operating these cases, but a real follow-up and good operation. And I must say, Dr. Botham, my daughter and son-in-law are also in Mayo Clinic with you. We'd like to see you when I visit there.
I will look forward to what are their names?
Arushi Khurana, she is in medical oncology, and Guru Kripa, he is in cardiology there.
I think I have met him. Thank you for that connection. But I do thank you to everyone for the opportunity to be part of this special group.
Thank you very much. It was a wonderful presentation.
Yes.
So if there is no question, then we are already late and we end this session here. And so let the other person take up for the next.
Eric, we really enjoyed it all.
Wonderful presentation and nice. Thank you very much.
Thank you, Dr. Khurana and Dr. Amitava, for a very nice coordination.
Thank you, sir. So nice.
It kept us awake.
Thanks for your blessings, sir.
I took my coffee in between.
We saw you leave.
That's the advantage of being home.
Yes, I must say Dr. Goel is Bhisham Pitama for Spossi and strabismus in India.
Thank you, sir.
Thank you, sir. And I must appreciate the efforts of Dr. Dadya and Namrata for wonderful organization of this conference.
Yeah.
Absolutely.
One just comment for the last comment regarding the optic capture to Eric Botham. We've just published a paper in Jan 2020 where we compared optic capture was in the bag. So bilateral cataracts, in one eye we did capture, in the other eye we did in the bag implantation. And it included 7 infants as well. And over a period of 2 years, prospectively, the ones with the capture without anterior vitrectomy were just doing much better. There was no proliferation of the epithelial cells. Whereas in the bag, there were a few cases with the proliferation of the epithelial cell, even though the visual axis was clear. So we've started doing these in infants as well, where the chances of VO is quite high.
I commend you and I thank you for that work. And I think collectively, I think we're going to continue to make that rate better.
Thank you.
My apologies for getting lost in between. I'm sorry, but that was the last slide, so that's okay.
Thank you, ma'am.
That's okay, Nishi. Yeah.
Let's wind up this session.
Okay. Bye-bye.
Bye. Thank you.
Namaste.
Namaste.
Sat Sri Akal.
So, Dr. Jasprit, we need to stay back here for the next session.
Good morning, Dr. Shikhar. Good morning to you.
Morning. Sorry, without invitation, I have started off my share.
No,
I've
no,
started
perfectly all
sharing
right.
the screen.
Thank you so much. Thank you so much. Please start.
Shall I start?
Yes, please. Please start.
Yes, I thank Delhi Ophthalmology Society for giving me this opportunity to talk about optic neuritis in multiple sclerosis. We all know multiple sclerosis is an immune-mediated disease of the central nervous system, which is characterized by inflammatory attacks against the myelin, which leads to progressive axonal degeneration and eventually leads to a permanent disability. Hence, the importance of diagnosing this disease early and treating the same. Optic neuritis is the demyelinating inflammation of the optic nerve, and which is basically an extension of the brain. The connection between the optic neuritis and MS is that 20% of patients with MS present as optic neuritis, and the lifetime prevalence of MS optic neuritis is around 50 to 66%, and half of the patients with typical optic neuritis will develop multiple sclerosis within 15 years, according to the ONTT. So, optic neuritis first attack can be described as clinically isolated syndrome, which is basically defined as the initial presentation of any demyelinating inflammatory disorder which has not demonstrated dissemination in time required for the diagnosis of multiple sclerosis. So the first attack may remain a clinically isolated syndrome, or what we call idiopathic optic neuritis, or recur and relapsing optic neuritis may either be multiple sclerosis or because of NMO spectrum disorder or CREON or REON. Now, it is after the treatment of the acute attack of optic neuritis or the clinically isolated syndrome, it's very important that we pick up the predictors of multiple sclerosis. And MRI predicts strongly the risk of developing multiple sclerosis. The characteristics of demyelinating lesions would include 3 millimeter ovoid lesions that are mostly located in the periventricular areas in the white matter and radiate towards the ventricular spaces. The risk of developing MS at 15 years in a patient with first episode of optic neuritis is 25% if at presentation the MRI is normal, and it becomes 72% if one or more lesions are present. The other risk factors for developing MS include family history of MS, younger age of onset, winter onset, neurological findings associated with the optic neuritis. And the risk of MS was 3 times higher in women according to ONTT. Presence of CSF-OCP also is a predictor of MS. Recurrent optic neuritis again indicates MS. it's very important to pick up the old attacks of optic neuritis and silent attacks of optic neuritis. Hence, the indicators of functional and structural loss of axons in the optic nerve have an important role. The functional health of the optic nerve is easily picked up by the VEP. If the waveforms show increased latency and reduced amplitudes, it indicates demyelination, and it's fairly sensitive and specific for detecting optic neuritis even in silent cases. The structural damage to the optic nerve can be picked up by the OCT, which shows RNFL thinning or GCC thinning, which is an indirect indication of axonal degeneration and atrophy. McDonald's criteria are the most utilized diagnostic criteria to assess the MS conversion risk in patients with single demyelinating episode by providing MRI evidence for dissemination in space and time. ONTT was the very important study done in 1992, which still guides our treatment of acute optic neuritis, and it showed fellow eye involvement in 14 to 15% of cases and showed disc swelling in 25 to 40% of patients. Visual recovery is faster in the patients treated with IVMP, and the study stated that at the end of 6 months, the patients treated with placebo, oral steroids, and IVMP, all three regained the same amount of vision. Let's look at some cases of optic neuritis and multiple sclerosis. This 30-year-old female presented with a painful decrease in vision in the left eye, but on examination, she had bilateral disc edema. The visual field showed involvement of both the eyes, but the left eye definitely denser defects. The MRI showed a T2 signal in both the optic nerves with a thickening of the left optic nerve, and the brain MRI showed typical periventricular plaques called Dawson's fingers. So this acute attack was treated with IV methylprednisolone followed by oral steroids. Patient was sent for the neurology consult to rule out MS, and at the end of 1 month, patient had regained the visual acuity back to 6.6, visual fields had cleared, disc edema had disappeared. So this is what a typical optic neuritis and multiple sclerosis behaves like. This is another case of a 29-year-old female who presented to us with painful decrease in vision in the left eye, and there's a very subtle edema on the left side. Again, there are periventricular plaques in the brain MRI, and there's a cord involvement also. Treated with IVMP, sent for neurology consult, and started on disease-modifying treatment. After the IVMP treatment, visual fields has cleared. 1 year later, despite being on the DMT, the patient developed a decrease in vision in the right eye, that is the other eye. And though the vision was 6.6, the field effect can be seen here as a quadrantinopic defect. An important insight in this slide is that left eye, which was previously affected, the visual field is normal, vision is 6.6, but the OCT tells us another story. The OCT is able to pick up the left eye RNFL thinning on the this graph, and in the GCC also you can see it as red and yellow areas. So though the eye with the acute attack, the scan is normal here. So an old attack, as we saw previously, the structural health of silent and old attacks can be picked up by these investigations. This patient's MRI brain orbit spine was repeated because the patient was on disease-modifying treatment. There was a decrease in number and size of plaques, but despite the treatment, the patient had a recurrence in the other optic nerve. So let's look at in brief at the treatment. Acute treatment is IV and oral steroids as recommended by ONTT. If it doesn't improve, can try Plex and IVIG. Long-term management depends on the MRI findings basically. If there are demyelinating lesions of patient has recurrent attacks, associated neurological symptoms, consider DMT. If the MRI brain is normal, then follow up closely. This is a very crowded slide telling us about the options of disease-modifying treatment for long-term management. Basically, for very long, interferons have been used to prevent recurrences of MS. Of late, we have got fingolimod and teriflunomide oral drugs, which makes it easier for the patient. And if the patient cannot afford or tolerate these, immunosuppression also can be tried. Thank you.
Thank you, Dr. Shikhar. That was an amazing presentation and very well summarized. And can I request Dr. Jaspreet Sukhija to share the slides and begin his talk with the approach to inflammatory optic neuritis?
So are my screens visible and am I audible?
Yes, you are.
Thank you.
Yes, please.
Yeah.
Please continue.
So,
very nice.
So after that lovely talk by Dr. Shikhar, I mean, obviously my work is easier. But yes, sometimes it becomes difficult when there's an overlap of things, I mean, the optic neuritis especially. So as we know, the etiology of optic neuritis, I mean, there is just so many causes. I mean, it could be demyelinating, ranging from multiple sclerosis to NMO spectrum to other things. It could be autoimmune with sarcoidosis, SLE, Sjogren's, infectious, para-infectious also make up a big chunk. Then it could be post-vaccination, TB, tetanus. So just a whole gamut of everything. So basically what I would be covering is two broad categories. Is this typical or demyelinating optic neuritis or atypical optic neuritis? Because these are the most common ones what we see, and there is an overlap in these two types of optic neuritis. So typically, as has been beautifully said in the previous presentation, it's usually a young female and is commonly associated with MS. The testing in atypical requires aggressive testing, not so in a MS case. The clinical overlap at presentation makes diagnosis challenging. There are some clinical clues, but they are not diagnostic. The management differs, so you have to have a good approach, and the outcome is different. So a typical optic neuritis would be like a retrobulbar with pain, unilateral, acute, a young female. You can see a visual loss till about 6/18, painful eye movements. The recovery of vision usually starts in the first month, even without methylprednisolone. It could be an isolated attack, like if it's the first attack without any MRI findings, or it could be associated with MS. So I'll just give you some examples and then see how we approach this as per on a case-to-case basis. So this is a 30-year female who comes with blurring of vision right eye since 15 days. So she says it's sudden onset and noticed on waking up, associated with headache, and progressed over 3 days, was associated with pain on eye movements. So that's a very important clue. Otherwise, her systemic history was absolutely unremarkable. She's a non-vegetarian. So the vision in the right eye is counting fingers close to face. Usually in patients of typical optic neuritis, what has been described in the ONTT as well, I mean, it's like 6/18 type of vision what you have. And the left eye, it was 6/6. In the right eye, she had RAPD. So she has a fairly low vision, counting fingers, okay, which doesn't go in favor of a typical optic neuritis. She has a blurring of the nasal disc margin, disc edema is there. And of course, the left eye also, you can see some blurring of the nasal margins, which has extended onto the peripapillary region. So she has a classic triad of visual loss. She has periocular pain and she has dyschromatopsia. So when we do the OCT, now OCT is usually done because we have it in the OPD. It's before sending the patient anywhere else, we just get an OCT done. I mean, the RNFL was fairly good in the right eye. As you can see, some swelling in the nasal part. In the left eye, the signal strength is low. It's about 6. So some loss here. I mean, it can't be so conclusive. And when you do the ganglion cell layer analysis on the OCT, it's fairly good. So because ganglion cell loss would start much earlier as compared to RNFL, it's a much better predictor of whether what things have gone wrong, or maybe how your management, how aggressive you can be. So obviously this patient then had a typical optic neuritis. Now the etiologies of optic neuritis, as I have described, could be idiopathic, demyelinating, autoimmune, infectious, inflammatory, and post-vaccination. So these are some of the things which we had to keep in mind because it was a counting finger. She had disc edema and in both the eyes. So we ordered some investigation, the basic what you would order in any case. Got a kidney function test as well. the important thing here was get a vitamin D levels as well. Although it's not a direct cause, but it's a risk factor for optic neuritis. Fortunately, they find her inflammatory markers were within normal limit. And because, I mean, there's an overlap between a typical and optic and an atypical because of the vision in this case, probably we got these done before starting any treatment. And a CSF was done because the MRI was within normal limit. So usually the criteria and all, many times you can diagnose it on just based on MRI, but when it's not seen, then the oligoclonal bands are the ones, if present, give you a clue to the diagnosis. So again, methylpred was started here at the usual dose, followed by a taper. I mean, she improved from counting fingers to 6-9 after 5 injections. The RAPT persisted, the dyschromatopsia persisted. So the second case is, so that was just you can say a clinically isolated syndrome. I mean, without any MRI findings and the CSF being normal. I mean, that's just the first attack. So this is a second case who comes, a 34-year-old male with a sudden decrease in vision since 1 day with brow ache. First episode, no systemic complaint. So this is a male now with 34 years old. Now, when you do the vision, it's again very low. It's 5/60 in the right eye. RAPT is there, no vitritis is there. He has a fairly moderate disc edema in the right eye, where the left eye seems something has resolved, but he doesn't give any complaints in the left eye at all. So we have low vision, we have disc edema, we have 1 day history, something hit him, he says, and he doesn't have pain on ocular movement, just a brow ache. So when you get that OCT done, in the eye which has the disc edema, I mean, it's showing the RNA, the ganglion cell analysis is fairly good, it's green. Okay, and the left eye, which is normal, which is 6/6 vision, you can see a red ganglion cell loss. So could be he could have had subclinical attacks there. And whereas in the right eye, I mean, it's showing maybe because of the disc edema or something is interfering, is showing a green color. But yes, it stayed there even after 3 weeks of IVMP, which shows the left eye did have subclinical attacks previously. So the OCT is a really good tool when you're approaching these patients, and when you find before any investigation you order, I mean, this can give you some clues. And when we ordered the MRI, obviously he had Dawson fingers, which are clearly seen here. And you can see the thickening of the optic nerve here. And you can see one segment enhancement in the cervical spine. So these are pointers in favor of an MS lesion. So he was started on IV methylpred. Prednisolone later was given. His vision acuity was 5/60, which improved to 6/9 after 1 week. We did get a CSF and blood in these cases as well while we were waiting for the MRI because of some atypical features. So coming to the atypical, I mean, because of so much overlap, even though there are clinical signs, but sometimes it's difficult. So this atypical optic neuritis, there is severe inflammatory demyelinating disease, which affects the optic nerve and the spinal cord. It's a distinct disease with antibodies against aquaporin 4 and MOG, the commoner ones. The MRI findings, which are suggestive of a neuromyelitis optical spectrum disorder, are the brain lesions. You have more than 50% involvement of the optic nerve. In MS, usually it's anterior 1/3 only, limited to just the orbital part. In these cases, more than 50% more posterior involvement. You have chiasmal involvement, you have periependymal involvement. So just something which is going more intracranial. Spinal lesions, as I showed you, there was just one segment involvement. So if you have more than 3 segment involvements, usually goes in favor of a atypical optic neuritis. So you can some of the MRI slides which findings which show it's atypical you can see here. I mean, this thickened optic nerve extending almost up to the chiasma. Same here. I mean, just see the enhancement here, where it's going way back, and so much thickening again, reaching posteriorly. So the spinal cord here, you can see this enhancement, more than 3 segment enhancement. So these are pointers in favor of an atypical spectrum. So the NMO spectrum also covers the MOG. Here, isolated optic neuritis is more common, but usually with a transverse myelitis. The MOG positives we are seeing more in children here. The phenotype is similar to NMOSD. Recurrences are more common here. Although the visual loss is profound initially, painful, but responds well to steroids. So MOG positive usually responds to steroids. You have more disc edema in these cases. Imaging, because it's an NMO spectrum, it's more than 50% optic nerve involvement. Chiasma is less involved. Perineural enhancement is one of the characteristic features. So this is something which you're seeing in the MOG patients. The acute management is same for any kind of optic neuritis. You give them IVMP for 5 days and then immunomodulator later, depending upon what type of an optic neuritis it is. So just to sum up, I mean, this to how to differentiate a typical versus a atypical, you can do it based on the clinical signs, the symptoms, it's the laterality of the attacks, which are usually bilateral in NMOSD. The severity of visual loss is severe. The ganglion cell loss is severe on OCT. The optic nerve involvement is anterior orbital here. It's posterior in these cases. Transverse myelitis more than 3 segments is common in NMOSD. And of course, you have more tissue destructions. In cases, because many times the MRI can be normal, and then if you go to the CSF, the oligoclonal bands are frequently found in cases of MS, and proteins are much higher in case of NMOSD. So these are some of the things how you can identify, how you can approach a patient depending upon the signs and symptoms, and of course, what imaging to get. And when you get the imaging, you can just, you can say narrow down your diagnosis to what type of an optic neuritis you're dealing with. So I would like to conclude here by saying that in the era of biomarkers, the way we look at optic neuritis has changed. The pattern of optic nerve enhancement on MRI provides diagnostic clues to the etiology, helping us understand the mechanism of the disease. Because there is so much overlap in the phenotype between MS versus an atypical optic neuritis, it is very important to appreciate that these are separate entities with differing prognosis and underlying pathophysiology. And because they have optimal treatments, it is very important that our approach is tailored to what type of an optic neuritis, and the management is accordingly done. Thank you.
Thank you, Dr. Sukhija. That was an amazing talk, outlining the differences between a typical optic neuritis and, the optic neuritis associated with MOG disease or, the multiple sclerosis. Now, we would now shift gears, and I would welcome Dr. Digvijay Singh to share his slides and give his presentation on non-arthritic ischemic optic neuropathy. Dr. Digvijay.
Thank you. Am I audible? Is my slides visible?
Yes, please. You're all good to go.
Okay, good. So I think we'll shift gears, as Dr. Krishna said, to NAION, management pearl, which is completely different from optic neuritis. And so it's really going from first gear to fifth gear, if you want to look at it that way. So I'm going to discuss management pearls of NAION briefly. NAION, as we know, is the most common ischemic optic neuropathy that we get. It accounts for 90 to 95% of the ischemic optic neuropathies, and it is, typically seen in the 5th to 7th decade. And it's a small vessel disease because of the closure of the short posterior ciliary arteries at the back, that there is vision loss, typically presenting in the morning when the patient wakes up. It's painless vision loss that is happening. And usually these patients have some systemic risk factors. There are ocular risk factors such as a crowded disc could be there in the fellow eye, but systemic risk factors such as blood pressure, diabetes, cardiovascular disease, collagen vascular diseases, homocystinuria, obstructive sleep apnea. So there are quite a few systemic risk factors which you would often find in these patients. In about 30%, the vision may be normal, but in the majority of the patients, there is a reduction in the visual acuity, and the visual fields would typically show you an inferior altitudinal defect, or an altitudinal defect rather. And there is a disc chromatopsia, which is usually, unlike optic neuritis, here it is commensurate with the amount of disc involvement overall. And then there is a disc swelling, and the discs would look something like this. Initially hyperemic, later on they would get into a palate swelling. There would be a delay in the choroidal filling on the FA, and there would be some kind of a disc leak that you'll probably see. And you'll see a crowded disc in the fellow eye. So this is what NAION is briefly. Pathophysiology wise, it is basically an ischemic lesion. It's not really an autoimmune problem. It's not really something which is, there is an inflammation which is involved, but usually it's a secondary inflammation that tends to happen. And people have found that the vision loss could actually be because of a compartment syndrome kind of situation in the optic nerve itself, or you can also have macular edema. So this has also been described here, and which is when people started, looking at steroids as a possible mechanism of treatment. Though we know naturally that in about a third of the cases, there would be worsening of 3 lines or more, as has been seen in trials in the past. In about 20%, there would be 3 lines, in 30%, there'd be an improvement. In 20%, they could have a worsening of 3 lines or more. And then in about half the patients, it tends to stay where it is. As a ballpark, you can say in about 40%, you may see some natural recovery happening in the visual acuity. In terms of treatment, there is no definitive treatment that is known as of now, other than to identify and control the systemic risk factors if that we can. Aspirin has been used, anecdotally, but it has not been shown to have any effect on preventing the fellow eye getting involved at all. Steroids are somewhat controversial, and I'll come to a couple of studies on that. And there have been some novel agents that also I'll mention, but we really haven't found anything which is substantially beneficial. The role for steroids actually came in from the point that people thought, it'll work as an anti-inflammatory modality, it'll stabilize the membranes, it'll reduce the free radical damage, it'll remove the, compartment syndrome kind of a picture. And just like they were using it in, cerebral ischemia initially, quite a bit, they started to use here. No longer they're using in cerebral ischemia, but here we still are exploring the role completely. So the evidence for steroid therapy actually came in from studies as far back as 1970, and then a lot of studies by Dr. Harry et al., who found that if you give steroids, between 50 to 90% of patients would improve compared to a placebo. And and these studies had some shortcomings, being a patient choice study, but these were strong proponents for steroid therapy currently. But at the same time, there have been a number of studies recently, clinical trials, including one randomized control study that we did, at Ames with Dr. Saxena. And we found that steroids on the whole are not really making a major difference to the clinical visual outcome. Subclinically, in reducing disc edema, yes, maybe some changes in the VEP compared to a placebo, we did find some changes. So on the whole, that and another couple of studies by Rebodella et al., etc., have shown that steroids are not really beneficial. In fact, they have shown to have adverse effects. We have seen that in about 1/3 of the NAION patients in one of these studies, there were severe adverse effects of steroids. In our own study, in about 1/4 of the patients, there were adverse effects of steroids versus in about 10% or 13% on placebo. And about 10% patients who were given steroids, particularly when they were diabetic, needed to have another medicine to control because they had impaired glucose tolerance. And even those who didn't have diabetes ended up having some impaired glucose tolerance in the period. So what is the role of steroid treatment in NAION? And there's one more thing here that I mentioned was that some of these studies, even intravitreal steroids have been tried, and they've been shown to have some success in, single case reports or short case series. So we definitely know that steroids have to be used in arthritic AION. There is no doubt in that situation, which is related with giant cell arthritis or arthritis itself, because you need to take care of the inflammation there. Probably the role in NAION is not very definitive. You could use it relatively safely in non-diabetics where there are other risk factors, and that's probably where, that's what the study we did, where we used it in non-diabetics, and we found that, the number needed to treat was 4.7. So if you treated 4.7 NAION patients with steroids, you'd end up with a visual benefit in 1. So which is probably not all that bad if you're doing it non-diabetics, because, the risk factor, the adverse effects are much lesser. However, a large majority of the NAION patients will be diabetic. So that doesn't really work out. A meta-analysis published last year, which has looked at 8 studies, 8 clinical trials, randomized controlled trials, has finally concluded that steroids do not really show a benefit in NAION, and in fact that there are adverse effects. So the risk-benefit ratio is not helpful. It's not something that is suitable to give steroids. Other therapies that have been tried in the past have included erythropoietin, it's included hyperbaric oxygen, it's included citicoline, and so all of these therapies have had some effect, probably at the subclinical level, in terms of some of the biomarkers improving, but not really on the clinical visual outcome. So there's a, there is a very again, anecdotal evidence here and there, but the studies have not been able to prove any other product to have a real benefit in NAION. Some novel agents have been tried recently, like the QPI 107 or the RPH 201. And the QPI 107 was a small interfering RNA that was being used for a study, to make sure, it was basically to prevent apoptosis, so the damage from NAION. But however, the trial did not show benefit and was stopped midway. The other trial is still ongoing, which is this Gum-Matic RPH 201. But again, so far, the preliminary results are not very, encouraging. So, where do we stand now? Basically, we know that NAION, of course, is a clinical diagnosis, so we have to make it clinically. And if we know the clinical findings, we can differentiate it from optic neuritis and other forms of optic neuritis, though there could be some gray areas once in a while. We do note that in terms of treatment, the important thing is to identify the risk factors and to control that. As of now, steroids are not really beneficial. No other real agents have come in. If at all you want to use steroids, probably I would say in non-diabetics it works well, or in well-controlled diabetics, and do a very strict monitoring of the blood sugar. So that is in brief, the current management pearls of optic of NAION, and we're still hoping that we end up with some good treatments in the future. Thank you.
Thank you, Dr. Digvijay. That was truly very good. And there's a lot of thought there, very little to go on. But you very nicely summarized the current situation and the current directions that you could possibly take. Shailendra, would you like to make any comments, please? Anybody? So, may I welcome Komal Saluja for her talk on a pale optic disc.
Hello.
Hello.
Can you see my screen?
Yes, please. You're audible and your screen is all there.
Good morning, everyone. Today I'll be talking about the differential of a pale optic disc and a unilateral disc edema. So the pale optic disc is the end result of a number of pathological processes leading to axonal loss and their replacement by glial tissue. Pale optic disc is due to decreased vascularity and capillary dropout, gliosis, and increased visibility of scleral lamella. The aim of our clinical evaluation is to find out if it is an ongoing or a progressive process, or it is a one-time insult, and to assess the visual prognosis and assess the need for intervention. The differential diagnosis of a pale optic disc is majorly optic atrophy, while other differentials include optic disc pit, optic disc coloboma, medulated nerve fibers, disc bruisens, morning glory syndrome, optic disc hypoplasia, and a myopic disc. Optic atrophy can be pathologically categorized into ascending atrophy, in which the primary pathology is in the retina, for example, retinitis pigmentosa, arterial occlusions, glaucoma, or a trauma. It may be descending, where the primary pathology is intracerebral, or it may be inherited. We can also classify optic atrophy as primary, in which the optic nerve head anatomy is preserved, for example, in optic neuritis, in tumors, etc. Or secondary, which is secondary to long-standing disc edema, as seen in chronic papilledema or anterior ischemic optic neuropathy. It can be consecutive to inner retinal or vascular abnormalities, as seen in retinitis pigmentosa, arterial occlusions, and post-inflammatory lesions, or cavernous, in which there is excavation of the optic nerve head and caverns formation, as in glaucomatous optic atrophy. Etiologically, optic atrophy can be classified into ischemic, inflammatory, toxic or nutritional, compressive, traumatic, and hereditary optic atrophy. To evaluate a patient, we'll first notice the age of the patient, as there are specific causes of disc pallor in children, young adults, and older adults. There are few causes of disc pallors which have male and female predilections. Optic atrophy can cause unilateral or bilateral vision loss, as unilateral as seen in optic neuritis, ischemic neuropathies, traumatic neuropathies, while toxic, hereditary, and atypical optic neuritis can be bilateral, may or may not be asymmetrical. The onset can be acute in optic neuritis, ischemic optic neuropathies, or insidious in toxic, nutritional, and hereditary neuropathies. We can also look for associated symptoms, neurological symptoms, jaw claudications, scalp tenderness, headache, etc. Precipitating factors like fever and trauma, exposures to drugs and toxins like methanol and tobacco toxins, malnourishment for vitamin B12 deficiency, systemic illnesses for ischemic optic neuropathies, and family histories. Coming to examination, we have to look for pallor for nutritional and nutritional deficiencies, pulse, blood pressure, bruise for ischemic optic neuropathies, signs of nutritional deficiency, alcohol and smoking, gait to look for tunnel vision or ataxia. In ocular examination, visual acuity will be decreased. There is color vision and contrast sensitivity loss. Relative afferent pupillary defect is seen. Ocular movements may show strabismus and nystagmus. Anterior segment neovascularization can be seen in ocular ischemic syndromes. Intraocular pressure should be recorded, and optic disc appearance as per to the size, shape, color, margins of the optic disc, neuroretinal rim, cupping of the optic disc, visibility of lamina cribrosa, nerve fiber layer defects can be seen. Kestenbaum index as to the reduction in number of small capillaries less than 6 is specific for optic atrophy. Surrounding retina has to be observed for indications of retinitis pigmentosa, diabetic or hypertensive states, sheathing or attenuation for occlusions, spontaneous venous pulsations, optociliary shunts for some intraorbital or intracerebral tumors, signs of trauma as per Berlin's and choroidal tears. So after evaluating the optic nerve head, we can define a primary, secondary, or consecutive optic atrophy. For visual field examination is done for to look out for centroscotomas, enlarged blind spots, or altitudinal and arcuate defects as seen in demyelinating optic neuropathies, papilledema and congenital anomalies, anti-ischemic optic neuropathy, glaucomatous defects respectively. OCT has been utilized to detect retinal nerve fiber layer, ganglion cell layer defects. Electrophysiology for pattern which visually evoked response, ERG and EOG can also be done. Investigations for systemic investigations, hemogram and peripheral blood smear for vitamin B12 deficiencies. ESR CRP is raised in ischemic optic neuropathies, inflammatory neuropathies, blood sugar for diabetes, Montus chest X-ray for tuberculosis, carotid Doppler and temporal artery biopsy for ischemic neuropathies, sarcoidosis for serum ACE and calcium levels for sarcoidosis, other collagen vascular diseases, ANA levels, heavy metal screen and vitamin B12 and folate for toxic and nutritional neuropathies, and mutation screens for hereditary neuropathies. Coming to the management, for ischemic neuropathies, low dose aspirin vascular surgeries if indicated. In case of inflammatory neuropathies, we have to prognosticate for multiple sclerosis and start patient on immunosuppressants. Compressive treatment for compressive is according to the lesion. Traumatic is usually irreversible, and for toxic and nutritional neuropathies, we have to avoid exposure and provide vitamin supplementation. Shall I continue with the second one?
Yes, please.
So, talking of differential of unilateral optic disc edema, we have to first find out whether it is a true disc edema or a pseudo disc edema. In true disc edema, the disc is hyperemic, the cup is filled, there is opacification of nerve fiber layer and multiple nerve fiber layer hemorrhages. While in pseudo disc edema, the nerve fiber layer is transparent and cup may be small or absent. The causes of pseudo disc edemas are optic nerve head bruisings, medullated fibers, morning glory syndrome, tilted disc, hyperopic disc, and Buckminster papilla. Features of optic nerve head edema include transient visual obscuration, decreased visual acuity, color vision loss, contrast sensitivity loss. Central vision is affected late. There may be blind spot enlargement on visual fields. So the important signs of disc edema are mechanical and vascular signs, that is filling in of optic cup, edema of peripapillary nerve fiber layer, retinal choroidal folds, venous congestions, peripapillary hemorrhages, exudates in disc and peripapillary areas, nerve fiber layer infarcts, and absence of spontaneous venous pulsations. Most important cause of disc edema include non-arthritic anti-ischemic optic neuropathy, optic neuritis, and intracranial pathology. Unilateral optic disc swelling is seen in demyelinating optic neuritis, non-arthritic AION, and RVOs and diabetic papillopathy. Now, optic neuropathy should be considered in cases where there is visual loss with anomalous swollen optic nerve head, and fundus is normal, but acuity, color vision, and field abnormalities are accompanied by RAPD. Optic neuritis is defined as an inflammation of optic nerve head associated with decrease in visual acuity and visual field loss. There is pain, tenderness, relative afferent pupillary defect, contrast sensitivity loss, central and centrocecal scotomas, may be associated with multiple sclerosis and periventricular plaques in MRI. So, to differentiate typical and atypical optic neuritis, typical optic neuritis is usually seen in young adult, may improve by itself within 2 to 3 weeks, and usually associated with multiple sclerosis. MRI may be the only required investigation, while atypical optic neuritis is basically steroid dependent. There is lack of partial recovery within 4 weeks. There is persistent pain, and progression of visual loss continues after 1 week also. To classify optic neuropathy into typical optic neuritis, where only MRI is the investigation of choice. In atypical optic neuritis, which may be due to non-infectious systemic disease, infectious or post-vaccination. In infectious optic neuritis, we have to look for history of stay or travel to endemic areas, associated system, or evaluate the patient according to the associated systemic involvement, including fever, skin rash, neurological involvement, or immunocompromised states. Coming to ischemic optic neuropathy, it is characterized by sudden vision loss. Interference with blood supply of posterior ciliary artery and anterior part of optic nerve can be arthritic, which is associated with giant cell arteritis, non-arthritic, which is associated with hypertension, diabetic mellitus, etc. Arthritic is characterized by raised ESR, majorly seen in older individuals associated with pain, jaw claudication, and temporal arthritis. While non-arthritic is seen in middle-aged individuals, ESR is not raised. It is seen more in small crowded discs, etc. Compressive neuropathy is seen in intraorbital or intracerebral tumors. There is slowly progressive vision loss can be seen, optociliary shunts can be seen, and optic nerve gliomas, glioblastomas, meningiomas, etc. Hereditary neuropathies, there is loss of vision in subacute painless loss of vision in one eye, then it is followed by the other eye. There is swelling of NFL layers, dilatation and tortuosity of posterior pole vasculatures. In neuroretinitis, there is no risk of multiple sclerosis. There is a systemic cause, maybe due to cat scratch disease, syphilis, Lyme's disease, HIV, etc. It presents like optic neuritis and responds to steroid and has a good prognosis. Diabetic papillopathy may be unilateral or bilateral. It resolves by itself in few months with no resulting optic atrophy or minimal or no decrease in acuity. It is seen majorly in younger diabetics, and anti-VEGFs and good glycemic control is the way to go. Venous occlusions, depending on ischemic or non-ischemic, there is mild or severe disc edema, multiple hemorrhages, cotton wool spots. These have poor prognosis if there is, in the ischemic variant, if there is macular ischemia. So to evaluate a patient of painless progressive loss of vision with unilateral disc edema, if ESR is high, we'll go for inflammatory causes, anti-ischemic optic neuropathies, giant cell arteritis. If there is a lesion in CT MRI, the primary tumors, metastasis, thyroid ophthalmopathy may be the cause. And if the serological test, Monto's test radiogram show lesions, then syphilis, toxoplasma, Lyme disease, or tuberculosis may be the cause. Coming to the investigations, in the visual fields, again, a central scotoma, altitudinal defects, centrocecal scotomas can be seen. Fundus fluorescein angiography shows delayed filling of choroidal phase or segmental disc, delayed disc filling in ischemic optic neuropathies. CT scans and MRIs can show compressive tumors and periventricular plaques in multiple sclerosis. For blood investigations, ESRs, blood sugars, ANA, Lyme titers, basically the same workup that we did in for pale disc. CSF analysis is done if we are suspecting multiple sclerosis and infections. Coming to the management, ONTT trials shows the management for optic neuritis, methylprednisolone 250 mg 4 times daily for 3 days, followed by oral prednisolone 1 mg per kg for 11 days. Anti-ischemic optic neuropathies may show response with intravenous methylprednisolone, then antiplatelet therapies like aspirins or immunosuppressives such as methotrexate. And for non-arthritic anti-ischemic optic neuropathies, there is no definitive treatment.
Dr. Have you finished?
Yeah, thank you.
Yeah, that was very nice. Thank you so much. That was
Sorry, I can't hear you.
Okay. Can you hear me now? Thank you so much for that vision. Can we now look at from the disc, we now go on to the enigmatis. So we Dr. Swati talking about decoding anisocoria. Please share your slides, please.
Thank you, Dr. Krishna. Are my slides visible to all? Am I audible?
Yes, please, Dr. Swati.
I think I'm the odd person out in this session of afferent disorders. I'm the only one who's speaking on the efferent disorder. So to begin with, as I said, this is one pathology which is not caused by afferent disorder. To begin with, I'll just go through 2-3 cases and then the approach, how to approach a case of anisocoria. So this was a 55-year-old female who presented with drooping of eyelid and loss of ocular motility associated with headache. So her clinical features were ptosis, limitation of duction movements, and the eye was fixed in exo and hypo. So this is the clinical picture. You can see that the left eye pupil is enlarged. There is ptosis of the left eye and left eye movements are also limited. The adduction, elevation, depression, all these movements are limited. So it's not a rocket science to identify this particular case. It is probably a case of third nerve, not probably, it is in fact a case of third nerve palsy with a pupil involved. The another case is a 20-year-old male who presented with blurred vision and photophobia. He had no other systemic illness. His ocular history was insignificant and there was no history of any drug use. On examination, this was his vision. His distance vision was 6/6 in both eyes, but he had this poor near vision in left eye. Now, if we can notice, the size of the left eye pupil is larger as compared to the right eye. The third case, I'll come to the approach of anisocoria later on in my presentation, just for the clinical picture of cases first. So this was a 25-year-old female who had complained of drooping of upper eyelid in right eye. Otherwise, her ocular examination was normal, except for there was mild ptosis in right eye, and there was anisocoria with the right pupil very small. So how to approach this case? So what is anisocoria? Anisocoria is actually a difference between pupil size and up to 0.5 mm is considered as physiological. Up to 20% of normal population may have physiological anisocoria. So how do we approach? Before that, we should know what is the normal anatomy of the pupillary constriction and pupillary dilatation to begin with. The pupillary fibers follow the visual fibers and they exit the visual pathway at the level of pretectal nucleus. Pretectal nucleus then supplies to agenda vespal nucleus. Bilateral supply is received by both the agenda vespal nucleus. The pupillary fibers then travel along the oculomotor nerve and then get relayed at the ciliary ganglion, from where they supply to the sphincter pupillae. The pupillary dilatation is brought about by the sympathetic supply, which begins with hypothalamus. These sympathetic fibers descend down to the level of T2, to the level of CA T2, and from there they get relayed and the preganglionic fibers arise. These preganglionic fibers travel in the sympathetic chain, which travels along the internal carotid artery. And here at the cervical ganglion, the postganglionic fibers arise. They travel along the internal carotid artery into the cavernous sinus, then again to the ciliary ganglions, and then supply the dilator pupil. Now, the normal time for dilatation is around 10 to 15 seconds. If you have a dilatation lag of more than 25 seconds, it is suggestive of a defective sympathetic system. So, as I wanted to point out earlier also that the anisocoria is rarely caused by afferent pupillary disorder. The most common pupil problem of afferent disorder is a relative afferent pupillary defect, which we see in optic nerve disorders. In this case, if we shine light in one eye, we will have equal constriction in both eyes because of the consensual response. So that is the reason why we do not have anisocoria in the afferent disorder. So what are the causes of anisocoria? So number one, as case number one, I said is a cause is because of third nerve palsy, pupillary involving third nerve palsy, and the common cause is a compressive lesion anywhere in the starting from midbrain to the cavernous sinus. It can get compressed anywhere, and if you have pupillar involvement in cases of third nerve palsy, it's very, very important to investigate them thoroughly. Especially neuroimaging is required in form of MRI and MRA as well. So common causes include posterior communicating artery, herniation of hippocampal gyrus, craniopharyngiomas, meningiomas, and sometimes even ischemic mononeuropathy can also present as anisocoria, but that's rare. How do you approach a case of anisocoria? That depends on the how you see it. So first and the foremost thing is to see anisocoria both in light and dark. So if an anisocoria that worsens on light is probably has a larger pupil, which is the defective pupil. So as in this case, you can see that the anisocoria is more prominent in light as compared to in dark. So this probably gives a clue that this is the larger pupil, which is the affected pupil. Then we proceed ahead with the, so what are the causes of larger pupil? It could be Eddy's pupil, it could be third nerve palsy, as we have seen earlier. It could be because of drugs, or it could be physiological. If anisocoria remains same both in light and dark, then the cause is most probably physiological. If there is no history of drug involvement, if there is no other sign of cranial nerve involvement, third nerve involvement, we have to go for, may have to differentiate Eddy's pupil. In such a case, a pilocarpine, diluted pilocarpine test is a very useful test because of the hyper sensitivity of Eddy's pupil for pilocarpine. So Eddy's is basically an idiopathic condition that results from damage to the ciliary ganglion, and the most common finding is verniform pupil reaction, where we see the segmental pupil reactions on the slit lamp. So you can see the vermiform movements of the iris. In acute state, the reaction to both light and near stimuli are absent. But as the condition becomes chronic, the pupil the accommodative fibers get re-innervated, and therefore there is a light near dissociation. And this can cause a tonic near response of the pupil, where once the pupil is constricted for the near vision, there will be difficulty in redilatation. So this response is a very classical of tonic near response of Eddy's pupil. The causes could be, most of the time it's idiopathic, otherwise it could be because of any viral infection. So so coming to the third case, if the anisocoria is more in dim illumination, as in this case, you may see that the anisocoria in light is not so significant as compared to the anisocoria in dark. So in this case, it is the smaller pupil which is the defective pupil, and such a case you should always check for dilatation lag. As I said earlier also, the dilatation lag of more than 20 seconds is suggestive of sympathetic problem. So causes of smaller pupil, the most important cause is Horner syndrome, but of course we should not forget to look at the local damage to the iris in form of any tear or any local ischemia. It could be still physiological, and as I said, if the anisocoria remains of the same amount in both light and dark condition, the cause is physiological. Sometimes aberrant regeneration of third nerve can also lead to small abnormal pupil, and drugs, of course, is the important cause to rule out. So the Horner syndrome is an oculosympathetic paralysis and has a classical triad of meiosis, where the dilatation lag is characteristic and diagnostic. There should be a small amount of ptosis due to the paralysis of Muller's muscle and ipsilateral facial anhidrosis. Then causes could be central as well as peripheral. The central causes could be because of hypothalamic lesion and cervicothoracic spinal cord lesions. The peripheral causes could be against any apical mass or any lesions at the neck region, cervical disc herniation, sometimes trauma also. How to diagnose a case of Horner syndrome? If you can do cocaine test, which is very, very diagnostic. So instill 10% of cocaine, which prevents reuptake of the noradrenaline at synaptic terminal. If there is no dilatation of smaller pupil, even after 40 to 60 minutes of instillation, it confirms the presence of Horner's. Now, the next step is to identify whether the lesion is preganglionic or postganglionic, which can be done with the help of hydroxyamphetamine test, which is generally done after 48 hours of the cocaine test. This prevents, the hydroxyamphetamine causes release of acetylcholine from the preganglionic terminal and causes dilatation of pupil. If there is a dilatation of pupil, that confirms that this is a case of preganglionic lesion. If no dilatation is there, then it suggests that's a case of pre-post ganglionic lesion. However, in today's scenario, one may not get easy access to cocaine and hydroxyamphetamine. So one may use apraclonidine 1% or diluted phenylephrine can also be used to confirm the presence of Horner syndrome. So to conclude, how do we approach a case of anisocoria? If anisocoria is more in dim light, it is the smaller pupil, which is the abnormal pupil. Check for the dilatation lag. If there is no dilatation lag, probably it's a physiological anisocoria. If there is a dilatation lag, we can do cocaine test and see whether the anisocoria increases. If the anisocoria increases, it's a Horner syndrome. And one can further proceed with 1% hydroxyamphetamine test, and if both the pupil dilate, it's a central Horner's. If abnormal pupil dilates, then it's a preganglionic. If abnormal pupil is larger, yes, it's a preganglionic. If the abnormal pupil is small, it's a postganglionic Horner's. However, one can alternatively also do a phenylephrine test and see whether the pupil dilatation is due to structural anisocoria or due to the structural damage, or if it's dilate widely, then it probably we are still dealing with the Horner syndrome. I'm sorry, Miss. Yeah. So if you have an anisocoria which is more in bright light, then we are dealing with the larger abnormal pupil. Look again at this slit lamp, look for the local iris damage. If the iris is normal, then check for the segmental paralysis, those vermiform movements. Then check for the light near dissociation and point towards the Eddy's pupil. Pharmacologically, you can confirm the Eddy's pupil with 1% pilocarpine test. If it's positive, you're most probably dealing with Eddy's tonic pupil. If it's negative, you still cannot rule out any Eddy's tonic pupil. Look for the tonicity of pupil. Sometimes even third nerve palsies may respond to 1% pilocarpine, not to 0.1% pilocarpine. Thank you. With that, I conclude my presentation. Thank you.
Thank you, Dr. Swati. You truly stood out with your presentation. Very nice. Now, do we have Dr. Swati please talk about this.
Thank you, Swati, for such a elaborate discussion on anisocoria. It was really needed.
Thank you.
Thank you. But what I was really wondering all throughout your talk is how whenever we see anisocoria,
yes, ma'am,
we should obviously exclude any structural abnormality or any other disease of the iris and pupil per se. Then we look for all these neurological causes that you have described. But what I wanted to really clarify is that should we label a anisocoria as a physiological anisocoria after exclusion, or is there something that would suggest that no, this is probably physiological?
As I said during my talk as well, that if you have the same amount of anisocoria both in light and dark, then you might as well label it as physiological anisocoria. And you can of course measure
our
the
PGs
amount
are, our PGs would jump at the option of physiological anisocoria at the earliest opportunity. So it should not be. See, we have to look for causes before we actually talk of physiological anisocoria. The test is very simple, though I agree, but at times it gets confusing.
Yes, ma'am, I agree.
Thank you so much.
You can also measure the amount of anisocoria, ma'am. Generally, physiological anisocoria is not more than 0.5 mm or 0.8 mm to be massive. So if you have an anisocoria more than this amount, then probably it's a pathological one.
Yes.
So how, I have a question. How do we measure that 0.5? I mean, it's quite difficult to measure 0.5, even on a slit lamp or...
Gauze. You can use pupil gauze, or you can use pupillometry. Infrared pupillometries are there nowadays. The exact amount of pupil size is available there.
Okay, so that's the important thing to measure it with that.
That's really, yes.
Other than that, if you see anisocoria is visible to your eyes and you find that it is not more than 0.5, so it is obviously less than that.
You also have the current autorefractometers which have size measurements, and they use infrared, which is more more accurate than using light things. So you can actually measure this in the autorefractometers usually there in most offices.
Even our visual field gives the size of pupil if you put it.
Yes, indeed. Yeah. So, but then you have an autorefractometer there and all those things. So in your OPD, you can easily measure your pupil sizes there. Of course, as you said, you have pupil gauges and you have more elaborate systems of using your light-based pupillometry thing, subject of. Thank you so much.
Thank you.
You really stood out with your talk there. Thank you so much. We do not have Dr. Sudhir here, so I think I'll quickly go on to my presentation. Share my slides. Yeah, can you see my slides, please? Hello.
I'm sorry, Dr. Krishna. Actually, your voice is not clear.
It's not clear? Is it better now?
Now, yeah.
Better now? Okay.
Yeah.
Okay,
Better.
so now, fine. Can you see my slides, please?
Yeah, sure.
Yeah,
Slides
thank
are
you so
clear.
much. Yeah. Okay. So I shall be talking about idiopathic intracranial hypertension in the past recent decades. There are a lot of research which have been talking about the
Can't hear you. Can't hear you at all, Dr. Krishna.
Voice is breaking and
voice is
inaudible.
breaking up. Okay, is it better now? Hello.
Yes, it was a little better.
Okay, better now?
Yeah.
Okay, perfect. So can I continue then?
Please.
Yes, please. Thank you so much. So idiopathic intracranial hypertension. So despite the recent plethora of advances in research work on the etiology, genesis, and these, I'll quickly go on to the goals of management, which is salvation of time. And the main goal of the management of this particular disease remains the preservation of optic nerve function. in a condition with characterized by raised intracranial pressure. So we need to manage that too. And perhaps one of the most irksome and bothersome symptoms associated with this disease is headache. So we need to treat that. And also look at the causative mechanisms which could cause and give rise to idiopathic intracranial hypertension, such as coagulation disorders, central venous thrombosis, sleep apnea syndrome, obesity, and of course, certainly not drugs and agents that cause increased uterine pressure. This is exhaustive. Contraceptives, drugs. So first, how do you look at what do you say that your intracranial hypertension is basically with presence with symptoms of raised pressure.
Dr. Krishna,
No
your
local.
voice is cracking.
Okay. Is that better now?
Yeah, when you say like this, it's better, but along with the presentation, it is not coming well.
Okay. Okay, I'm so sorry. But I don't know. I guess it must be, maybe I'm going too fast.
Now it's better, like you're talking, it's better. But I don't know, with the presentation, it keeps cracking.
Okay.
Just try it again.
Yeah, I'll just go on. So you have idiopathic intracranial hypertension in patient with symptoms of raised pressure, abnormal or no cognitive defect, normal imaging, and opening pressure of more than 25 centimeters of water. Basically, you should have no explanation for raised pressure. So there are some types of intracranial hypertension. You have the type with profound loss of vision. You have the typical IIH, which is a female of childbearing age with nearby and the atypical IIH.
There's still that sound coming. It's like a robotic sound along with your voice. Are you using a headphone, sir?
Yeah, I'm using a headphone.
Please try without it. Can you try without it? Sometimes without it.
Yeah, remove the headphone.
Still there.
Still there. Maybe something to do with the
We were fine just before moderating, but with the talk, it is not clear. Is it just with you? Others are also feeling the same thing?
We all are having issues. There is problem with his
end. Okay.
It's there.
Is that very better now, please? Shall I go on?
It is, I mean, I can't hear you properly. Maybe you're asking me something. It is still cracking. Yeah, still little better now. The moment you speak little faster, the voice, the sound starts coming.
Okay. Maybe I should go a little slower. So, it's better.
No, it's not better now.
It's not better now.
Can't make out anything what you're saying. Can the IT people help here?
Maybe you
Anybody
can try changing your connection.
कृष्ण सर आप 2 डिवाइस यूज कर रहे हैं या सिंगल डिवाइस यूज कर रहे हैं?
सिंगल डिवाइस कर रहे हैं
और लॉगिन
देन सर ये तो फिर नेटवर्क इशू है.
Network issue. Okay.
Is it this problem is there in this presentation, or was it there in other presentations also?
Only this presentation, Dr. Kubash.
नो सर,
And
सर
while he
जब
was
मॉडरेट
moderating,
भी
it
कर
was
रहे थे
okay, but
सेशन को तब भी वॉइस में प्रॉब्लम आ रही थी.
I'm asking some IT person.
Now when I'm talking slowly, can you hear me?
not very clear, Dr. Krishna, even now with slowly also. As soon as you're speaking, there is a robotic sound along with your voice that comes.
Okay.
Shailaja.
Yeah.
Shailaja,
Is it better now? Is it better now?
Yeah.
Shailaja, in the
Okay.
meantime,
It is slightly
get
better.
someone else to speak. We can always come back to Krishna again.
There was
Instead
his
of
talk was the
wasting
last
time.
talk, ma'am.
Sorry?
His talk was the last talk.
Okay, okay.
One presenter is not there in between.
Okay, okay.
This is the last talk.
Yeah, this is the last talk of the session.
Okay. If he can give it from his mobile instead of his laptop, can he do that?
Yeah. Email the presentation to you and yourself and try to send, do through your mobile.
If he can send one of us, you the presentation, you can play it, he can speak it.
Yeah, yeah.
That's
Is it the presentation or the his voice basically is a problem?
I think it's something to do with his laptop.
Okay. Yeah, he can try with the mobile. That's what.
Yeah, he can speak from his mobile. You can play his slides.
Dr. Krishna, if that suits you, can you send it to me?
Yeah. Or can you hear me right now?
No,
Is it okay?
No, it's
No?
cracking.
Your voice is cracking. Krishna. There is some
Okay.
issue with your device.
Okay. So maybe I should just.
Maybe you can change your position in the room. Sometimes the network is better in some.
Okay. Maybe.
Now you're sounding okay.
Am I sounding okay now?
Yes, yes.
Okay, then I'll just continue then. Shall I?
Yeah.
Now it is slightly
Now
clear.
better. Please continue.
Okay, maybe there was some kind of an echo behind me. Yeah. So in the management, we basically looking at whether we should treat or not treat. We've seen blindness associated with only about 25%, whereas blindness would be only about 42%. Now, when you look at the management, like medical association, but before we start that, I would like to bring about this slide, which is usually given at the end, but the current understanding, this is what of the management. That is to less than 30 in any patient with a high BMI. And it's actually 22% resolution reported on sites. In patients who are atypical and who do not have a BMI more than 30, which in a 5 to 10% weight loss has been associated with pressure. Aerobic exercises and activity have a protective effect on the optic nerve independent of the optic weight loss. Other measures such as fluid restriction before you go to sleep and elevation may also be used to aid the process of stabilizing the visual activity. Is your voice better now? Better And is required in certain groups of patients. Also, be careful about inducing an angiography, which and induce myopia, which can happen because of topiramate. In some patients with headache may be indicated. This probably because of a presumed inflammatory etiology and actually may help, but it's also used as a salvage therapy in patients with pulmonary hypertension and progressive visual loss. In these surgical management, basically there are three arms. We have operation penetration, CSF diversion procedures, and interventional venous stenting. The optic sheath penetration reduces the edema, may have some effect on the headache, has a bilateral effect in 70% cases, and which is also been demonstrated to have a vascular effect in the other eye, and but very little effect on the intracranial pressure. You could do an operation penetration or by a medial approach, lateral approach, and a endoscopic approach. Because you have patient selection for each of these approaches, and you have tailor-made approaches for each of them. So now, what are the results of operation penetration? It results in visual stabilization of 95% and actual improvement in visual function at 75 to 90%, on average about 80%. Bilateral effect, you first like to operate at an eye with a poor vision because it generally does give you a good effect in the other eye. There is a secondary visual decline reported after 3 to 5 years, which should result into blockade of administration, but vascular components may also result in this vision decline. Of course, the visual improvement is poor in patients with no given vision. Now, this is a picture of the penetrated optic nerve. It's not exactly a penetration, you actually need to, delaminate the whole optic nerve sheath and leave it there so as to prevent blockage, number one, and also idiopathic Wilson syndrome. You might have a bleed inside the sheath, which might prevent the optic nerve. Complications include diplopia, optic nerve injury, particularly vascular injury following by medial approach, diplopia abnormalities are common, and optical hemorrhage, infection, and one of the commonest complications of an optic sheath penetration is chronic red eye, which many patients complain of. In CSF diversion procedures, it reduces intracranial pressure. It's a direct attack on intracranial pressure and reduces it very nicely. Also response, headache also responds very well. Procedures include polyperitoneal and ventriculoperitoneal shunts, but ventriculoperitoneal shunts are difficult to do in IIH because the ventricles are split, and so they have very high complication rates. However, you do have persistent headaches in 50%, both low tension headaches and high tension headaches, particularly with the lumboperitoneal shunt, which doesn't work when the person is supine, and that's why you do have the headaches. You could have a loss of vision because of vascular compromise, particularly after sudden immediately after a CSF diversion procedure. And in revision, eye infection is a common failure because neither is common after 3-4 years. The intracranial venous sinus stenting, what is the transfer venous transfer sinus?
Dr. Krishna,
Can you hear me?
not working.
It's not working.
Yeah, intermittently some parts are clear, but majority of the part it is not clear.
Can you speak?
I can't hear right now what you're saying. I don't think there's a point to continue like this. Either we need to rectify it
This
or
is the last slide.
okay.
So you can just look at the slide. Look at this.
The voice is very intermittent here. Otherwise, it's on.
Yeah, I think that's it. So I would just like to emphasize optic sheath penetration. That's the, otherwise, I think. Thank you so much.
Sorry everyone for that internet issue. We had a great session. Thank you, Dr. Krishna, for the presentation. I think we are already late, but we got the session late, but we little caught up. So for the next session.
Okay, thank you, Dr. Selja. So, very good afternoon to one and all. In this session, Dr. Gopal, Kedas, Dr. Shreya, Dr. Dipali, and Dr. Reena. So, can we start the session? I invite Dr. Reena is there.
Yes, sir, I'm there, sir.
So you can call the first speaker. You can call the first speaker.
Yes, sir. Sure, sir. Just a second. I would request Dr. Sunaina Malik to speak on a very important topic, that is refraction in strabismus. Dr. Sunaina, ma'am?
Yes, yes, I'm there.
Please share your screen.
I'm there. Good afternoon, everybody, and thanks so much to DOS and, of course, Dr. Subhash Daria in particular for inviting me to be part of this session. And this topic is very important, refraction in strabismus, and actually it's a bit long, but I'll try to compress it into 7 minutes, maybe 1 minute over time it could go. Now, why is it necessary to refract? All of us know how important it is, because the evaluation of any case of strabismus would be incomplete if you don't refract. It is extremely challenging as well, but at the same time enjoyable, because each patient's refraction is different and every ophthalmologist has a different take on the patient's refraction. But there are some common guidelines which luckily for us have been laid down by AIOS, and I'm going to talk on that. I have divided my talk into two parts: refraction in children and refraction in adults. Now, in children, it's very challenging because children have a very strong accommodation, are often uncooperative, and have a very dynamic ocular system because they are growing all the time. And when do you refract? Early refraction is indicated, particularly in symptomatic cases where you're seeing an obvious squint in certain clinical settings. Otherwise, generally, refraction should be done in all children before the school-going age, that is 3 to 4 years, and pediatricians in particular have to be sensitized to this. What cycloplegic do you use? Atropine, especially in esotropes, homide, hometropine, or cyclopentolate. But this is a table which shows the age-appropriate cycloplegia. This is available on the AIOS website, so I'm not going to go into details, but just to tell you that in the presence of esotropia, atropine 1% ointment is required, no drops, because they will go in the patient's system and they may cause allergic reactions. Atropine 1% is the first choice in esotropes less than 5 years because it is necessary to eliminate the accommodative element totally. And the ointment is to be used in rice grain size 3 times a day, 3 days prior to when you're calling the patients. As I said, drops are avoided because of systemic absorption. What are the side effects of atropine ointment? You have to sensitize the parent about this, that there may be contact dermatitis, allergic conjunctivitis, keratitis, so on. Systemically, there can be dryness of secretions, fever, skin rash, etc. The side effects of hometropine are almost the same, but less severe. Now, cyclopentolate drops are a good option but they also have almost the same side effects. And please remember, tell the parents about these side effects. Otherwise, you will be getting a call sometime at an odd hour that my child is facing this problem and what do I do? Prescribing spectacles now. This is another chart which is again given by AIOS, and this tells you exactly how much and when you should be prescribing, in what condition. How to prescribe spectacles? After a complete assessment, you must give the appropriate correction, seeing the acceptance of the child. You can see this accommodative esotropia, how it gets corrected as soon as you put on the glasses, as the child puts on the glasses. Again here, if you're giving executive bifocals, in accommodative esotropia, remember to tell your optician that the line must bisect the pupil. There are certain special cases where you have to prescribe spectacles immediately as per the retinoscopy, even in less than 2 years of age, like pseudophakics or fakes. And in less than 2 years, give only for near correction. Later, you can give executive type. In Down syndrome, ROP, prescribe as early as 6 months. Intermittent XT, myopia correction as per the table. Overcorrection can be done up to minus 0.5 for more than 3 years. And in ET, hyperopia more than or equal to plus 1.5 diopters. Overcorrection is also possible. Bifocals must be given in high ACA by A ratio cases. There are some practical tips which I'd like to share with all of you. One thing is, don't keep your vision chart on till the child is seated and one eye is occluded. Reason, they memorize and they are very smart. Make sure the child's head is straight and he is not peeking over the trial frame. No prompting from parents. Make them sit in your waiting room if necessary. In amblyopia, please explain clearly. There's some disturbance going on. Someone is unmuted and someone is talking. In amblyopia, explain clearly to parents what needs to be done. This is just a small video showing my granddaughter getting her refraction done. You can see how troublesome she is. And most parents are like this. She's being extra troublesome because I'm a grandmother. Refraction in adults, this is a totally different scenario altogether because they are cooperative. They can read. They follow instructions themselves. So you don't have that much trouble in adults. But still, it can be challenging. Few pointers are always do a dilated retinoscopy. Whether the patient is emetropic, myopic, or hypermetropic. Please do not rely only on auto-ref readings, which most of our residents tend to do nowadays and the recent pass-outs. And get the feel of the patient. Believe me, if you can feel the patient, you are going to give him a correct refraction. And after a lot of experience, like I have had 43 years of experience, so your sixth sense guides your hand automatically to the right lens. In hyperopes, I never prescribe without fogging. Explain clearly that the refractive error and the strabismus are two entirely different entities, though related. And correction of squint is not correction of the refractive error. The same formula applies to kids. Emphasize that the spectacles need to be worn all the time, means all the time, and treat the associated amblyopia as required. The two cases, if I have time, I can go to them. This was a 10-year-old boy brought by his father in 2015. History of squinting right eye since age of 6 months after an attack of dengue fever. On examination, the uncorrected visual acuity right eye was 6/12, not improving. Left eye 6/6. After fogging, this is the refraction he got, +1 right eye, +0.5 left eye. And the XT was 35 degrees. A phenomenon was present. Hirschberg's was 75 prism diopters for near and distance, both. So I diagnosed him as right eye XT, 35 degrees with mild amblyopia. Advised occlusion, left eye 2 hours per day for 6 days in a week, followed by 1 rest day for 6 months. He improved to 6/6 partial right eye. Then I went ahead and did the surgery, and he's maintained, we put him on maintenance occlusion. There's a residual squint of 5 degrees, which I'm not worried about. I'm not bothering about it. I'll skip over this case because of lack of time. I acknowledge the AIS focus group for all the information and of course my patients. Thank you. Here's to a corona-free world.
Thank you, ma'am, for a very comprehensive talk. I would request now Dr. Biswajit to present his talk on squint evaluation made simple. Dr. Biswajit, please. Is Dr. Biswajit here?
I'm not seeing him actually.
Yeah. Then is Dr. Dipali Garg here?
I'll start my screen sharing.
Yeah. Please share screen. She'll be speaking on accommodative esotropia. Over to you, Dr. Dipali.
Yeah, sure. Thank you. So a very good morning to everyone, and I hope I'm audible and the slide is clear. as a first point?
Yes, you are audible.
Thank you so much.
Thank
So
you.
I'll be talking on accommodative esotropia, which is a very common entity and accounts for almost 50% of all ESO deviations that we see. And I'm sure as strabismologists and as general practitioners, this is a common finding in some of our patients. By definition, accommodative esotropia is a convergent deviation of the eyes associated with the accommodative effort necessary to overcome the blurred image caused by hypermetropia. We see two major types, one which is refractive, which is totally correctable by the hypermetropic correction, and one which is non-refractive, in which we see a near distance disparity. Traditionally, we see the near esotropia is more than the distance, accompanying a high AC by A ratio. And very rarely we have a hyco-accommodative type, which was described by Costin Bader long back with a remote near point of accommodation. Depending on the degree of control, it can be fully accommodative, whereby you have no residual esotropia once you've corrected the refractive error of the patient, or it could be partially accommodative, which is also called deteriorated or decompensated accommodative esotropia, in which partly the esotropia is corrected by the refractive correction and partly it is still residual. So let's look at the classic presentation. The onset is mainly between 1.5 to 3 years. Initially, the parents or the caregivers will say that we see that the child is squinting only when involved in near tasks. There's an associated hypermetropia, which is more than normal for age. And this esotropia is eliminated on controlling the accommodative demand. But I think we have this classic presentation, but this varies with each patient, and the prognosis is dependent on how early and how much of the refractive error management you've done. So it looks very straightforward, but often it is less than ideal with many glitches, and it's better to catch these patients while the esotropia is still intermittent. Now, we are often bombarded by questions, and I'm sure you all would be, that will my child always wear glasses? Will the glasses number reduce? Will it increase? Will my child always squint? Will he need surgery? And that is just to name a few. Let's look at some cases now. Here I have a 2.5-year-old child who presented to us with a right convergent squint to an alternating convergent squint with a left fixation preference. He was given a full refractive correction, which was done under atropine, and then started on occlusion for the fixation preference. At 6 months, we found him to be ortho for distance and near. The vision with Lee symbols was 3 by 3.8 in both eyes with good alternation. Stereopity tested with TNO was 120 seconds of an arc. So this is the patient with a full refractive correction. The second patient was a 9-year-old child with fully accommodative esotropia with treated left amblyopia. Now, he had a very interesting history. He had an onset of this ESO deviation noted by the parents at 3.5 years. And he was grossly undercorrected till 5.5 years, was given around 1.5 diopters in both eyes. And when I went through his papers, he was mainly refracted under Tropicacil. The left amblyopia was often treated and occlusion was given. At 5.5 years, because he still had residual ESO deviation, he was advised surgery for the residual amount. And he almost came to us right when he was advised surgery. And when we had seen this patient, he was already at least 7 years of age. He had a visual acuity of 6.9 on the right and 6.18 on the left. We still refracted him under atropine and found that he was grossly undercorrected. We prescribed him a +4 on the right and a +5 on the left, and he was given occlusion therapy as well. In 6 months, he was ortho for near and distance with a vision of 6.6 and 6.6 part. The stereoquity, however, remained to 40 seconds of an arc. So this is the patient as you see him for near and distance, and you can see that he is well controlled both for near and distance with his glasses. The third patient was a 6-year-old female child who had a high AC by A ratio. She was diagnosed at 4.5 years. The best corrected visual acuity was 6.6 part in both eyes. She was refracted under atropine where she was seen early, and she was ortho for distance with glasses. However, she wasn't checked for near and she had a residual near deviation. A high AC by A ratio was missed in this case. So we planned a repeat refraction first to rule out that she wasn't undercorrected and then switching over to bifocals if her augmentation of the distance correction did not correct her for near as well. So traditionally, she was put on executive bifocals with a line bisecting pupil, and she was ortho both for distance and near. The fourth patient was a 7-year-old male child with a partially accommodative esotropia with a high AC by E ratio. He complained of an inward deviation of both eyes noted by the parents, more for near. Glasses history was that he wore the glasses intermittently. The best corrected visual acuity was 6.6 in both eyes. There was a near distance disparity. He was given bifocals with executive bifocals with the line bisecting pupil. He still had a residual ESO with the bifocals. As you can see here, he was then taken up for surgery for the residual part, and we took him up for a bilateral medial rectus recession of 6 mm. Not only did this correct the residual ESO deviation, it also got him off the bifocals, and he was corrected for distance and near with the distance correction only. So to infer, children with accommodative esotropia do require a maximum hypermetropic correction, and I do believe in refraction under atropine, though it has been mentioned under 5 years of age, but I continue till even up to 10 years of age if there are refractive esotropes, especially in darkly pigmented eyes, whereas I've found that cyclopentolate doesn't give as good results as atropine. It is imperative to check alignment both for distance and near, check the AC by A ratio, check binocular function with the TNO test. If there is amblyopia, go for aggressive amblyopia therapy because that can be a confounding factor. And once the patient has decompensated or you have landed into a partially accommodative esotropia, it doesn't revert. Delayed treatment also precipitates deterioration. We cannot understate the importance of refraction. So repeat your refraction before you declare that the patient has gone on to becoming partially accommodative. A regular follow-up is a must. But there, our dilemma isn't solved. So can we really wean this child of glasses? And is surgery a quick fix? These are the two questions which still remain in our mind. Let's go through the literature. Now, RAP found that hypermetropia does reduce by 0.18 diopters per year in these patients as opposed to 0.22 in normal patients.
Please conclude.
I'll just take a minute. Accommodative esotropes behave differently, designed to remain more hypermetropic, and undercorrection by even 1 diopter can cause significant increase in the deviation, which was by a study in McEwen. Also, these patients are destined to remain wearing glasses full-time. 38 out of 39 adults with accommodative esotropia were still wearing glasses well into their adulthood. So spectacle wear does restore alignment, averts amblyopia and maintains stereopsis, but the glasses number, though it may reduce, not significantly by adolescence or early childhood, adulthood. However, the need for bifocals mostly is eliminated by 10 to 12 years. The weaning of glasses number attempted only with good alignment and binocularity, and it requires a very close follow-up. Surgery can be done for the non-accommodative component. It can be done for eliminating bifocal use in teenage. MR recession with or without Fadden is one option, or we can go in for augmented MR recession. To conclude, we need an early diagnosis, we need timely prescription, we need to maintain binocularity and be wary of all the confounding factors like amblyopia, inferior oblique overaction, high AC by A ratios, and an early onset. So I conclude with Park's line that present efforts should be more cautious and directed to a realistic, though unfortunately not more encouraging advice to affected individuals. Thank you.
Thank you, Dr. Dipali, on stressing different presentations of accommodative esotropia and telling their management. Now I would like to call Dr. Anirudh Singh. Dr. Anirudh, are you here? Please share your screen. He'll be speaking on early intervention in infantile esotropia, which is a preferred practice pattern nowadays. Is Dr. Anirudh there? Yeah.
Yeah, I'm there. Yeah, I'll just share the screen. Just a second. So I'll be speaking on the early intervention in infantile esotropia, as the previous speakers already stressed on a lot of factors, which I'll again be re-stressing in my talk. Early intervention, how early is early? Is it in adults? Is it teenage, when the child is looking for when the child has become almost an adult and is looking for a job or a marriage prospect? Or is it 3 to 4 years of age? Or 6 months to 2 years of age, or maybe even earlier than 6 months? We will just touch upon these things, that how early is early in infantile esotropia cases. So not to mention first the Claude Worth, who actually said that there is irreparable defect in fusion faculty. So there's no point in operating. But this concept was radically changed by Shavase in 1939, who actually said that fusion faculty is present, but gets impeded by the motor component. So that's why an early surgery or a surgery to correct this motor component is required. The Costin Bader is the person who's been credited with the first exclusive pediatric ophthalmology practice, and he was the one who in fact advocated early surgeries in all strabismus cases. And in fact, it was his student, M.M. Pass, who's known as the father of pediatric ophthalmology, who's advocated early surgery as early as less than 6 months, and all his research has been on this particular aspect. Prominent amongst them was by Lawrence et al., which actually said that there are interconnections between the right and the left ocular dominance columns. Now, these interconnections are present in the normal alignment, but in case you see a patient of strabismus, these interconnections are absent. They found this on research on these monkeys, and they found that in case this alignment, this motor alignment, if it is corrected in the first initial 60 days or maybe 2 to 3 months of the onset of the misalignment, these interconnections do develop. But in case you delay it beyond 2 months, the interconnections fail to develop. Again, prominent amongst them is this CEOS study, or the congenital esotropia observational study, which actually gave us a subset of patients on whom you can possibly do early surgery. And this comprised of infantile esotropia, which they said that it persists in almost 90% of the infants, especially those who have a large angle that is more than 20 degrees or 40 prism diopters, those who have a constant esotropia, the cases where the onset has been after 10 weeks of age and the refractive error has been less than 3 diopters. So this gave us a subset where we could possibly promulgate early surgery in these infantile esotropia cases. Again, a prominent study was one by Birch et al., which studied the natural history of infantile esotropia in the initial 6 months. They concluded that it is basically infants who present in the initial 2 to 4 months of age with constant esotropia of 40 prism diopters or greater. These are the candidates who are actually valid candidates for surgical treatment. And this early surgical alignment actually can promote development of coarse stereopsis and possibly even fine stereopsis if done even earlier, that is within 60 days of the onset of misalignment. So just to highlight my point, I'll just highlight 2 cases which are slightly contrasting. One is a 6-month-old child who presented with invert deviation of both eyes since birth, alternating. Refraction in fundus was normal. We labeled it as infantile esotropia. The plan, obviously, parents wanted to observe for some time, wait for some time, but we advocated the early surgery. And we went ahead with a minimally invasive small incision strabismus surgery. Just run a clip, a fast clip where we do a small keyhole incision in the fornix. I'll just run this video a little fast. So then we isolate the muscle, do a thorough tenectomy to isolate the muscle clearly, so that it's delineated, right? You can see up to the posterior extent. This step is important. So once this is done, we secure with a 6-0 white pill. This insert. Then measure depending on the amount of misalignment. And this thing is marked as to how much resection is being planned. Once that is marked, and you can see the muscle being reinserted, just run it quickly, and moment this is reinserted and reattached onto the sclera, it is secured with a single 6-0 white. So a very fast and a very cosmetically acceptable surgery even for the parents who are little skeptical in the beginning. So in a pre-operative, this is the same patient. So in case you find, obviously, you can see even on the first post-op day, the motor alignment is pretty good, and generally alignment is better. Parents are quite relieved, but the fact which is more important is that the stereopsis regains faster in children in whom you operate little early. Compare this now to the second case that I'll just show. This is a 6-year-old girl child, and where the parents said that the deviation was present since almost 3 to 4 months of age, but they had been moving from one surgeon to another surgeon, one doctor to another doctor, but they could not give the consent for an early surgery. So at the 6 years of age, finally, when they made up their mind and they came, as expected, the vision, as you can now see this right eye is almost straight and is dominating. The left eye is a non-dominating eye, and the child has a constant left eye squint. Now, if you see, actually the right eye, the vision as expected was 6/6, but the left eye was 4/60. Although refraction and fundus was normal, and this just to show how stereopsis is being tested by Randott and TNO. In this particular child, there was not even cross stereopsis or co-stereopsis. So we label this as an infantile esotropia with a strabismic amblyopia of the left eye. The first plan was to manage this amblyopia by patching the dominant eye. We did this for at least 3 to 4 months, and afterwards we went ahead with the minimally invasive strabismus surgery. And this is the picture of the same child after 8 months of the amblyopia management as well as the surgery. And now you can see that the vision in the right eye remains 6/6. It is normally aligned, but the left eye is improved from 4/60 to almost 6/12. But there has been no further improvement in the last 2 to 3 months.
Sit outside for 10 minutes.
And if you see, there is no fine stereopsis in this child. However, co-stereopsis had still been recorded in this particular child. So this is just to highlight that in case you delay the surgery beyond a certain age, there is very less likelihood of developing fine stereopsis, and child may still develop post-stereopsis if you operate earlier than 2 years of age. But if you go beyond that, there is a minimal chance of developing fine stereopsis. So to summarize, the timing of surgery in infantile esotropia should be done definitely before 2 years of age, preferably between 6 months and 2 years of age. And ideally, it should be done within 60 days of the onset of strabismus, which comes to somewhere between 4 to 6 months of age. So early surgery gives better binocular vision and stereopsis. And obviously, we treat amblyopia before the surgical correction. So the take-home message is operate early, that is within 4 to 6 months. And not to forget, a thorough refraction should always be done with atropine in such children. Because sometimes you may get a child with onset of deviation at 3 months of age or 4 months of age, and he may even turn out to be accommodative esotropia. So a thorough refraction with atropine, as pointed out even by the previous speaker, is definitely a must and should never be missed. Thank you.
Thank you, Dr. Anirudh, for a very extensive talk. I would invite our next speaker, Dr. Amit Gupta. Dr. Amit, please share your screen.
In the meantime, can I ask one query, sir, from Dr. Anirudh? Sir, what
Yes,
do
sir.
you recommend? Because studies say that if we intervene at the age of 6 months or within 1 year or so, at the later age, overcorrection is very common, and repeat surgeries are indicated. There are studies. So what?
Yes, sir. Yeah, yes, ma'am. That is true. That has to be explained to each and every parent. Every time you are counseling the parent, that whenever you go in for an early surgery, you have to tell them that there is a definite chance of a resurgery required, at least maybe 20 to 30% in all the cases. However, this is a very small price to pay for binocularity, which will remain throughout life. So this particular point has to be stressed, what I feel at every point of counseling whenever you are doing it. So that is the main issue in this.
And one more issue I want to recommend from Dr. Subhash, sir. Sir, one more. MICS, you told yesterday talk that MICS is quite pretty difficult in younger children. And
Yeah.
Sir, yeah. So, sir.
So basic take-home message is this MICS minimally invasive squint surgery is ideally done from age of say 14 to 40 years of age, because in children's due to lot of tenant tissue, it is not advisable. The originator of this minimally invasive squint surgery, Dr. Mozon, has clarified that it is difficult. So ideal candidates for minimally invasive surgery are 14 to 40 years of age. So if Dr. Anirudh has done it,
it's a pretty difficult young
yeah,
child.
so it is
very
classic. It is not a classical indication, but
thank you, sir. Thank you, Dr. Anirudh, and thank you, Dr. Subhash, sir.
I think we can discuss the questions in the chat box as we're running.
Dr. Reena, let there be, because basic aim is to have interactive session. So who wants to ask the question, one or two questions? You can.
Yeah, early surgery will prevent DVDs and inferior oblique overaction in infantile esotropias, no? So it's better to do early surgery.
I would like to add that exotropic drifts are far more common, 3 times more common than residual esotropia in infantile ESO. And the main problem that I have faced with early surgery is an exotropic drift. And as it is, even if we do early surgery, it will not preclude the appearance of DVD, because DVD will appear at a later age because of late development of the virgin centers. So,
but it is less.
Yes. So
yeah,
we have seen that happening, and I've always cautioned my patients that they would require a minimum of 2 surgeries for correction of infantile ESO, even though you get perfect results in the first surgery, because you cannot account for either residual ESO or an exotropic drift at a later age.
Yeah.
That's been my experience.
Good stereopsis is a price to pay for a small consecutive exo later. So yes, you have to explain that there could be a consecutive exo, but it's better to do an early surgery.
Yes, ma'am, I agree with an early surgery. Thank you.
I think if we operate
all the problems that we anticipate,
the ideal time. But what I've seen that if you take up these patients and repeated examinations are missed, and if you are sure about your readings and you get something around 8 prism diopters of ESO, which is residual, that's the optimal result, because then we are able to give them steropsis also.
Yeah. Correct. Ideal age may be around 1 year.
Any time between, let us say, 8 months to 1 year.
Yes,
around. That's right.
That is the time that we become sure of the deviation. The earliest that I have operated is a 9-month-old child. And you see, Dipali was very right that there might be problems and there might be a probability of a second surgery. There may be a consecutive exo. All those problems are there, but that does not deter us from providing those in the very essential periods of development of binocularity to not correct the deviation.
I agree, ma'am. Doing
a second surgery, I think, is required, because these patients, even if they don't have a residual ESO, they will definitely come with inferior oblique overaction or DVD, which is picked up in the second year only.
Not may come.
Yeah, most of the times they do come. Yeah.
Dr. Vinita.
Yes, sir.
I think the worst problem which we face in such cases is that many ophthalmologists say, don't operate early, let the child grow older.
Yes.
So this is the point that we must emphasize with general ophthalmologists, that the child has to be operated before 1 year as early as possible. That must be propagated.
We have to convince.
In fact, ma'am, as Dr. Goyal is saying, most general ophthalmologists say, don't do anything. As the child grows up, the squint will disappear, which we all know is not going to happen. And so, general ophthalmologists have to be sensitized to this fact that the squint doesn't go away. It has to be treated.
Both it is on the same, so that's why.
I think our next topic is also for general ophthalmologists, the refraction prescription in children, which is also one topic which I think they should know, how to prescribe glasses in children.
Let the video be off.
Very important and most neglected.
Exactly.
I'm just listening to them. I'm not talking.
Can we proceed to Dr. Amit for the talk?
Yeah.
This is audio answer. This distribution. So the samples audio is on.
Is Dr. Amit there?
I have switched this far. That's okay, no? Yes. But they're able to hear more. Yeah, when I turn the video on, they will be able to hear. Viewing is now what we are talking. Will be.
Dr. Amit, are you there?
Okay. They would have muted me there, no? Yes,
Dr. Reena, you can call the next speaker if he's not there.
Yes, sir. So I would request Dr. Anupam. She's going to speak on pattern deviations. Dr. Anupam, please share your screen.
Minutes after that, my talk. Then I switch the video on English.
Good afternoon, one and all. It's my slides are visible.
Yes, yes.
Before I come to management of pattern deviation, I would like to talk about historical aspect. Duane was the first one who introduced a pattern deviation, concept of pattern deviation of strabismus in the case of bilateral superior-oblique palsy in 1897. Then Albert suggested the terms A and B pattern in 1957, and Nabs finally elaborated the causes and treatment of AB pattern in 1959. There is no single best geological factor which can explain AB pattern, and various schools of thought have evolved over the years. According to horizontal school of thought by Urest, horizontal recti are responsible for pattern deviation. According to Brown, vertical recti are responsible for pattern deviation, and the most accepted one are given by Knapp, that is oblique muscle oblique muscles are responsible for pattern deviation. The other factors which can contribute to pattern deviation can be craniofacial anomalies, heterotropia of muscle pulleys, anomalous insertion of muscles, sagittalization of oblique muscle insertion, sensory deprivation, and poor binocular function. And prevalence varies from 12.5% to 50% of strabismus population, and approximately a pattern deviation is seen in some or other form in each one patient in each of 5 patients of strabismus. And V pattern esotropia being the most common, followed by A-iso, then V-exo, and A-exotropia is the least. And most commonly, pattern deviation are seen with infantile deviation and paralytic strabismus. The types can be V pattern, A pattern, X, lambda, Y, T, and diamond pattern. And clinically, these patients can present with complaints of asthenopia, diplopia, and abnormal head posture. When we come to clinical workup, it should always comprise of proper history and history of diplopia, asthenopia, abnormal head posture, lid abnormalities, abnormal extraocular movements, and occupational need for binocular vision, because this is the most important part and for which we need to do surgery, and this point should be kept in mind in each and every case. When we come to motor evaluation, alternate prism bar covers test should be done with head erect in primary position with accommodative target at 6 meters. Then head should be tilted down so that eye is in 25 up gaze of 25 degrees at least, and then tilted back to achieve 25 to 35 degrees of down gaze. And in each of these positions, the patient should be fixating at an accommodative target at 6 meters. Further, AC by ratio should always be checked to rule out any pseudo AV pattern. Then we assess the extraocular movements in all 9 gazes and head tilts to rule out underaction and overaction of any of the extraocular muscle. And one should always look for subjective and objective torsion in case we are suspecting oblique muscle overaction or underaction, and followed by sensory evaluation. Indications of surgery are deviation greater than 15 prism diopter, interfering with the development of binocularity, leading to abnormal head posture and asthenopia. When we come to treatment depends upon the underlying etiology. If horizontal recti are the culprits, we plan for vertical transposition of horizontal recti with or without slanting of muscle insertions. Then weakening of obliques depending upon the overaction of the oblique muscle. And then if any of these procedures are not feasible, we can plan for horizontal transposition of vertical recti. Coming to treatment of V pattern, MR recession only itself corrects without any vertical transposition, itself corrects 10 prism diopter V pattern. If we combine MR recession with half tendon infra placement, it corrects up to 25 prism diopter of V pattern. Bilateral IU recession adds up to 20 prism diopter of pattern. And Harada Ito procedure is the one procedure which can be done in rare cases with V pattern more than 20 or so, and with fundus significant extorsion without any clinically significant SO overaction, sorry, underaction. So treatment of V pattern exotropia comprises of LR recession with half tendon supraplacement, which can correct up to 15% after V pattern, and bilateral IO recession adds up to 20% after correction. When we come to A pattern esotropia, MR recession with supraplacement of half tendon corrects up to 15, and bilateral PTSO is done for A pattern up to 20% after without any significant fundus in cyclotorsion and with superior oblique overaction. And bilateral esodenotomy can be done for pattern deviation more than 20% after with significant superior oblique overaction and fundus in cyclotorsion. And when we come to treatment of A exotropia, LR recession with half tendon transposition corrects up to 15. If we combine LR recession and tendon transposition with posterior slanting of inferior fibers, it corrects up to 25% after 20 or 25. Then bilateral PTS and esotenotomy can be done as in case of A pattern ESO. This is a 9-gauge photograph of a patient having V pattern esotropia, and the patient was operated by bilateral MR recession and bilateral IU recession, and V pattern was taken care of. This is a case of A pattern exotropia. A pattern was within 20% after, and patient was having superior oblique overaction, but though no fundus intorsion, and the procedure which were done was bilateral LR recession 9 to 9 and bilateral PTSA. Here we can see there was no significant change in the torsion in preoperative and postoperative period. This is a preoperative 9-gauge photograph of A pattern exo. The A pattern was more than 25% after, and bilateral LR recession with bilateral superior oblique nasal renotomy was done, and here we can see the A pattern was corrected. And in preoperative photograph of fundus, there was significant fundus intorsion, right more than left, and this intorsion was corrected postoperative. When we come to complication, patient can have diplopia in postop period, which can lead to head posture. Sometimes preoperative during doing preoperative workup, we can fail to diagnose the or treat the oblique muscle overaction. And sometimes over a postoperative period, patient can develop a superior oblique overaction or inferior oblique overaction, which was not present preoperatively. And anterior segment ischemia can be a risk when we are operating, when we are planning to operate more than 2 recti at a time for 1 eye. So to conclude, each and every case of pattern deviation should be assessed preoperatively for undercorrection or for any other underlying etiology of pattern deviation, and plan of the surgery should be according to the underlying cause and need of the occupational need of the patient, and goal should be to correct pattern deviation as well as horizontal deviation and to enlarge the binocular field of binocular vision, binocular single vision, and one should avoid asymmetrical weakening of oblique, especially superior oblique, to avoid postoperative decay. Thank you.
Thank you, Dr. Anupam. Do we have any questions? Then I would invite Dr. Shreya to please invite the next speaker. Dr. Shreya.
Dr. Anupam, I would like to ask something. In cases of amblyopes, when you have inferior oblique overactions only in one eye, do you go ahead and operate a single inferior oblique, or do you go in for asymmetric?
See, if there is any chance of taking a fixation with the amblyoptic eye, we should not operate single eye inferior oblique. It should be asymmetric. If there is amblyopia is dense and there is no chance of taking eye, we can go for one eye surgery. And
right.
The cutoff limit should be within less than 660. What I feel.
Okay.
In fact, many people recommend that you operate both inferior obliques. But
Yes,
I find that when I operate single, I'm doing single inferior oblique if there is an option. Invariably, we find post-operatively that there is an overaction of the other inferior oblique also in due course of time, and then I tackle that at a later stage instead of doing all two together.
Okay. Okay. Thank you, sir. Thank you, ma'am.
I have a question. So Dr. Subhash sir, how often do you go for nasal transposition of the inferior oblique muscle, which nowadays we are going on? And basically, I do it for superior, very severe inferior oblique overactions like post-SO palsy, which we get. But any experience for doing them with primary inferior oblique overaction cases as well?
Dr. Anupam?
Yes, sir, it can be done depending upon the amount of overaction, because ANTIO, I have seen only 1 or 2 cases, but the results of ATIO is very good, even if it is primary. As far as ATIO is concerned, torsional effects come into play.
And +4.
Nasal transposition, there is concern of torsional component as well. So ATIO is good enough for a significant inferior oblique overaction, what I feel, even if it is primary one.
Any elevation syndrome with ATIO anyone has come across?
Yeah, it is very common.
Anti-elevation.
Basically, personally, I go for hangback recession of the inferior oblique.
Sir is very good at that.
So, do anyone have experience about partial tenotomy of the horizontal recta if there is a ortho in the primary position and a pattern exo in down gaze? Patient will have difficulty in reading. Can you do partial tenotomy?
Yes, ma'am, the results are quite good.
Yeah.
I don't think it is recommended really, but if you are doing it, it is different.
Okay. A primary position ortho and down gaze a pattern exo. Partial tenotomy will be good, I think.
Any more questions? Dr. Shreya, please invite the next speaker. Dr. Shreya Shah.
I think ma'am is not there.
Dr. Pali, can you please invite the next speaker?
I'm the next speaker.
So our next speaker is Dr. Aditya Sethi, and he'll be speaking on examination of squint in a preverbal child. It's my way or the highway. Right, Dr. Sethi?
Thank you, ma'am. Thank you, panel. And thank you, DOS, for giving me this opportunity. Can you see my slides?
Yes.
Okay, so I'll continue. So we know examination.
Are you Dr. Sethi's son, by
Yes.
the way?
Yes, sir. Yes, sir. I'm Dr. Arun Sethi's son. Yeah. So we know examination for squint in a child can be quite a struggle, and often the statement of intent is my way or the highway. It's very important to get the examination right, because we are always facing the threat of amblyopia and permanent vision loss as the child grows. So it's best to get it done. Before we go ahead with any examination, we have to establish some goals. And these goals are: establish a cause for the strabismus, assess the binocular sensory status, measure the deviation, and diagnose amblyopia. So every examination starts with a good history. So first thing we have to ask is the squint intermittent or constant? Or if there's any associated head posture, if there is, there's always a possibility of fusion. If there's onset of strabismus has been recent, then often there's a possibility of fusion. Noting the head posture is very important. Again, in cases of acquired strabismus, look for any neurological or systemic disease. When the patient complains of double vision or diplopia, cause is usually acquired. Birth and developmental history is very important, because in low birth weight patients, esotropia is often associated, and delivery complications like use of vacuum or forceps can lead to esopalsies. Health of a child, if is low, then syndromes and any CVI should be suspected. And developmental milestone, if there's a delay, then you can often have unpredictable results. Ask for a good family history, because often squint does run in the family, and an early intervention may be the way to go in these cases. Previous treatment history and compliance is very, very important. History of glasses, contact lenses, patching, frosted glasses, penalization, prisms, orthoptic exercises, including anti-suppression exercises, and previous surgery. That is the old record scrutiny is of utmost value. The age-old photo scan, which is comparable to MRI scan in neuro-ophthalmology, is very important. Like in this case with exotropia, when we did the photo scan, we saw that when the child was a young toddler, they had an esotropia. And as the child grew, there was somewhere in between orthotropia was there, achieved by some surgery, which was not mentioned before the photo scan. And then later, the child had consecutive exotropia. So we know the child has short attention span, needs comfort and reassurance in your OPD. So the environment at the OPD has to be friendly. And we also know that doesn't follow instructions to the dot, and pre-verbal children can't comprehend instructions. So examination OPD has to be extra comfortable, extra child-friendly and reassuring, because a small modification of our OPD can go a mile in examination. And our equipment is super expensive, some nice nursery rhymes, some nice toys, prisms, and Leah symbols. Examination starts with observation, and as soon as the child walks in and when the child sits on the chair, notice the head posture and the inspection of the eyes. Evaluation of sensory system has to be done after that, then visual acuity estimation, refraction, evaluation of ocular alignment, cycloplegic refraction, and finally the fundus examination. Always remember you're a doctor first and then an ophthalmologist. So don't just notice the eyes, like in this case of bilateral congenital Brown syndrome. If you examine the child as a whole, you note that there's a syndrome involved. Inspection of lids and lid fissure, globes, ocular alignment, facial asymmetry in cases of esopalsy, nystagmus in pupils is utmost important. Head postures like face turn, head tilt, and chin positioning is very important to be noted. Sensory system examination. Goals of examination include to establish diplopia, suppression, presence and severity of amblyopia, retinal correspondence, and stereopsis. And we know sensory examination has three parts: fusion, retinal correspondence, and stereopsis. So tests for suppression of fusion that we generally do are Worth 4-dot test for both distance and near. We have the 4-prism base out test, which is very simple to do. And we have the Baggellani striatic test. Test for stereopsis, which is an appreciation of depth due to horizontal disparity between stimulated retinal points in the Panops area, include the Titter's fly, Randot, and TNO. And this is a table which has shown the different disparities of which could be tested with various tests available. Motor examination includes motor ocular motility and alignment. We have to check the ductions, the versions, the vergence. And when it comes to alignment, the Hirschberg test, which is very popular with residents, is the age-old and gives us a good idea about the deviation amount. The modified Kimsey test, in which the patient fixates light placed with a prism in front of the fixating eye, observes light reflex in the deviating eye, and as we increase the prism power, the light reflex is centered. This gives us a good idea and good value of the deviation. The cover test, which is done after sensory exam, can be done by the occluder, hand, palm, or thumb. But the most important question before you do a cover test is, what does the patient wear? You have to give full correction of glasses with or without bifocals or contact lenses before you do this test. Where does the patient focus? Always at an accommodative target. It could be done for distance or near. Don't focus on a torchlight or fixating light. In cover test, we cover one eye and watch out for the other eye movement. If there is a movement, then we have to note which direction that happens, and that's the tropia or manifest squint. We have to keep doing this till we are sure about the result. What's the eye that moved? Does it hold fixation, and for how long? This has to be noted as well. In case of no movement, repeat the test and try again. If there's still no movement, then you run to the next test, which is the uncovered test, in which we watch the uncovered eye. And if there's movement, we're looking at phoria or latent squint. Repeat till you're sure. Alternate cover test is when we alternately move from eye to eye, reminding the patient to fixate at a distant accommodating target. And this estimates the total squint, like shown in this video where we've done for distance, by alternating our cover from one to the other and looking for movement and fixation. Same, this is another video we're showing for near accommodative target. Prism cover test is a very useful test in measuring deviation, in which we simultaneously use the prism and cover test for manifest, and when we do alternate between the two eyes for total. The endpoint is when there is no movement, reversal, or redress. Some special situations do exist, like DVD nystagmus and manifest latent nystagmus. And some limitations are there where patient can be highly uncooperative because the child is having a little bad day, or vision is very poor in both the eyes. But don't forget vision assessment, anterior segment examination, cycloplegic refraction, fundus examination before you draw a conclusion, because often there can be something else lurking. Thank you.
Thank you, Dr. Aditya. That was a very comprehensive talk. And I do agree that examination of pre-verbal children is always a challenge and requires multiple visits. And because each time I think you gain a little confidence in from the child in examining the child, and all your armamentarium was very good and very much needed.
Good afternoon, everyone. I'm sorry to join a little late, too late. Can I add 1 or 2 points in your presentation? Can I add? Am I audible?
Yeah, ma'am.
Yes.
Yeah, I was just saying that when you examine children, the first and foremost thing is always follow 3.5 years rule. So below 3.5 years, baby should be on the lap of mother only. That's the first rule of examination of pediatric patient. That always helps. The second is multiple toys in your clinic. Child cannot be attentive more than a minute. So you keep only 4-5 toys, it's okay, but keep on changing 4-5 toys in order to get the attention of child. Not only just fixes and target, the attention of child is a most important thing in the examination. And especially when you examine strabismus patients for children, then there cannot be a fixed rule that after sensory only motor you do or only motor you do first. It can be totally dependent on the thing. So as Dr. Dipali said, confidence gaining is at most important. Thank you.
Thank you, ma'am.
I wanted to ask, we were discussing about early surgery and now we're discussing about evaluation in a pre-verbal child. So when we're going in for a surgery in less than 1 year child, do you base your measurements on the Hirschberg, or are you able to do PBCTs for such children in infantile ezodes?
I think
PBCT a little bit.
You do surgery till you're sure of the measurement. So I think Hirschberg would not be the right thing. So till you get a couple of readings and your reliable readings, I don't think you should rush for himself.
Do you get reliable readings in 6-8 month old children in PBCTs?
Nowadays, there is one application with the photograph only. You can just measure Hirschberg's and photographic evaluation. So there is some equation. I have forgotten the name, but there is one equation. So you just take the photograph of children looking at distant and near and then count accordingly. That is based on the Hirschberg's test.
In fact, surgery is important at this age. So even if we err on the wrong side, doesn't matter. We would correct most of the squint deviation, and if residual or overcorrect can be taken care at a later age of 4, 5, 6 years. At least binocular vision would have started developing at 1 year of age.
So sir, we can go in for a bilateral 4 mm or 5 mm recessions because these deviations are invariably very large.
Yeah.
I think I agree with Dr. Goel that one thing is that we want to give these children early steropsis. So naturally we have to take them early, right?
Yeah.
But the other thing is that it's a challenge to measure cover test in these children because usually they don't cooperate. So I usually repeat 2-3 examinations in every visit. And if the children don't cooperate for cover test and I go for modified Krimsky test, I think it's quite accurate.
Quite
Close
helps, yeah.
accurate. And you can always correct these children.
Yeah. Can I just make a point?
Yeah, please. Sir, please.
It's very important that in pre-verbal children, you do not make decision about what muscle to operate, how much to operate on day one. Because quick position may change in these children depending on their attention span and depending on their gradient of attention. So it's important to call these children back a week later or 10 days later or day and reevaluate, and then only make decision about which muscle to operate, much to operate.
That's the point agreed upon.
At least 2 to 3 visits, yeah.
Yeah, minimum 3 visits.
Sometimes I've even told the parents to make small videos and share, and especially in cases with suspected abduction deficits where you're getting a pseudo abduction deficit in infantile ezos because of cross fixation. So I've asked the parents to patch one eye or, distract the child and show the range of movements on a small video. Sometimes the child cooperates at home and doesn't cooperate in the clinic.
See, before surgery in the infantile esotrope, do you all give alternate patching, at least for some time?
I do.
I do.
Yeah.
And I think we should also keep this in mind that there is a spontaneous improvement also. So sometimes these children, they present before 4 months, 4 to 5 months, there are cases where you can see spontaneous improvement.
It can, yeah, well known.
Watch them also for at least 4 to 5 weeks, how they're going. The angle is variable or it's constant.
Yeah,
especially children who have smaller angles, less than 30 prism diopters. So that's quite common.
I'm in my examination chamber and we talk about comfort. So a little bit, you can just make some.
Yeah, nice.
Oh, this is lovely.
You can get some things around, and I think it's
Very nice. Could go to the next talk.
Yeah.
Thank you.
Dr. Reena, would you be calling the next speaker?
Yeah, I would ask Dr. Shreya to invite the next speakers.
Yes,
please, Dr. Shreya.
Yeah, the next speaker is, everybody knows him and he has invented something. Dr. Santhan Gopal sir from Bangalore. He would speak on amblyopia treatment with orthoped. And I would tell that I have already purchased that. So let's see.
Okay, am I audible?
Yes.
Clearly, sir.
Good. Can you see me now?
Yes, sir. Yes, sir.
Share the screen. Okay, just one second. I'm going to talk about my method of treatment.
You are visible on 2 screens, in fact, Dr. Santhan Gopal.
Oh, 2 screens?
Yeah.
Are you using sir, are you having diplopia?
Now, are you seeing 1 screen or 2 screens? Okay. Okay. Shall I start? Can you hear me?
Yes.
Yeah.
No, the other one has your photo only, so it's okay.
Okay, I'm going to talk about magnocellular stimulator, which I have designed. And till now, I have treated more than 115 patients. And as I speak, there are still about 2 patients sitting in my clinic and doing the exercises. Next one. Now, orthoptic or magnocellular stimulator. I use magnocellular stimulator. You want to know why I use this to treat amblyopia? I need about 20 hours to tell you. But I have 7 minutes to explain to you. And therefore, I don't have much time to tell you about why it works, how it works. But I'll just show you why, how to use the instrument and how to fix the instrument. Now, using this instrument in patients between 6 and 50 years of age, 50 years, mind you, not 5, 6 and 50 years of age, we have been followed up for more than 6 months with amblyopia suppression and loss of binocular vision, and they all have regained, about 98% have regained good stereopsis, good binocular vision, and good monocular visual acuity after exercise on this instrument, which has never been reported in the past. Many of them regained 40 seconds of stereopsis within about 10 days. Now the instrument has 3 rows of light, LED light, and central one is red in color. I'm actually designing one for pre-verbal children based on some important facts about catching the attention of pre-verbal children that will be available in the market soon. The lights come on for 300 milliseconds and off for 300 milliseconds. The patient has to fixate on the lights which come on and have to point out with a laser pointer. Since there is a laser pointer involved, we cannot use this in pre-verbal children. However, or even for that matter, in children with cerebral palsy. The patient is seated at a distance about a meter from the machine, and the procedure is conducted for 30 minutes with both the eyes open. This is how the machine looks. And next one. And I'll show you a video of how it is, play the video. Yeah, how it is used by the patient. It does not require a lot of effort on the part of the patient or understanding. See, if one 5-year-old child is doing this, where it's pointing out the light which comes on with a laser pointer. Now, why laser pointer and why the light comes on is because the hand area in the brain is very close to the frontal eye field area. Whenever the hand area is stimulated, the frontal eye field area gets stimulated. Or whenever the frontal eye field area is stimulated, the hand area gets stimulated. And therefore, the two are very closely interacting with each other all the time. So if the child points out this with laser pointer, the hand-eye coordination improves significantly. That's how I use in one part of the exercise, which is called as improving the covert attention. We use what is called as laser pointer. It is called overt attention because the eye moves, and the surgeon can see the eye moving, and also the patient moves the hand and points out the light. So this is called as overt attention. This is one part of the attention stimulating mechanism. And the next part of attention stimulating mechanism is what is called as covert attention, where the patient's attention is fixed to the center of the light and the patient does not move the eye, but all the peripheral lights keep moving. And when the peripheral lights keep moving, the patient starts counting the peripheral lights with the amblyopic eye 30 to 40 times. About 300 to 400 times. Now, during the time, the patient is fixating all the time on the central red light, but these peripheral lights are moving, and the patient fixates on the peripheral lights and counts them about 400 to 500 times with the amblyopic eye. This is called as covert attention, where the attention mechanism is directed to the peripheral lights, but the eye does not move, and the patient is constantly fixating on the central red light. And this covert attention mechanism also stimulates the, you can see the girl is doing the exercise. This also stimulates the occipital cortex. And when both the covert and overt attention are stimulated in the occipital cortex, over a period of time, when they do the exercise, the vision definitely improves in these patients. Now, if you look at my results of over 100 patients, we initially tried to compare the anisometropic amblyopia and strabismic amblyopia because our feeling was the anisometropic amblyopia responds better than strabismic amblyopia. Then we realized that there's not much of a difference between the two. Binocular vision representation was pretty much there, 0 in both the groups, and the vision was pretty much the same in strabismic amblyopia and in anisometropic. And you can see here binocular single vision with red and green glasses after treatment, which was 0 before, was 100% in anisometropic and 86% in strabismic amblyopia. 86 because they needed some surgery, which they refused to do because they were quite happy with whatever cosmetic appearance which was there. So binocular vision regained equally well in both, and the gender of participants refractive error are pretty much the same. Between strabismic and anisometropic amblyopia, we did not find any difference in terms of improvement of vision, in terms of improvement of binocularity, or in terms of improvement of stereopsis. So they pretty much respond equally well to treatment. You can see that 0 and 14%. Next one. These are all the statistical analysis for you to know initial visual acuity, and go back one more. Initial visual acuity in strabismic and anisometropic amblyopia was 0.493 plus or minus 482, and this is the logMAR visual acuity I'm talking about. Next one. After the treatment, you can see the visual acuity is significant improvement in both 0.07 and 0.08 in both the amblyopias. This happens within about 2 weeks. Now you may be surprised, I may be wondering what is this fellow talking, magic or some kind of voodoo magic he is doing, but it is a fact. Next one. I cannot explain why it works, but it works. The initial stereopsis in all these patients was 0, but 0 is actually better stereopsis. So statistically speaking, you couldn't put the number as 0. Initial stereopsis was lowest possible, that is 3000. After treatment, you can see that the stereopsis improves 45.4 and 216 in strabismic. That is because in strabismic, 2 patients brought down the results a little bit less. Next one. So mean refractive error pretty much the same in both the groups. Next one. Next one. So mean refractive error is pretty much the same. Next one. And you can see the stereopsis improves in all these children. Monocular visual acuity improves in all these children, and binocular vision improves on all these patients from age 5 to 55. Now the question to be asked, why the instrument works so fast and why it works so rapidly, and what is the secret behind it? It's very simple, magnocellular stimulator. Now when you stimulate magnocellular cells or the peripheral retinal receptors by a strong stimulus, the brain captures this first in the parietal lobe more than in the occipital lobe. It goes to occipital lobe via force C alpha, it goes to the parietal lobe, and in the parietal lobe, it captures more. And from the parietal lobe, the top-down impulses, what is called as the impulses coming back from the parietal lobe to the occipital lobe, come back to occipital lobe and stimulate the foveal area, because whenever a stimulus is presented to the peripheral retinal receptors strong enough to stimulate a saccadic movement, then the saccadic movement happens because of stimulation from the parietal lobe to the frontal lobe and from stimulation of parietal lobe to the occipital lobe. Now, during this saccadic movement, the intervening area between the peripheral retina and the fovea is suppressed by the brain, and only 2 points are stimulated. There's peripheral retina and fovea. And when you repeatedly stimulate the peripheral retinal cells, the fovea gets automatically stimulated repeatedly, and the eye moves to take a fixation. And this movement of the eye is only possible because of foveo-cortical fidelity, which happens in the parietal lobe. The sensory motor integration is very essential for this thing to work. And this sensory motor integration happens at parietal lobe, which also has saccadic generation center. So when the attention mechanism is stimulated by the peripheral retinal stimulation, see, the magnocellular cells stimulate the attention of the fovea, and they say, okay, look, guy, there is somebody going on here, I don't know what it is, why don't you take a look? And the eye moves to take a fixation. When the eye moves to take a fixation, the fovea is automatically stimulated because the saccadic movements stimulate the peripheral retinal point and the fovea. This is the principle we use in this instrument, and it has never been used in the past ever in the treatment of amblyopia. We have been patching the eyes for over 900 years, and patching works. Yes, the answer to patching works because the eye still moves. When you patch the normal eye and make the patient fixate with the amblyopic eye, the eye receives many of the peripheral stimuli, which makes the eye move. That is what improves the vision. Nothing to do with the bottom-up impulses which go through the suppression at the level 4C beta in the occipital cortex, whereas the top-down impulses come beyond the suppression point, and therefore the vision improves rapidly, and therefore this works extremely well. And the article has been presented in the IJO in the November issue. Thank you very much.
Is there some basis of after images in this?
Nothing to do with after images.
Nothing to do with after. It is
nothing
just,
to do with after images. They are real images.
No, real images are all right. But then since we get after images after the initial stimulus, which also keeps stimulating the fovea time and again.
I explained to you that whenever the reflex see, there are many saccadic eye movements. One of the most important eye movement is reflex saccadic eye movement. Whenever a peripheral stimulus comes and whenever a stimulus is presented to the peripheral retina suddenly, that's called as the eye reflexive saccade. This is called as a reflexive saccade. This is also called as the prosaccade. Whenever a prosaccade happens, two things happen. One, the foveal area is stimulated, and two, the peripheral retina is stimulated. Number three, frontal eye field area is stimulated, and number four, the occipital cortex foveal area is stimulated. All these points are immediately stimulated whenever you present a strong stimulus to the peripheral retina. The top-down impulses coming from the parietal area to the occipital cortex level 4C alpha. That's where the P cells end in 4C alpha, M cells end in 4C beta. From there, from 4C alpha, the P cells end in 4C alpha and they go to the temporal cortex. And that takes time because there are four parallel visual impulses going from the occipital cortex to the temporal cortex, like the size, the shape, the texture, and the color. These are the four things. They go separately in the occipital cortex to the temporal cortex, where the final computation is done by the temporal cortex. So therefore, the occipital cortex is called as a feed-forward area. It just feeds the impulses to the higher centers. Whereas the parietal lobe coming down, the top-down impulses are called as image facilitating impulses. That is, they come down to the occipital cortex and discharge onto the P cells beyond the suppression. So therefore, they are not bothered about what suppression is there in the occipital cortex. It works because it works beyond the suppression in the synapses.
What is
These
the cost?
top-down impulses.
Cost. Dr. Santhan, what is the cost of this?
Cost is about 1.1 to 1.3 lakhs, depending on where you are.
What is the earliest stage you can use?
So the duration of treatment, like, do you see any recurrence once we?
Yeah, once we stop it. Yeah.
Okay. After, while I started the treatment, a few patients had about 2 weeks of treatment, and because of COVID, they never came back for 3 months. And then they came back after 3 months, and there was no deterioration.
Okay.
They maintained. And my follow-up has been for many patients for over a year of stopping treatment. I've stopped the treatment and they are fine. Nothing wrong. I think there is a problem in amblyopia is that the top-down impulses, which are called as the beta impulses or beta oscillations, if the beta oscillations come to the occipital cortex before the gamma oscillations start, about 0.1 seconds before the gamma oscillations start, they facilitate the gamma oscillations. In amblyopia, there is a desynchronization between the beta and the gamma oscillations between parietal lobe and the occipital lobe, and therefore there is a problem due to attention deficit. Amblyopia essentially can be considered as an attention deficit disorder like any other attention deficit disorder. Many children, they are quite happy because their handwriting improves. We have recorded one child with cerebral palsy who could not even hold anything, pen, can write now his name with his left hand. That's the beauty of this instrument, that it is wonderful instrument for treating cerebral palsy. But only thing I need is EEG in all these patients before starting to prove that beyond reasonable doubt, yes, the beta oscillations from the parietal lobe do come before the gamma oscillations in the occipital cortex.
Dr.
It works.
See, this is a very interesting instrument and a very interesting phenomenon that you have been telling us about, I think, for the last about 3 years, maybe.
2 years.
2 years.
Yeah.
Okay. And you have had a fairly good experience with it. And but I wanted to know, first of all, how can we get the instrument?
Write to me.
Okay.
Just write
Sir,
to
it's
me.
it's a great innovation. We congratulate you. We are all happy. It's a great innovation.
Like, we could try, we could have some multicentric trials with this instrument.
Yes.
We could plan that.
Yes.
Yes,
certainly I am trying to
It
organize
sounds multicentric trial when you get the instrument from.
Can you gift me one, Dr. Santhan?
By default thing.
Shreya is already, will get one in about 10 days time. So she can tell you more about it. But the few people I have given to already, they have written to me saying it works wonders in many patients. There was one patient who was not recruited for army due to slight difference in vision. And finally, after treatment, he was recruited in the army.
Sir, what is the youngest age?
Youngest age you can treat is 4. But as I told you, I am working on the pre-verbal children also. They can also be treated. But I am making some modifications to this so that pre-verbal children can also use this.
So when we're using this, there's no role of patching at all. So if a child is compliant with the visits and everything, so you've totally given up patching in the treatment period as well as the follow-up period, maintenance period that we say.
I'll tell you, patching has no role to one, because patching one of the eyes is like giving cataract in one of the eyes. Okay? It does nothing to your binocular vision. It does nothing to your stereopsis. Correct? Number 1.
Correct.
Number two, patching, you have to continue for months together. Some of the children, they have come here with me, they have patched for 1 year because the general ophthalmologists are unaware that you should not patch the eye for more than 3 months if there is no improvement. It is meaningless to patch if there is no improvement. Right now, I have another child which I have posted some time ago in the pediatric group where I showed the child came with eccentric, what looked like an eccentric fixation, amblyopia due to high hypermetropia. And after treatment, she is about 70% better in 10 days. Although she came with counting finger vision with me, now she is about 12 part vision with correction. Although the eye looks exo, she says it's straight ahead. It's not exo, which is 6 degree, but it is pseudo-exotropia. And that confused many people.
Okay. And sir, how early are you seeing the effects of this in the improvement in vision?
2 hours.
2 hours itself. Okay.
2 hours. You can talk to our patients. You come this side, I'll show one of the patients. You come. You can look at this patient, okay, and you can ask her some questions. He'll come and stand here. Come and stand here. Bend down a little bit. This girl, she's 16 years old. You can look at the camera which is here. See, she looks exotropic. And that exotropia is exactly exotropia, but it is pseudo-exotropia. Okay? But unfortunately, she has amblyopia due to high hypermetropia. And now when you cover this eye, is it looking straight or to a side? Straight.
Straight.
See, cover the right eye, she says it's straight, although the eye is looking like that. That is because of abnormal arrangement of the optical elements of the eye. Abnormal, I can't say abnormal, but it's normal for her. It looks abnormal to us, but it's normal.
Is it an eccentric fixation?
No eccentric.
No.
Even eccentric fixation at all.
It's a large angle kappa. It could be a large angle kappa. Large angle kappa.
Correct. Large angle kappa. I will send a video of that on the refractometer. You can see much better. It is completely nasally displaced. The center of this thing, pupillary axis, the visual axis is nasal, which means that the angle is displaced temporarily. Fovea is displaced temporarily, and it's still fixing. Fixation, when you say fixation, the eccentric fixation point must have 0 retinomotor value, must have highest visual acuity value, and must have straight ahead visual direction. Whenever you say eccentric fixation, the eccentrically fixating point doesn't have all these things. It doesn't have 0 retinomotor value, it doesn't have highest visual acuity, it does not have straight ahead value. So I don't believe in eccentric fixation at all. What happens is, whenever you fixate on a point with the fovea, the macrosaccades become microsaccades. The eye is never stationary when you fixate with fovea. The eye keeps on moving. But you can't notice it because the movement is so small, about 4 to 5 seconds of arc. You can't notice that there is a movement. But if you have a sensitive implant, you can recognize the movement. So a peripherally large saccade becomes small saccade or microsaccade as it comes towards the fovea. And therefore, the fixation cannot be called eccentric nasal, eccentric temporal, etc. It is a term which we have used for a long time, and we don't know how to change it, but I'm going to change that soon.
Thank you, sir.
Good. Convinced? Convinced, but not to spend 1 lakh. Yeah.
No.
Not convinced, Santa, not convinced at all.
Oh, good. No problem. One customer less.
Can I invite Dr. Yogesh Shukla, sir, to present his talk on newer paradigms for prevention of myopia?
Oh, there is one more talk, I think, no?
Dr. Deshpande.
So Dr. Dadia said that we can proceed with your talk first, sir.
Okay.
Yeah, I think he is not visible on the screen, so...
Okay. Just let me open it. I'm not very familiar with this. Subhash, give me a minute. Yeah, now.
Yes, sir. You can take 2 minutes, sir.
No. It's on the screen, but how?
Share screen button is there. You just need to press. So share screen button. You just need to press.
It's not coming on the screen. That is the problem. It's not coming.
Nice to see the success stories.
Nice to see.
At the bottom of your screen. There is a share screen green
I
button.
know. He told me yesterday. Yesterday also there was one talk which was having the same
But
problem.
in that case, if it is not a full view, sometimes if you create a full view, it comes. In certain computers, it doesn't come. So just there is a view and create full view, you will get that green button immediately.
Yeah, that's what I'm doing. He
Sir,
told me.
have your talk on your laptop so that it's easy to share. Yeah, that's it.
It has come.
Yes.
That's great.
Where
Yes.
it is?
Now just go to slideshow.
Where is the slideshow?
ऊपर sir. ऊपर.
You are sharing this.
थोड़ा सा
More to your left. More to your left.
View. Sir, view पे कर दीजिए. View.
Share new share.
नहीं.
सर व्यू पे कर दीजिए.
आपका ऑलरेडी कर्सर टेल मी पे है, व्यू पे ले जाना है.
उसके बाजू वाला.
There is no view coming.
Upside sir, in red bar.
It is there. I can see it. आपके जहाँ आपका कर्सर है उसके बाजू में लेफ्ट को.
Move it towards left a bit.
थोड़ा सा लेफ्ट में सर, थोड़ा सा लेफ्ट में.
थोड़ा सा.
Participants.
To your left. To your left.
Sir, upper cursor, no? The upper cursor.
ये वाला.
This one? No, this one. या ये बड़ा मुश्किल है. इससे अच्छा तो
सर आप पढ़ दीजिए, विजिबल है वैसे.
अभी क्लिक करिए.
तो नीचे से वो कप बटन दबा देंगे तभी स्लाइड शो आ जाएगा. It will be very easy.
No, what you are saying, but I am not seeing on my screen. No, the problem is this.
Oh.
You are sharing question answers, new share.
So can you see your slides? You can just read them, sir.
I can't see.
You can't see your slides?
Now it is. Is it coming? Any slides?
Yes. All the slides are coming.
Are they coming?
Yes,
sir.
Slides.
Okay.
Sir, you just go to slideshow.
I think sir's slide window must be minimized or something. He must be seeing the main Zoom screen rather than the slide screen.
Could be.
That could be.
Can anyone from the IT guys help him out, please? Sir, can you do one thing, Dr. Shukla? Just send your presentation to one of us.
Or I'll just leave it otherwise. Yesterday also same thing happened and
Sir, your screen and your PowerPoint I think is minimized on your computer.
Yeah.
Just
He hasn't gone to slideshow. I think.
I think his Zoom window is only minimized. He's not able to see his slides.
you can share again, sir. It will help.
सर आप जूम को मिनिमाइज कर लीजिए और अपनी प्रेजेंटेशन पे जाइए.
I think just let the IT guys do it.
Meanwhile, I had one query with all the faculty here. Can we have a question?
Yeah, we can. But I think he's about to start.
No, but it's okay. She can ask.
I don't know. I'm not able to do anything.
अरे नहीं डॉक्टर शुक्ला आप सब कर सकते हैं. ऐसा
नहीं.
आप ऐसे
सर मैं आपको चैट में
आप जैसे जवान थोड़ी हैं. आप नहीं समझ में आता.
You want to have
You believe share the slides on the email.
Is it coming? Is it coming on the screen? It's coming on my screen.
It is coming.
Yes, sir. It's coming here, sir. We can see all the slides.
Is it coming?
Yes, sir.
Okay, shall I start something?
Yes, sir.
Start. Okay, so my topic. Can you hear me also?
Yes,
sir.
Okay, so my topic is basically not prevention, but prevention of progression of myopia. वो थोड़ा सा गलत लिखा है anyway. So I straight away missed this. I exclude this because it is a 10 to 12 minute talk. I will straight away go to the management, which is basically okay. Now the modes of management, that is the control of progression of myopia. We have the several tools in our armamentarium. Number is spectacles and bifocals. So this is basically to control the progression of myopia. This thing. So one is the spectacles, bifocals, contact lenses, which is the defocus contact lenses, environmental conditions, pharmacology and orthokeratology. These are the the tools we have in our bag where we can use to control the progression of myopia. Now, bifocals and progressive lenses work on the principle that there is an excessive accommodation which is going on, and that excessive accommodation by somehow creates pressure on the globe, and there is an axial prolongation of the globe, so that we tend to minimize or deflate the accommodation which are doing by giving +3 lenses for near correction or addition of +3 in progressive lenses. Now, the other important thing which is now in the vogue and which is becoming very popular are the defocus incorporated soft contact lenses, or known as the disc lenses. Now, these lenses are special type of lenses which work on the concept of peripheral defocus on the retina. It is hypothesized that hyperopic defocus accelerates myopic elongation of the globe, while myopic defocus retards it. Now, hyperopic defocus means if the foveal and the parafoveal region is hyperopic defocus, the rays are focused behind the eyeball, and then the eye tries to focus it back on the fovea and that excessive stress on the this thing, the eye makes the eye elongate, because to focus it on the retina, if you don't use your accommodation, then the only way is the eye elongation. It cannot shorten. You see, to have the hyperopic defocus get focused on the retina, the eye has to enlarge. It cannot shorten. So the eyeball increases. So if we correct this hyperopic defocus in the periphery, the eyeball will not enlarge, and to convert it from the hyperopic into a myopic defocus. So that is the idea. These lenses have a central clear vision minus numbers with concentric alternate circle of clear vision and a +2.5 addition number. Now this +2.5 addition number, which creates a myopic defocus in the paracentral region. So this is what is the concept, and it is shown that it reduces the myopic progression by 25%. Now, this is the diagram which shows that how the myopic, this diagram is when the rays are going behind the retina at the parafoveal region, and we have to focus it back on the retina by using a +2.5. So this excessive stimulation of hyperopic defocus is removed by this plus lens in front of this. It is focused back on this. This is the concept. Now, the orthokeratology. Now, this is based on the principle that increased base curve semi-rigid contact lenses press on the central cornea and flatten it accordingly. The lenses are worn overnight and removed every morning, and the vision remains clear for the day. Thus, they have to be worn every night and removed again in the morning. The effect is temporary, and it is not a permanent solution for prevention of progression of myopia. So it is just a temporary solution. Can you hear me? Hello?
Yes, sir. Yes, sir.
Yes, sir.
Okay. Then the third...
Clear, please go ahead.
Okay, then the third thing is the natural environment. Lot of stress is now being put on this concept of natural environment. Now, what does it mean? The human eyes, which have evolved over millions of years, were not programmed to do so much of near work. They were meant to see for distance only, as people were wanderers, farmers, and roamed over mountains and green pastures. So now that concept of far vision has gone, and we are with the present times on the computers and mobiles, we are constantly doing near work, and this has caused excessive strain on accommodation on the medial rectus muscles, which press on the eyeball and cause its axial elongation. That is what the concept, Now, outdoor activity again. Now, they have found, a lot of research has been done for last 1 decade, and they have found how to counteract this. 1 hour of outdoor activity per 6 hours of near work counteracts the near work exertion of the stress on the eyeball. This is what they have found out in Singapore. Now, illumination, another concept. They say that again the eyes were not programmed to see in this artificial light, which again causes excessive miosis and excessive near reflex, and again pressure on the eyeball, and so on and so forth. Now, the near work and accommodation, another concept I may just again recapitulate, the excessive convergence, mechanical pressure on the eyeball increases in the IOP. This is one thing they have found. There is an increase in the IOP by 4 to 5 millimeters of mercury. And this increase in the IOP again causes the elongation, the posterior elongation of the eyeball. The third thing which is related to accommodation is that these patients who are highly myopic, they have an accommodative lag. Now, lag means insufficiency of accommodation. What you have, because the eye does not need accommodation. And over the years, when this thing continues for a long time, the accommodation becomes insufficient and there is lack of accommodation. So this is another concept, that the accommodative lag or insufficient accommodation causes the eyeball to stress on the eyeball. The patient bring the eye, the subject more and more near to the eye and causes excessive pressure again. Now, the pharmacological agents which have been the lot of research is going on, lot of debate is going on, and a lot of work is going on especially in Hong Kong and Singapore on these drugs. Now, the best and the foremost drug which has been very popular now is atropine. They have tried 1.5, 0.1 and 0.01% drug, but 0.01 atropine does not cause accommodation, does not cause it does not cause miosis also, but it acts on the scleral cells and the retinal ganglion cells, which hamper to liberate dopamine. Dopamine causes the increase in the axial length of the sclera. That's what they have found. So it reduces, because this is basically a anti-muscarinic agent, parasympatholytic agent. So this causes the reduce in the release of dopamine and hampers the progression of the elongation of the eye. Another drug in the same group is ophthalmic pirenzepine, which is a 2% ophthalmic drug used in the United States, very common. Again, an anti-muscarinic agent. And methylxanthine is another anti-muscarinic which is used basically in asthmas and bronchial problems, and it is also used, is again anti-muscarinic, and oral dose is 400 milligram daily. It also causes about 25 to 30% decrease in the axial prolongation. Nutrient supplements. This has been again an area of discussion. Sclera is mostly collagen. Various nutrient supplements have been advocated to strengthen the sclera. And now these all the things, I don't have to go into details. Now, surgical endeavors which have been tried to stop the progression of the posterior elongation of the sclera are cadaveric scleral implants, which has been tried 50 years before, but it's not been very popular. Collagen cross-linking is now being tried, just like corneal cross-linking. They have tried collagen cross-linking also with the ultraviolet rays, but it is difficult. It is, technically it is very difficult, so it has been only in experimental ages. Biopolymers are certain agents which are polymers of plastic, and it has been used. These are artificial, like scleral implants. These are artificial agents for scaffolding the posterior sclera to stop its progression. Now, so these are all the agents which have been now tried to prevent the progression of myopia, basically the elongation of the posterior sclera. Thank you very much. Hello.
Thank you, Professor Shukla sir. Now, since we are already late, we conclude this session and we hand over the hall to the chairperson of the next session, Professor Khokhar sir.
Yeah, thank you, Subhash. High time, huh?
Thank you.
I think you had a very big stalwarts in the end. So, I mean, they had to cover everything. I mean, they really covered up so well. I mean, Dr. Santhan and Dr. Shukla, I mean, they're masters in their fields, myopia and all. Hong Kong
Good
study.
afternoon. Good afternoon,
I mean,
Sudarshan ji.
yeah, thank you, Ji. Doctor, can you mute your mic now? I think your
Oh,
session is
sure,
over.
sure.
Thank you very much. And
I'm leaving the hall. Thank you.
no, you don't want to attend. Okay, okay, fine.
Okay, I'll come back.
All right, okay, fine. So I think I'd like to call upon and Char Agarwal. And perfect. Vidya Nair, you can open up, please. So next session is going to be of pediatric cataract. Now, I think whenever the patients bring the patient and you tell the relatives that, okay, your son has, your child has got a cataract, first thing they say, cataract in the younger age group? I mean, never heard of it. So you have to tell them, no, it's not that rare. I mean, 1 to 10 per 10,000 do have cataract. Hello, Dr. Rastogi, you're there now? Perfect. So you can unmute and we got ample time here. So
Dr. Coker, my internet connection is a little unstable, so I'll try to be there, yes.
don't worry. We can hear you well. Right. Welcome. Okay, so what are these cataracts and how do you go about the surgeries? And I think we got all stalwarts here. Dr. Abhay Vasavada is there. He's going to be talking about his experience. We have Ramesh Kenkunia here, and we have Dr. Sarkar, who will be talking about the UVMs. I think these are the new modalities which are coming. Ajay Paul is there, and the last we have Praful and all these subluxury lenses, how to do a very good intralenticular aspiration. I think it's going to be a treat for everybody, especially the ones who are doing the pediatric cataract. So I think I'll call over Dr. Dhrubajyoti Sarkar. Are you there, Dr. Sarkar?
I don't see him, sir.
So I think we should blacklist people who don't come for this talk. So, okay, I think, Ramesh, you're there, right?
I'm there. I'm here. Can you hear me?
Yes, we can hear you.
Yeah.
Hi, Ramesh. I think you're frozen. Can you hear me, Ramesh? Ramesh is also gone. Oh God, so we don't have anybody here. Praful?
Sir, I can start my presentation.
Praful, I think you do that because there's nobody else there. So Dr. Praful is going to tell us that what are you doing to do with the subluxury lenses. Just before he starts, I think the subluxury patients are the ones which are actually not picked up immediately after birth. When they have a subluxation, the eye is myopic. So they can still see things nearby, so they don't complain for anything. So the moment they start going to school, they realize suddenly they can't see anything for the distance. Oh. So majority, about 90% of these patients will come by the age of 5 years when they start going out of the house and when they picked up as... Ramesh, I'll take you in later on maybe because we have started already. That's okay?
No problem.
Yeah, thank you. Sorry, because I think the connections are bad. So, so they're 5 years kids, they're not younger kids, so you can actually plan the surgeries very well. Depending on your expertise, you can actually either you can eat up the lens completely and put the iris claw lens or a SFIOLs, or you can save the bag and do it. So it depends. There's so many ways you can skin the cat. So it depends on what you've been trained for and what you're good at. So let's see what Dr. Prafula has to show us. He's going to tell us about the intralenticular lens aspirations in pediatric cases with anterior dislocations of lens. Prafula, all yours.
Thank you, sir. So I'll be speaking about the result of our modified technique of lens aspiration in pediatric patients with enteral dislocation of lens. So enteral dislocation of lens, as we all know, the common causes are trauma and Marfan syndrome, homocystinuria, microspherophakia. In fact, these are the common causes at our center also. These are ocular emergencies. You have to remove the lens. If you don't remove it, you can land up in corneal decompensation as well as glaucoma in long run. So these are the few examples that I have come across RP center. So at our center, delayed presentation is very common. In fact, the study that I'll be discussing, the short series that we did here, the mean time of presentation was 2 months after enteral dislocation of lens. So this is one such example where even the cornea has started opacifying in the deeper layers with corneal decompensation and vascularization. So this is what the intro picture of one of my case. As you can see, there is dense adhesion between the capsule and the cornea. And in fact, at points there are focal scarring has started in the deeper layers of descemet membrane. So the technique, there has been several techniques described in literature. Initially, people used to do ICC, but I don't think nowadays anybody does that. Then lensectomy, either through plasplanar route or through the limbal route, and endovitrectomy. If there is associated cataract, you can go with phacoemulsification. But the last two techniques are probably the best, I feel. The first one was described by Vasavada et al. In 2003, that is in the bag bimanual lens aspiration and endovitrectomy. And the last one is by Sir Coker Sir, where they did that endocapsular lens aspiration with IOL implantation, or maybe you can leave phakic also, but the technique was endocapsular lens aspiration. So this short series we published in Eye last year. So coming to the video, this is the video of one of my case. As you can see, there is enteral dislocation with some opacity and some haze. And this is the IOCT picture. You can see there is adhesion between the capsule and the cornea. So the technique involves creating two side ports as usual at 10 and 12 o'clock position. And you can advance that MBR knife further to create two linear capsulotomy at the equator. Once the linear capsulotomy are created, you can inject some visco-dispersive viscoelastic like viscoat between the plane between cornea and the enteral capsule. However, as you can see in this case, it was not possible to separate the capsule completely. So we went ahead with the lens aspiration using a bimanual irrigation aspiration system. And once the lens matter is aspirated completely, you can inject some Hilon or high viscoelastic, high specific gravity viscoelastic to reform the bag. Then one trick is always remove the enteral capsule first. Don't remove the posterior capsule first, or else you'll have to fight with vitreous throughout the procedure. So in this case, as you can see, the adhesion was dense. We use an intravitreal forceps to apply gentle peeling force and remove the enteral capsule first. Once the enteral capsule was removed using a vitrectomy cutter, the posterior capsule was removed with some limited enteral vitrectomy. If you are not sure about your complete vitrectomy status, you can use a triamcinolone acetonide. And as a routine, and as I have learned from my teachers, I usually do a PI in such cases. In the end, you can close the wound with 2 10 monofilament suture. As we started doing more and more cases, one thing I learned, what we learned, especially when my residents were doing that, they were struggling. Once they are out of the lens and once they want to go back with vitrectomy probe, they were struggling to find out the capsulotomy area. There are linear capsulotomy at the equator. And in fact, in one case, one of my residents simply torn the capsule by entering through a different area. So to avoid that, this is the little modification that we did in our subsequent cases. Rather than injecting trypan blue in the enter chamber, we injected little trypan blue into the lens itself at the initial step only, so that the margin of the capsulotomy was quite visible in subsequent steps. So we did this in 11 eyes of 8 patients. And as you can see, 10 eyes out of those 11 had corneal lenticular touch with corneal edema. 2 of them had raised IOP, and the associations were homocystinuria, microspherophakia, Marfan syndrome, and buphthalmus, and 1 case of ectopia lentis et pupilli. All cases we could perform, and one has to remember all these cases need a detailed systemic workup, because these kids, they have some systemic association, and getting a GA clearance is very tough. So all cases were done under general anesthesia, and we did not find any intra-op difficulty. And there was no problem with vitreous prolapse or iris damage or posterior movement of lens matter during the surgery. Visual acuity, since these were in pediatric age group, a lot of factor impacted that. However, we find overall there was some improvement after FAK correction. Immediately there was post-operative corneal edema was there in 9 eyes. However, all of the edema resolved by almost 4 to 6 weeks. However, 5 eyes, as I was showing you one picture, they had that central corneal descemet scar which persisted. So these are few examples. As you can see in this left bottom image, there is some corneal scar. And one thing that we notice in these eyes, the reaction is quite severe. It's not like what you get in a routine cataract surgery of pediatric cases. So since the lens is there in interchamber for a lot of time and there are adhesion between iris and capsule also, so the reaction is a little bit more and you have to continue steroid for a long period of time. So intralenticule lens aspiration, it allows you a completely closed chamber procedure throughout the surgery. So all the complications are avoided. This technique, largely whatever I have learned from Dr. Khokhar to working at RPC and few of articles of Dr. Vasavada, this technique is basically amalgamation of all these knowledges. So I would like to thank you, DOS, and also the panelists for giving me this opportunity. Thank you for the kind attention.
Thank you, Prafulla. That was very nice, actually. So just one question to start with, then the rest, I think we can all ask questions because there are not too many speakers. So I think, Dr. Vidya, do you want to react to this?
Yes, I would just want to ask Dr. Prafulla one thing. So do you routinely pilocarpinize these children before you do the surgery? Because I've had children in home, sometimes the lens is, partly anterior, partly going posterior. So when you get them supine, they tend to kind of sink into the vitreous sometimes.
So, the video that I showed you, in that case, the lens was already stuck from all.
Yes, if it's stuck to the cornea, then it's not so much of an issue.
But if your lens is mobile, after taking the side port, the first step is to inject pilocarpine.
Yes, right. Yeah. Thank you.
Yeah, Prafulla, but what I do is when even the lens are mobile, so what you can do is you can just hold the lens with forceps, even if it's going back. And you're lucky if the lens is clearer. If the lens is clear without any cataract inside, the chances are 90% this is a spherophakia case, because spherophakia patients are the one in which the lens is globular, starts coming anterior posterior.
That in that case, pilocarpine
goes, and the first thing you picked up early, otherwise you could have managed that much better. A small PI would have helped. So since it comes anterior and it gets stuck, once it's stuck, even if you peel it off, as Prafulla showed, you can actually peel it off very easily, but the endothelial cells in that place is lost. So it takes about 2 months, maybe more than that, for the endothelium to grow up and the cornea gets a little clearer. Second thing, that if you do this technique, nothing falls down. So basically there's a trampoline of the posterior capsule which is maintained throughout the procedure. And since your infusion and aspiration both are inside, what I do is, in fact, I started doing with the bimanuals, and we switched over to with the vitrectomy probe on an eye cut mode. Suction, you can go as high as 500, and you can, in fact, keep the cutting at the least possible. That's about 100 in my machine of Centurion. So what happens, you eat up the nucleus, suck it up, and when you want to cut, you can just turn the probe upside down rather than coming out of the eye again.
Right.
That way, you won't lose where you entered once, what he showed you very well.
Right.
If you do the hydration in these patients, after making the incision first time into the lens, sometimes you will lose the track of the opening. But we started doing that earlier, but now we stopped doing hydration totally in these patients, so that actually, and once my left hand has gone in and there's an adrenaline which is coming into that, people start writing a little more. That's fine. Once you got a lens in your grip, then you don't have to come out before finish the work. You can do this iris claw, or maybe the AC lenses. If the AC lenses are also done properly in the bigger age group, the sizing is good, it's great. In fact, right now in the RP Center, we're running a thesis in which we're putting up retrofixation of the iris. We've done about 50 odd patients and about already 6 months follow-up. They're doing very good, promising. So let's hope when the thesis gets over, we'll publish something. Dr. Anju Rastogi, any reaction to that?
Yes. So I completely agree that putting pilocarpine is an important step. And this intralenticular aspiration is very useful even if the lens is not anteriorly subluxated, because you see, the longer we prevent the vitreous from coming into the chamber, the better the results are. And in some cases, even when I am doing an AC IOL or a retropupillary IOL, because the subluxation is so marked, if I have a remnant of a bag in place, it gives me a much clearer eye. And as you also mentioned, management of the aphakia with retropupillary iris claw IOLs is really doing well. And we have also done one thesis, but much less number of cases, and it's really doing well. And I also want to ask Praful, which viscoelastic did you use?
Ma'am, initially to separate the capsule from posterior corneal surface, we injected Viscoat, which is a viscodispersive one. But for filling the bag, it was Hilon, which is sodium hyaluronate 1%.
So how did you ensure the complete removal of your viscoelastic? Because that can create a problem once the, there's no bag at that time.
Yes, once you use Viscoat, you have to remember the IA part has to be little bit prolonged, because there is a study where it says that if you have injected Viscoat, the IA should be at least 4 to 5 minutes, in contrast to what you routinely do with normal viscoelastic. So normally I do it for at least 2 to 3 minutes, so that all the viscoelastic is removed. And you are right, at times you may leave a little bit of that, and especially when the cornea is hazy and there is a deeper scar, that is a possibility. But with the recent phacoemicine, I don't think if you do IA for at least 2 to 3 minutes, something will be there remaining.
Very nice presentation.
Yeah, very good, Prafulla. And as you rightly said, with the new machines, you have such a high suction that there's no problem. Thank you very much, Prafulla. And other questions people can put on the chat. Now, I think it gives me an immense pleasure to call a good friend, and Ramesh, Kenkunia is ready. I think you're the one. There's nobody else left now. Prafulla, can you unshare your screen, please? Prafulla. Yeah, Ramesh, all yours, please.
Yeah. Thank you so much for this invitation. I've been asked to talk about 5 special situations in pediatric cataract surgery. So I'll be showing 5. I'll try to cover in 2 minutes each. So when you look at a childhood cataract, it's not one size which fits all. It can happen even in adult cataract with so much of plethora of presentation. But in pediatric, each of this child requires special attention, both in terms of evaluation, surgical decision, and surgical final whatever you do, it's different. First issue I want to talk about is IOL in infants. When you see an infant, obviously after the evaluation in the operating room, try to do whatever is possible on the table, looking at the angle structures, whether there is any anomalies. Even if you don't find 95% of the patients, you won't find any anomaly. But when the child develops glaucoma, you will feel that there is some difference between the eyes, those who have developed glaucoma and who have not developed glaucoma. And in addition to this, obviously you'll have to check the corneal's thickness and keratometry and all that. Once you have done, there are some selection criteria where you can implant this lens. What I generally use, Trypan Blue is quite safe to use in these children, even if they are infants. One of the important thing you need to tell your anesthetist is to keep the end tidal CO2 level, ETCO2, less than 30 to 35. That will make sure that you don't have additional pressure coming up from the vitreous. And obviously the Trypan Blue is safe. Some of these lenses, even in a 3-month-old or a 2-month-old, can be intumescent. You will have to release some of the lens material before you attempt or complete the capsulorhexis, or in between you might have to decongest the intralenticular pressure and then go ahead with the capsulorhexis forceps. So that way, that's one of the things you can do. And as Dr. Coker said, you can use for this step the vitrectomy probe itself. You can do the aspiration as well as the vitrectomy together. And once you have started removing the lens material, it's better to go for the retro illumination globe, so that you can look at all these vitreous as well, the PC, everything will be visible. which is a better visualization of these things. In infants, what are the criteria? You can't implant a lens. There are plus and minus of implanting a lens in an infant. What I try to do is additionally, I try to polish this lens epithelial cells which are there. Then try to do this capsulorhexis. But in infant, I implant the lens first and then try to do the capsulorhexis, because you will realize that the capsular bag size is quite tight. When you implant, it becomes very, very tight. So in most of these children, you'll have to implant the lens first, and then you can go underneath this and then try to do a vitrectomy in a very controlled manner. With the newer technique of vitrectomy, you can shave it off, both the PC as well as the vitrectomy. It can be done quite smoothly. It does not even take much time. And I always suggest to keep a very high cut rate, and additionally always suture these wounds, which are very, very important. So we published this in the India Journal. It's safe in selected implantation in infants, even in less than 6 months, is reasonably safe in appropriately selected patients. If you look at this chart, this is where the selection criteria for implantation, even in infants, with the good horizontal as well as vertical white to white corneal diameter, good axial length, and no presence of associated ocular comorbidities, specifically anti-segment dysgenesis, glaucoma, microphthalmos. I have two additional points in deciding. The number one is the surgical experience should be good of the surgeon who is doing. They would have done enough surgery to do it in infant. Second thing is, if you see any complications intraoperatively, like a big extension of the entry capsule, probably, or you find a blood in the Schlemm's canal, or it's a PHPV or a PFV with the very large posterior capsular rent, what you can see in some of the patients of posterior lenticonus, then differ. Otherwise, it's quite safe. Second thing I wanted to show is retinoblastoma cataract. You can see in this video multiple patients with retinoblastoma. They develop retinoblastoma mainly because of intervention in the form of laser or chemotherapy, and most importantly, radiation induced. Generally, these cataracts are leathery type, what you see in adult with diabetes, and they will have some kind of plaque in the anterior capsule. Most of the times they will have that. This is one of the surgery in a regressed retinoblastoma. You can see that's an ophthalmic socket on the other side, and this is the surgery. If you see this ocular surface, they usually have tear deficiency. So copious artificial tears are important before you take them up. Stabilize the ocular surface before you take them up for capsulorhexis, before you take them up for cataract surgery. This is the anterior capsulorhexis. You can definitely use the trypan blue, or you can use the retro elimination. This is what I was saying. When you use this lens aspiration, it does not come so easily. They are a bit leathery. Sometimes you'll have to increase the aspiration, or you have to use both the instrument to rub against each other and aspirate. And behind that, you're seeing that regressed tumor with the calcification there. In terms of wound construction, best to go clear corneal, not even touch the sclera or anywhere in the limbus, so that inadvertent cells entering into the vascular system can be minimized. Once you have done that, you have a clearance from the oncologist whether to do a vitrectomy or not. Many of the patients you can do vitrectomy, but if you do a vitrectomy or primary posterior capsulorhexis, try to send this for cytology. You have to use this vitrector and then try to send these cells for histopathology and cytology so that they can rule out any recurrence. we looked at this cataract surgery in retinoblastoma patients. And in our experience, it salvages vision in 55%. And more importantly, the globe salvage in almost 90%. Even though there is a risk of extraocular tumor extension, which occurred in 3% of our cases. And this is a video, all that is available on YouTube. You can use it. In summary, for retinoblastoma cataract, go clear corneal. Preferably don't do hydro procedures because sometimes you can see a dehiscence in the posterior capsule. PPC if the tumor has regressed, and try to do a larger diameter, go for a larger diameter intraocular lens, because these children may need a laser later and visualization of the posterior pole becomes easy. And the most important preoperative thing is ocular surface. And if you perform a PPC, always send material for cytopathology. The third aspect I would like to just cover quickly is ROP and cataract. After ROP, it can come at any time. And this is the patient who comes at almost 2 years after the development, probably due to the intense laser he had. One of the very important thing you need to remember in this patient is, they try to poke their eyes, especially when they have a total cataract. You can see he's trying to move his hand so fast so that he's trying to get some kind of thing. This is the maneuver they do, especially they have some retinal, due to retina, the blindness or whatever form of blindness, they will try to do this. So surgery, especially in these kinds where there is a damage, could be a damage to the uvea during laser, it's very hard because they will have a significant, sometimes to remove this, you'll have to enlarge the wound, and post-operatively they do significantly well. But one of the things we need to remember in this patient, I will come to that in the next slide, which is very, very important. I have lost one of the patient, he lost his eye because of that, and that's the surgery. And sometimes you will see the similar thing after retinopathy of prematurity surgery, where the vitreoretinal surgeon has done some surgery, and you will see this kind of plaque here. You can see this plaque, and also the capsule as well as the posterior lenticular opacification you will see. And you can do a thorough lens aspiration. You can see there was some kind of lens touch here. You can see this defect here. This is what has happened during the ROP surgery. And then you can extend that and do this surgery in these patients. So we looked at the cataract surgery in children with ROP. And this is the patient of 22 patients. You can see the age at surgery in months. It can be as early as 2 months, or it can be as late as 5 years, that is 60 months as well. They will come to you. They can develop regardless of modality of intervention, and post-operative complication wise as well as refractive changes, surprisingly we saw they are similar to those without ROP. One of the important, this is the most important message from this, phthisis bulbi can happen following lensectomy in ROP patients in a previously treated patients, especially if they have some anterior segment ischemia due to the damage to the uveal tissues. This is one thing you need to remember. The fourth one I'm going to cover is Zepto and cataract. Zepto is quite safe in children, although the size of the capsular axis, what it can form is much more than what we really require. If I try to do a 4.5, generally it becomes 5 in a manual. Here it can become 5.5 as well. You can see in this video, the surgical learning curve, I think anybody can do it. It's not a big thing. What personally I see is that people struggle with capsular axis. That's the most difficult thing in pediatric cataract surgery. But if you can have a safe replacement, that's a very good thing for most of the people around the world, especially in developing countries. They can do these surgeries in any of these patients. So once you give this vacuum as well as laser, and then suction and reverse suction, you can see that capsulorhexis is quite round and regular. Some sandy kind of material you will see at the edge of the capsule. You can see here. This is not perfect cut. You can see this small little things you can see. And the intended capsulorhexis becomes a little bit larger when you do on these patients. Long term, it's quite good. It's quite stable. I have only one objection, the cost factor, and the probe is a little bit larger. Same thing can be done even in intumescent cataract. You can see the milky fluid comes out as immediately when you do it. And here is where we have done the Zepto as well as bag in the lens, what we are trying to do. This is the bag in the lens. Most of you know this lens is developed by Mary Tessignon, where the whole bag is implanted, whole lens is implanted within the bag. This is the post-operative follow-up of the same patients. Centration is very, very important for these patients, and long-term, they do very well. You can see the picture here, Schumfleg image. You can see both the capsule is holding the lens. You can also do, this is a little bit controversial, whether Dr. Prafulla showed all the lensectomy. We have done.
This is the last scenario? Is this the last scenario? Okay.
This is the last video, Dr. Coker. And it causes some kind of wrinkling when you're trying to do the capsulorhexis. Rest of the things, I use the similar intralenticular lens aspiration for these patients. In selected patients, when there is no total subluxation, you can even implant lens in these kind of patients. And we have 14 patients. This is one of the patients with 25 diopters of myopia. Post-operatively, they do very well. Still, they have some myopia. We have 3 years follow-up. This is the pilot study we wanted to do. We have 12 patients. Now the follow-up is almost 2 years. So we'll have to look at how this can be taken forward. Thank you so much for all the attention. If there are any questions, I can take. Thank you.
I have a question for you. Which vitrectomy cutter do you use?
Posterior capsule as well?
For the posterior capsulotomy and the vitrectomy which you showed, which gauge cutter are you using?
We use both 23 and 25. It's by the Alcon. That's the machine what I try to use. It has got almost up to the cut rate of 3,000 to 4,000. So
it's 4,000.
Centurion
machine is the Centurion is what I use. But yes, it can be used with even other machines as well.
Yeah, that's very true. So with the advent of the small bore vitrectomy, it has really become very easy, like you showed. And I also agree with you that in infants, if we implant the IOL, before doing the posterior capsulotomy and vitrectomy, it makes life much easier because you ensure in the bag placement. And in some cases where I find the chamber is very shallow, I even resort to a pars plicata with the use of a trocar. And it works very well. The 25 gauge cutter works extremely well. And I like to suture the sclerotomy as well, although it is recommended that it is sutureless. And I like to use the 10-0 Vicryl. So then there is no need to remove the sutures.
I agree. There are many ways to do this. Many people use that pars plicata. There are advantages of that as well. But personally, I don't use it. You can go really bigger with the pars plicata. You don't have to be conservative in the amount of or the size of the posterior capsule. So I personally don't use it, but I've seen many people using it. I think it's a good option too. It's a very good option for even the beginner. It's really very controlled.
Yeah, I think that's the way to go. Perfect. And what about posterior capsulotomy with the Zepto? Have you tried that?
Not at all. You can't even create the vacuum.
The vacuum.
It's not possible. And that day will be really good if somebody can come up with that. I think.
No, because I'll tell you a scenario in which we are doing. We got a femto machine which we shifted down to the OT. This is a different. It's a LENSAR which has come on a trial basis. Otherwise, my main femto machine upstairs does not have a GA facility, so I can't go there. So this came for trials. So we tried doing anterior posterior both. And when you do the posterior cone docking, you actually want to go beyond the level where the femto works. So machine is showing all red. So I'm trying to say, go ahead, go ahead. The machine is saying, are you crazy or something? What are you trying to do? You're going to the vitreous. Then I tried it, it worked. But the thing is, you put 2 cones, they put a suture in between, the chance of infection. So it's not practical. Even Zepto is good for the anterior. As Ramesh said, we also got Zepto on a trial basis. We realize it's okay. I mean, if you don't have a femto, you can try it. Otherwise, I think what he's shown is fantastic surgery. And there's no need to have all those funny gadgets. All right, Ramesh, thank you very much.
Power you give, power of the lens, so that amblyopia is prevented.
Oh God.
You actually correct. This is the question. I missed part of the lecture because my internet was down at that time.
So we'll come to that later. So we have enough time. So I think Dr. Ajay Paul is waiting. Ramesh, we'll hang around and do it. Dr. Goel, can you hang around for 15 minutes? We'll do it. So Ajay Paul, let's have your talk on posterior lenticonus, because when posterior lenticonus comes, and there's always a confusion. You've done a UBM, and there's nobody showing the UBM. So I think maybe in the end, I can show you some images. I don't know why these presenters have not turned up with the UBM. So luckily I have some few, so I'll show you some
rather, I'm using some of your UBM, sir, from your presentation, from your paper. Thank you. I just wanted to give you credits for that. Okay.
From Dr. Ramesh or me?
From you, sir. You paper.
Did you take a permission for that? Anyway, go ahead.
I'm telling you because you were there. So I just got a small and then
if you're showing it, then I don't have to show it again.
No. It's not the real one. Just 1 or 2 shots.
We want the real ones, not the virtual ones.
Yeah.
Go ahead, please. Dr. Ajay, please go ahead.
Yeah. Thank you. I'm basically an anterior segment surgeon, but I do a little bit of pediatric cataract, especially these sort of difficult cases, which our pediatric cataract who is relatively young would refer it to me. So basically posterior lenticulus management strategies. It's basically a localized, well demarcated, bulging of the posterior capsule that we have of the posterior capsule and the cortex of the lens. It's a congenital defect, sporadic and unilateral in most cases, can reach a diameter of 2 to 7 millimeter. The conus may occur anteriorly or posteriorly. If the bulging is spherical instead of conical, the condition is referred as lentiglobus, and it produces a decrease in visual acuity and irregular refraction that cannot be corrected by either the spectacle or contact lenses. Now, these are the areas when the earlier stage, when the cataract has not yet developed, this is the stage where you cannot correct the vision. So it occurs approximately in 1 to 4 children in 1 lakh child, mostly unilateral, bilateral cases associated with a positive family history and autosomal dominant mode of inheritance or possibly X-linked. Bilateral posterior lenticulus has been shown to have chromosomal translocation, disruption of TDRD7 gene, and was found to be expressed in posterior lens capsule and the mutation that causes cataract and glaucoma in mice. And it's also associated with Alport syndrome, where you can have both anterior and posterior lenticulus, and Loeys syndrome also. Pathogenesis is basically not known. It may be due to the thinning of the posterior capsule with the bulging of the cortex from the thinned out area into the vitreous cavity, which has been corroborated with histopathological evidence. This could be genetically determined in bilateral cases. It could also be due to remnants of hydroid. Now, this is one of the postulations, remnants of hydroid artery system causing attraction on posterior capsule. This was hypothesized by Mann et al. In 1957, and some cases have been shown to be connected with the posterior hydroid space, the arterial level. So biomicroscopically, it's a transparent, localized, demarcated conical projection of the lens and capsule and cortex, usually axial in location. In our case, we'll be showing a bit of para-axial. In early stage, retroillumination shows an droplet configuration. Using a narrow slit, the image of a conus is observed. In a more advanced stage associated with subcapsular and cortical opacities may appear. An increasing myopia is often an early sign. Visual acuity is usually decreased early in life and associated with amblyopia, strabismus, and loss of fixations are common. Now, this is what I was talking. Ultrasonography, you can see that illustrate the existence of lenticulus. A-scan ultrasound may reveal an increased lens thickness, and B-scan ultrasound may show herniated of lens material suggestive of lenticulus. This lenticulus. This is the UBM basically. The management strategies are basically clinical treatment with tropicamide, and occlusion might have a satisfactory result in early cases, but once the cataract develops and amblyopia sets in, most of the time they do come late because the children unilateral, they are seeing with the other eye, parents fail to notice it. And this case which I'll be showing is around 7-year-old child which had come with a unilateral cataract, and it's suggested that if the vision goes below 2200 or worse, the unilateral cataract associated with posterior lenticulus, this child had come with 636 partial vision. So let's see this. Posterior lenticulus, as we're talking, this was a bit of this was the picture that we saw, and this is what in the VM we could see a bit of, it appeared like a defect, but it was not a defect. So you can see what we do capsulorhexis. We are talking a lot about capsulorhexis in these children. Basically, they are elastic capsule. I have stained it to make it a bit tougher. That's what I do feel, that in children, if you stain it, then the rhexis is easier. Just holding it, I'm trying to make it around 4 millimeter. I know because later on it extends and appears to be 5 millimeter. So the shearing and tearing effect with the micro rhexis forceps from the side port. This is what I use in all my cases, even for adult cataracts, for white cataracts. The micro rhexis forceps from the side, it gives a better control, and you have the direction in which you want to move. You can have it. Later on, what I use for hydrodissection is basically the methyl cellulose that you get, autoclave it and make it a bit, liquefied. So it's not a fluid as such. I'm trying to do a bit of hydrodelineation, not hydrodissection, because that area where it looks like a PPC, that's how I'm treating this patient, as if I'm doing a PPC. I'm doing a aspiration, the phaco aspiration, just by the bimanual, going to the side, trying to separate as much as from the periphery. Later on, coming to the center, this going this side, and keep the stalk as in a case of PPC for the last, if I to see, then again, as if it was coming out, again, I go back a little bit more, I take it out, because, and then once this central part is there, I go into, lift it off from the center, the stalk that is there. Yes, that's the separation. There's a lot of, granular particle matter, but this was what the thinned out area basically. And aspiration, I mean, with the newer machine, like this was 3-year-old surgery, so newer machine, I'm sure with the Centurion machine, this machine also works wonders. As you see, once I've got that, now I have to get that posterior capsule. This was a -1 lens. So what I got in this case was the Rayner lens. The Rayner hydrophilic also, I mean, this has been there for now almost 3 years. I don't have any PCO. So this is the lens. I just tuck it in and there it goes. It's a bigger size lens, but I thought that is a myopic eye. So this lens would fit in the back nicely. And then I go in for a vitreorhexis. I just go, and this is a 1500 cuts. As you can see, the aspiration is not showing here. What I used was a 150 aspiration. I kept the bottom right as there, just trying to make that opening. And at last, just explore, because there is every chance that with the vitrector also it might, extend. I did try in one case of manual capsulorhexis, but then it extended. So this was the case where I used the vitrector, and there got it right to the side, and just as I got shaped into the periphery, this appeared a bit of eccentric. the posterior capsular axis, but then thought it was okay. And there I'm hydrating the wound.
मैं देखता हूँ कौन है जिन्हों.
So that's the end. Thank you for your kind attention.
Thank you, Dr. Paul. So you've shown up as a very challenging patient, and you've done it so well, actually. Perfect, very good. So there's no more speakers left right now, and Dr. Goyal, I think, is going to check the door. Somebody rang his bell, so Dr. Goyal has gone there. So I think by the time he comes back, I think I'll just cover up some about the UBMs, and we'll see what the UBMs looks like, and then we'll come back to question answers. I think we got enough. I'll just take about 10 minutes on this. And then I think we should be able to cover up things well. I don't know, other speakers have not turned up. So where are we? We are here, right here. Okay. Is the screen visible, please?
Yes, sir, it is.
Okay, so let me see, where am I in relation to this? Okay, here we go. I have to close this now. No. I think I minimize it. Okay, so we go to this now, and all right, it's there.
We can't see. We are seeing your screen, all right, but
You can see my screen. I think that's important. Okay, so
we're not
let's
seeing
the presentation.
You're seeing your desktop or the
different folders.
I think that's not open. Basically,
it's not open yet. Okay.
Yeah, it's not open. So you have to open it first and then go back and again.
Yeah, I did open it. I became like
many times sir, it shows like that.
No, I'll do one thing. I'll close it and go back again and then do it. Okay. Alright, it's not the first time I'm doing it, but it looks as if it's the first time. Is it there? No.
Not yet.
And you have to open it first and then go back and again. Yeah, I did open it.
Open,
but don't like that.
Yeah, I'll do
open
this.
and don't minimize it.
Okay.
Don't minimize it.
Yeah, open. Alright, it's not the first time I'm doing it, but it looks as if it's the first time.
Don't worry. Take your
Is
time.
it there?
No.
No.
Not yet.
And you have to open it first and then go back and again. Yeah.
Yeah. Yeah, I'll do
Open
this.
and don't minimize it.
Okay.
Don't minimize it.
Yeah, open. Sorry, it's not the first time I'm doing it, but it looks as if it's the first. Share screen, and there we go. And share. All right now?
Yes.
Is it?
Yes.
Yeah, I think I was not doing it the right way.
We got it.
Anji sir, bas ho gaya, shuru ho gaya. Okay, so I think we can I think we can come on to the EUA only. I think EUA is one of the most important steps in these surgeries, and this is what we do under the EUA. Everything has to be done on the table, actually. And can you see the video running?
Yes.
Okay, perfect. So the patient is under now. And as Ramesh said, you have to be specific about what kind of pressure you want from the back. And you do an auto ref. In all these patients, you have to do. We put the speculum and do it for the bigger kids. For the younger kids, we don't have to put the speculum. Otherwise, the lid pushes the globe out. But we realize that at the age of 2 years and above, it doesn't make much difference. So both eyes open means you can do faster. You do the corneal diameter white to white. And you do the auto ref and a keratometry on the table. Sorry, it's a keratometer. Horizontal and vertical both have to be measured. So sometimes you realize that the dimensions are different. So this gives you the clue. This is going to be a slow one. So once this is done, then you do the contact methods only after the non-contact things are done. So this basically is a red cam for the picture of the other other eye, and that's the A scan now coming. Now A scan will be automatic in taking up all the pictures, and automatically it picks up the image. So again,
I don't think we're seeing a video.
you're not seeing the video?
No,
okay,
no.
so I can avoid that one then. Okay, so then what we can do is, even this is not coming.
Yes, now we
coming?
can see the video. Yes.
Oh, sorry. So it'll just adjust now. So we have already talked about this one till here, measuring it, and see AC length. So there's no hurry in finishing the surgery. If you actually calculate the things properly, for the long-term follow-up these patients, you will be more accurate. So please do not rush your patients. In case you don't have a lens appropriate for this for the patient, you can actually avoid the lens, go back again, rather than putting any lens which is available. I think that's a mistake one should not do. And we have a good amount of inventory at the RP center. So now this is what we're doing a UBM now. So UBM, you have to fill up the cup and do it. So smaller eyes in which you can't put the cup inside, we push it one side on the lid and other side into the cul-de-sac. And we can hold the water and we can still get the image. So even as young as 1 month old child with the 18mm cup, we can do UBM. So that's the thing we just published. It will be coming in print soon. So that's how the UBM looks like. So now see this one now. Now this is what a zonular cataract is. And if you do a UBM, you can see all the entire anatomy up here. You can see the anterior capsule, you can see the posterior capsule, you can see the zonular, and it's corresponding to the size there, right? And this thing is very sensitive because it can pick up even your PPMs, persistent pupillary membrane, small tags and things which you will be able to pick up. I'll show you in some images later on. Okay, now this is the second group of the second patient, which you see it doesn't look like a complete zonular. It's not round. It's got ragged margins at the periphery. That means it has a nuclear also. That means the nuclear part was the one which is zonular, which came earlier, and the rest was maybe there's a fluid which has gone inside. Although the picture here looks like a zonular, but it's not a pure zonular in this case because you see the central chunk in the center. Okay, now this is a white Morgagnian cataract, and we have not done the rhexis yet. So we have picked up lenses which are Morgagnian in pediatric age group as well. So if you shift the patient to the side, the nucleus moves. So you have a Morgagnian in the pediatric age group as well. Now you see this one, the lens is floating up, and there's no posterior opening in this one. It's a big, huge lens with the nucleus which actually floating up. Now this, if you notice, the volume is less. So once the volume is less, there has to be opening somewhere. In this patient, there's opening in the anterior. So although you can't see here and the child will not show, it's a 2 months old. If you put a UBM, with this UBM picture, you're sure that you might need a cutter, anterior forceps to cut the anterior capsule. So be prepared with that one, or a plasma blade if you have a functional plasma blade in an OT. So this was Bhupinder, who was about 2 months of age. Now coming to this patient, you see it was a post-traumatic one, and we wanted to see this area. We realized that it's plugged up. The iris is plugging up, and there's no vitreous which is collapsing here, right? But in this case, we can't make out anything here, but here if you see the vitreous, the nuclear material is coming out. That means it's got an active opening present. So the moment you go inside, actually you can actually go through it and aspirate the entire the lens if you want to. Now this is what I think Prafula is showing. These are typical spherophakia patients. On day one, you might find it up in there, and second day you might find it on the vitreous. Third day again, they might come back and hitting the back of the cornea. So if you have these kind of pictures, please go in the OT and remove these lenses. Now, this is kind of lens which Prafula was talking about. So you don't need to constrict this one. This is not going to go anywhere because pupil as such with the light is reacting, and it was on the slit lamp. This was a 5-year-old kid, and nobody had actually seen this patient before. So he came to us. Okay. So this is again, you see the UBM, this one, the lens is sitting in the front, touching the back of the cornea. We picked it up very early, so we could easily pick up, and this patient had a very good visual outcome. But if we had delayed this one with the thinking of this blocking the pupil, they would have a pupillary block, pressure up, and the endothelium also would have gone for 6. This had opacity in the front, but to our surprise, despite the opacity, it has a posterior opening also. You see this bulging out posteriorly. Oh. So this was a case of posterior lenticonus along with the anterior plaque, which normally we don't get. So maybe there was anterior lenticonus along with this, and it had ruptured up and become plaque after healing. But this was a very strange picture we got. And I think with that, I'll stop it. And we are open to discussion now. We have time. We have time because I think 2 speakers are not there. We got about 15-20 minutes. We can easily discuss. So Dr. Anju, anything you want to add on, or you have any queries?
Yeah, thank you, Dr. Khokar. That was really wonderful. What I want to ask you is, do you routinely do an EUA in all your cases before taking up the case for surgery?
Yeah. So my patient comes to the OT. First thing is we do EUA for all patient and then we proceed for surgery. Not separately, same anesthesia.
Okay.
So we take up the patient in which I don't want to operate. Like PR and accurate, there's a problem. Those are the one in which I give them a date for the UA. When I say a date for the UA, that means that my resident knows that, so why UA? Because why not surgery straight away? So otherwise, each patient of mine will get a biometry done. Each patient, both eyes will get a UBM. Even the normal eyes. If there's a traumatic cataract in one, we take the normal eye out. So we got about a 250 normal eye data with which we realize what is the size of the bag we have, what is the white to white we have, and what is the dimension of the volume of the lenses. And we realize as compared to the Caucasian eyes, eyes are smaller, much smaller. So that's, again, we did a thesis about 2 years back and we're working on that. So UBM for all patients, then we start the surgery. And at the end of during the surgery, the last step of the surgery now we do is we put in an illuminator from the anterior port into the vitreous cavity, almost at the posterior PCC place. If you want, I can show you the pictures also, and I'll show you, and you put a wide angle and invert the microscope, and you can see the fundus pictures of these beautifully well. So we just send a case series to BMJ, which has got a publish, in which you can see the cuppings, you can see the PFPs, you can pick up the smaller disc, you can pick up the bigger disc, you can pick up the anomalies, you can pick up the ROP patients, you can have the retinal plasma pictures. So we got a set of about more than 500 patients right now with a wide angle on the table. Because these 6 months, 7 months, 8 months, later on, you can't see the fundus. So we're keeping the data with the patient, and that's what we're doing. And that's how we're doing it, all the patient. Dr. Anju.
So my reservation is, if you're doing all the examinations before the surgery, doesn't that increase the risk of infection?
No. See, what we're doing is everything is sterile there. All these things are sterile. And after the EUA is done, we wash the cul-de-sac totally with the betadine first before we start the surgery. So one resident is washed for the EUA. The second resident comes in and washes for the surgery with me, and then we proceed from there.
That's an ideal situation, but it really requires a lot of time.
Yes, Anju, we have enough time for the pediatric kids, because if we don't give them time right now, they're going to get in trouble because they got 80, 90 years to live. Whereas the adult cataract who comes at the age of 60 years, getting an IOL done, might stay for 40 years maximum. I'm stretching it too much, Ramesh, 20, 30 years. But these kids have 80, 90 years. So please give time. What I realize that when we are, okay, people can say you've done the UBM and you go for the surgery. But when you see the UBM and go to surgery, you're mentally prepared for this thing. You're already tuned that, okay, this is the one in which anterior access might not be possible. You might need a Zepto or a Femto or a scissor. And you can ask the sister to get the scissor. Those 5 minutes, when you reach this step, is already ready. I think it makes a difference for these patients.
I think simultaneous EUA is better rather than having 2 EUAs.
Yeah.
I completely agree, because many times, as you also will experience the same thing, it takes more time for EUA than surgery. Many times.
Most of the times.
Yeah.
See, when I started doing about 2 years back EUAs of this mode of UBM and all, the anesthesia guy says you could do 8 till 1 o'clock. You take, now it's 1 hour extra you're taking. I said, no, because of this, I think we should not cut corners. And I have 2 Centurion machines for the pediatric. I have my UBM for the pediatrics. I've got the entire set for my pediatric patient, and I can give anything, my right hand for the pediatric patient. So I think everybody who's doing it has to be dedicated. Otherwise, I think there's no point in jumping into the fray.
Yeah.
Dr. Goel, your question was that what IOL power you put?
What I would say, it was good that I attended this session, because I was not aware of that you can do UBM and find out the size of the bag and
sir, it's a new
place
era
where
now,
the
sir.
cataract opacities are there. I thought always the time it is a blind surgery and you place the IOL.
No.
That's what I meant. That blind surgery means that you place the IOL without knowing how what would be the sac and all that.
Not anymore, sir. In fact, today I had OR. So there was one patient in which my resident was cutting corner. He says, "Isko to UBM pehle kar rakha hai." I said, no. Please put it.
Are you demonstrating something tomorrow like that?
Tomorrow is a ICL surgery. See, Namrata wants whatever she wants me to do. I'm doing that one. So I'm doing ICL surgery. In that, I'll do an IOCT microscope, and I'll use it to show you the vaulting there. But that's not a big deal. 5-minute surgery, sir.
Well, my question
Coming
was
to the pediatric.
the power of the lens.
Power, I think I can talk about that. We've done enough publications. I think Ramesh, if you want to start, and then you should start. And okay, go ahead.
Yeah, I would make it very simple. It's kind of undercorrection, and the age of the child should be 7. That's the simple way we can manage.
How
But it
much
has got
undercorrection?
exception. Undercorrection for for a child of 1 year, you undercorrect it by 6 diopters. 6 plus 1 is 7. If a child's age is 2, then you undercorrect by 5. That's the thumb rule we can use. Yeah. But there are many scenarios where there is anisometropia, family history of myopia, child with delayed development because of cerebral visual impairment. In these situations, I'll try to go for more emmetropia than undercorrecting. So many patients, this works, Dr. Goel.
So what about unilateral cataracts?
Unilateral cataract, I will go for more of emmetropia. I will undercorrect less because you are already creating a difference between the eyes.
Right.
As you know, most of them won't do the patching, all that.
Yes.
Even if I can do a LASIK surgery for a myopia, if they develop later.
And
so that's what I would try to do.
Yeah, fine.
What
I
are
think
the
Dr.
chances
Goel,
of a replacement of the lens later on?
Okay,
if
Dr.
your
Goel, I'll just add on to
calculations go wrong?
Dr. Goel, I'll just add on a few things. Now, earlier what we're doing, we're following the Hans and Prost criteria, for which at the age of, I think, 1 year, they were 2 years, they were doing about 20% undercorrection, which was hell of a lot. That way, I agree with Ramesha because NBRD said that 1 plus 7, which the rule of 7 is, I think, is the closest to our eyes. So on the basis of that, we did a thesis in which we took patients in 4 groups, 0 to 6 months, 6 months to 1 year, 1 year to 2 years, and bigger than that. So we calculated all the parameters and put in the implants in these patients and followed these patients, each group for 6 months. So we have a 6 months going to 1 year, and we know how much is the growth. We realize the Indian eyes don't grow that much. So the undercorrection, what NBRD says, is more close to our setup than the Prost or the Hans criteria, which we were talking earlier. I think everybody will agree to that, Ramesh, especially because those hyperopes I did about 15 years back, they stayed 5, 6 hyperopes. They never corrected. They got 10 years, 12 years now. Then we have the explant. Sir, exchange and explant of the lenses are if you have plus minus 7 diopters. That is the cutoff we take. So any lenses by the age of 5 years has not become emmetropized to the range of plus minus 2 and it still is in the range of 5, 7, we have to exchange and explant. Earlier, we thought that the exchange of lenses will be difficult, but all these lenses, when you put the single piece into the bag of a good quality single piece, which is a
there are no good chances of a replacement lens.
No, we can replace them. That's what I'm coming to. So once you have, okay, if the sudden eye has gone out of proportion, these are outliers. They're falling. We thought them that maybe we never got the history of the myopia, or they had an increased pressure which was not checked, and suddenly it went up and the eyes elongated. That's what happens usually. So this will be becoming like more myopic. So if it's more than 7, I think we can exchange the lens very easily, sir. There's no problem. You can always take the lens out of the bag and take it out and put a 3-piece lens in the sulcus or a bag where it suits. It can be done easily, sir. There's no problem. Initially, we had anxiety about that, but now after doing for the last 15, 20 years, we realize that if it's possible, if it's required, it can be done. But majority of the times, we don't need that, sir, because the calculations are very, very fine now, and all these patients on the table are calculated.
And if it is unilateral cataract, you do some patching.
Of course. Amblyopia has to be treated in all patients. All patient amblyopia post-op to be treated, as Ramesha said rightly, less undercorrection. So the difference in both eyes, not more. Otherwise, you have to. And if you have a setup of contact lenses, which unfortunately we don't use contact lenses for pediatric in our setup very well. I think that's the thing which I'm missing. If unilateral cataract, I get a contact lens fitting on the top, and we can actually do wonders. I'm sorry, I was not able to get this one in my system yet, because I need to have a new faculty with me, and nobody wants to jump into the pediatric that easily.
Who looks after contact lenses now at RP Center?
I don't know. I think Unit 3 is handling it, but yeah, I'll have to get back to you.
It was Dada before.
Yeah, Dr. Dada was pioneer.
Before,
yeah,
yes.
That's right. You're right, sir. He was your era, sir.
Pardon?
But at that time also, surgery was not in the blind procedure. Now, pediatric cataract surgery, you see everything. Even if the smallest of the pupil, you can actually put iris hooks and get away and do the surgery. So all these surgeries with Rexis, anterior posterior, all measured, calculated, lenses in the bag or capture whatever, and everything is planned, sir. I mean, nothing.
That's right. I appreciate it.
Right, sir.
Because I'm thrilled to see that and all that.
No, we didn't show you more videos because I thought Dr. Vasavada is covering up, I think, because of some reason. So That's fine. And Anju, Dr. Anju, you want to add on something to this, please?
It's very fine to aim for more of emetropia, but what happens for IOLs in infants? There, the power will come more than 30, and sometimes you may not have the power available.
Okay, so if the exit length is less than 16 millimeter, then only the power is going. I'm just coming to that. So if the keratometer is too steep, say 52 or something, and or on the other hand, your exit length is very small, then the power comes about 35, 38, 40. Then you put the maximum you have. But still, what I do is, if my power is coming anything beyond 40, I don't put lens in these one. I wait for them to grow up and give them bilateral aphakia. Bilateral aphakias are doing very well. We have patients who have come after 5-6 years of aphakia and they're using well. Even Ramesh series I've seen last time is shown well. They do very well. So aphakia is still an option for a bilateral high hyperopes, right? Whereas anisometropia, then you get in trouble. That's where you need contact lenses and the IOL in the eye. So if you have I think single piece comes still plus 30 and the other one comes still 33 plus. These are the two options. Maybe I'm putting the other way around. That's the maximum power you get. And not you're getting more than that. Now we started, Ramesha, we started getting a series on Aura. We're using Aura for the pediatric.
Aura, yeah.
Aura. So what I'm realizing in that, you have actually, you can curse down and see, like I'm doing my parameters, what I'm doing, I was doing for last 10 years, but I cross-check with Aura. So I'm trying to validate it that if it comes well, the thing is you have to hold the eye with the forceps and bring into the center of the fixation and zoom, you can do it. So before that, what we did some surgeries in adults. One group topical, one was blocked. And we forced the eye into the center because patient is not able to look into that center. And we realized it's working the same. I mean, the results are good, published in IGO about a year back. Then we went out to the pediatrics. So for the last 6 months, we're doing pediatrics. And that takes another 3, 4, 5 minutes extra because Aura, you have to fill the chamber. And Ramesh, if you're doing the Aura, and anybody who's starting an Aura, you have to fill the pressure to 21 millimeter of mercury. Then only it'll pick up.
What is this Aura?
I'll come to that. So in a minute.
I don't know.
So please do not open the posterior capsule before. So do your Aura before posterior capsule opening. That's a trick I'm telling you. Because if you open the posterior capsule, all Helon will go into the vitreous and I mean, the effect 21 millimeter pressure won't come. So once you overfill the capsule bag, when you're doing the PCC, you have to deflate it. Otherwise, your excess will run away. Oh. So Aura is an OptiWave refractometer, which is an abrometer. So in which on the table, it's fit into the microscope. So on the table after the surgery, you have aspirated, the patient is aphakic. You put it on and it will pick up the parameters and give you the IOL power. And it'll give you an entire series of refractive errors if you're planning, you first hyperopic, first myopic or vice versa. So it's actually works on the lower order aberrations, not the higher order aberrations. It takes into consideration only the spheres and cylinders. That's it. Doesn't go to the comma, pistil or any trefoils and all. Only lower order aberrations. So we're just doing a study on that and we'll work on that. I'll tell you. Dr. Bhalla.
Yeah, for maintaining that IOP of 21, you put it, this thing, inject viscoelastic and hydrate the wound because speculum pressure may make the IOP variable.
No. Basically, it says it should not be less than 21 is what the game. Because if a softer eye, it will not work. That's why you should not open the posterior capsule. Otherwise, it will go softer. So more than 21, it works well. Because that's what they say is the optimum to pick up the IOL power calculation. Now it works on the principle in which the light cornea and the lens is absent. So it basically goes, it gets a reflected light and picks up the spherical aberrations in that. Spherical and cylinder. That's it. Ramesh, you don't have an Aura, but don't buy it yet. I'll tell you when you have to buy because it's unnecessary. If you can do it.
We thought about it and this is what we anticipated.
So we have it, Ramesh. So I'm telling you, let me publish and I'll tell you. Otherwise, if you can do a good refraction on the table,
yeah,
I think that's as good as Aura.
Yeah.
It was very, very helpful. Though I don't do this surgery now, but it was good to know all this. That's why I came in this session.
Despite somebody was knocking, ringing the bell for you and you're opening the door again and again. Right? So somebody was trying to sabotage it. All right.
The previous session went a little longer, in fact.
Yeah. I think we got this session about 40 minutes late. But
and finished 10 minutes early.
We'll give you 3 minutes only because I think the last session was Santhan and Yogesh Shukla, last two speakers. They went on and on and on. I don't know. I mean, it was a good thing they were discussing, but
I couldn't listen to Yogesh Shukla, in fact, because my internet went off.
You didn't miss much, sir.
Electricity failure
So-
for 5 minutes or so.
Okay.
And
All
by
right.
the time internet came, his lecture was over and you had started.
And what was the time that time, sir?
I think it was just before 3 o'clock. I think it was around 2 o'clock or 1:45.
It was 2:15, sir. And he was
Maybe
supposed to give us.
1:15. I didn't.
He was supposed to give us at 1:30. So he gave us 45 minutes. So I can put
Yeah.
these two guys, Bhalla and Rashim, on the task.
You were putting a message time and again.
No, it's okay. I
That
think it's
two
better to stick
speakers
around.
are
I
left
think.
after this.
So any of the closing
Anyhow,
remarks?
everything
Closing
is
remarks.
going on very well.
Vidya, any closing remark you want to say?
No,
30 seconds.
My tryst with pediatric cataract started with you, sir, with my thesis.
Oh, no,
And,
not that, not
yeah.
that. Tell me
I
something.
know. So what I'm saying is, it was really good to have this session here and to listen.
What is your take-home message from here? One take-home message.
One take-home message, sir, is I would say what Dr. Ramesh said, the infant eyes to do the posterior capsular rexes after putting the IOL, I think was a good message.
Very
that I
good, very
got.
good.
Yes.
Yeah, in the beginning, I think that's the best. Later on, you can always
Yeah.
graduate.
I have
Dr.
a
Anju Rastogi. Ma'am.
take-home message.
हाँ sir, आप बताइए.
Send
Via
cases
inverter.
to you. Send cases to you people.
So we already have floods there. I think I would like
Okay.
everybody to operate there in their own clinics.
I know.
I would
I
love to teach them because I'm doing 10 in a OT. I mean, it's not fair. And especially with all these investigations, I don't want to cut corners. So I would prefer that everybody does it. It's not an atomic, it's not that huge a thing. Surgery is the simplest part. The problem is the commitment in pre-op and post-op
How
follow-up.
many people are with you in this project?
I
Or
have
you are alone?
two SRs and two junior residents.
2 SRs and?
2 junior residents and those dedicated lot.
Okay. No,
Right,
no
Dr.
other
Anju,
faculty.
Dr.
Yes,
Anju, anything specific you want to add on our 1 minute?
Yeah. So basically, most of the things were very well covered. What I want to emphasize is that the proper patient selection, especially when we are dealing with infants, is extremely important. And what Dr. Ramesh also showed that you have to have some cutoff parameters. The eye should be otherwise normal in Indian setting. That is, if you have the appropriate corneal diameter and axial length, adequate expertise, and if you exclude microphthalmos and other pathologies, only then you should think of IOL implantation in infants. Otherwise, they are better off without the IOL and should be managed with either spectacles or contact lenses. And as you rightly pointed out, surgery is just less than half the job done. And the post-operative follow-up and the rehabilitation is extremely important, especially the repeated refractions, so as to keep up with the changing refractive status. This cannot be overemphasized. And one has to be dedicated enough. Otherwise, we will end up with amblyopia even after a very good surgery.
True. Ramesh, one minute.
Yeah, I just had 3 points in 1 minute. One is surgery is extremely important, but that's not the end or the beginning. It's just the beginning, I would say. Do a thorough EUA, as we have discussed. It's extremely important in the long term. And the third point is do a real follow-up. I have a mnemonic for real, R-E-A-L. R is for refraction, E for eye pressure, A for alignment and amblyopia, L for lens-related parameters. Every visit, do these factors, real follow-up. That's the message I have. Thank you.
Perfect, Ramesh. So every time the patient comes back, look at the IOP pressure. We also do the axial length and keratometry also to see how the corneas in the younger kids are molding. I think we can add on to that. I think everybody's covered well, and I was so happy that I didn't have to do much and everybody was so to the point and precise. And Dr. Ajay Paul also did a great job. So I think with that, I'd like to thank all the speakers and the panelists and my co-chairs for helping me out. And I think the people who missed out, too bad. Bye.
Thank you.
Thank you.
Thank you so much.
Thank you.
Thank you.
Goel is there for the next session.
Dr. Goel, over to you, please.
Sorry.
Where are you, Dr. Goel, these days now, after retirement?
I am in Sharda Medical College, Greater Noida.
That's good. Yeah. Anju and me had been there several times for examination. In fact,
Okay. Yeah.
Sharjah?
Yeah,
You want to
seeing
Sharjah?
Anju after a long time.
Sharda.
Achha, I thought you want to Sharjah for cricket
No,
match.
not
No.
Sharjah, Sharda.
Sharda.
Sharda Medical College.
That's good.
Respect से दा बोलते हैं ना Bengali दा. Sharda.
Thank you so much, Dr. Sudarshan. And we start with the neurophthal session. We have some very interesting talks which are lined up. The first to go is Dr. Shweta Chaurasia. And Dr. Shweta, are you here? You can share your screen now. Dr. Shweta Chaurasia?
Yes, am I audible?
Yes, you're audible. You can share your screen now. She's going to talk about cranial nerve palsies, localizing lesions.
Good afternoon, everybody. Topographic localization of neurological lesions affecting cranial nerves is possible with the help of careful history and examination and good anatomical knowledge of the brain. Here, with the help of few case examples, I will like to teach how to localize the lesion. A 14-year-old boy presented with 10-day history of bilateral eyelid drooping and diplopia. Examination revealed bilateral ptosis and adduction deficit. MRI revealed enhancing lesion in the midbrain. Serum ELISA for neurocystic circus was positive. Patient was given a 14-day course of oral steroid with albendazole, to which he responded. His ptosis resolved and ring enhancing lesion cleared. Since the bilateral ptosis resulted from the levator subnuclei, hence it was a nuclear third nerve. So oculomotor nuclei is located at the tegmentum or midbrain at the level of superior colliculi ventral to the sylvian of aqueduct. Nuclear lesions are uncommon, but the most frequent causes are vascular disease, primary tumors, metastasis, infection, and inflammation. This is the lateral view, and this is the superior view of oculomotor nucleus. It is composed of unpaired levator subnucleus, which is a central caudal structure that supplies both the LPS, and lesions affecting it causes bilateral ptosis. Then there is an unpaired Edinger-Westphal nucleus, which is located more rostrally and dorsally. Then there's paired medial rectus, inferior rectus, and inferior oblique subnuclei, which supply the ipsilateral muscles. And then there is paired superior rectus subnuclei, which supply the contralateral superior rectus. So lesions localized to the paired medial rectus subnuclei often lead to walled eye and bilateral internuclear ophthalmoplegia characterized by defective convergence and adduction. This is the 9-year-old girl showing waxing and waning kind of exotropia and adduction deficit. On imaging, there was a dural base midbrain vascular malformation causing nuclear third nerve. This is a 62-year-old male who presented with severe headache followed by slurring of speech and right-sided hemiplegia associated with drooping of left upper lid along with limitation of movement and diplopia. So it was the case of Weber syndrome, which was a involving fascicular third nerve, and MRI showed infarct in the left ventral midbrain. So fascicular part of the third nerve travel ventrally through the red nucleus and through the medial aspect of cerebral peduncle. And there are various syndromes which are described depending on the level of the neurological lesions. Causes are similar to the nuclear third nerve except for demyelination. Here is another example of a 52-year-old male who was a chronic smoker, presented with diplopia and ptosis, followed by sudden onset third nerve clap, headache, and periorbital pain with loss of consciousness for half an hour. There was no history of trauma. So it was a case of right-sided third nerve palsy. Since the pupils were involved, urgent MRI and MRA was done, and there was a saccular wide neck posterior communicating artery aneurysm, which was close to the origin of the carotid artery, impinging on the third nerve. So the patient was balloon assisted coiling of the posterior communicating artery aneurysm was done, and the patient recovered. So it was a basilar third nerve. So the basilar third nerve traverses unaccompanied by any other cranial nerves, and that's why isolated third nerve palsies are commonly basilar. It's important to note the status of the pupils because surgical lesions such as aneurysm and trauma generally involve the pupil by compressing the pile blood vessels and superficially located pupillary fibers, whereas the medical causes which spare the pupil like hypertension and diabetes, they involve the vasa vasorum because, causing ischemia and of the trunk and leaving the superficial pupillary fibers intact. This is another example of a 34-year-old male presented with sudden onset redness and pain, decreased sensation over right side of face, progressive proptosis, visual loss. There was history of trauma. He presented with pulsatile exophthalmos, chemosis, ophthalmoplegia involving pupil, and auscultation had blue. The ultrasound and MRI showed dilated superior ophthalmic vein. So the patient was diagnosed as carotid-cavernous fistula. The patient was urgently referred for the neurosurgery for carotid ligation. The site of lesion here was intracavernous. So intracavernous third nerve, part of the third nerve is located at the lateral wall of the cavernous sinus superiorly. And because of its close proximity to third, fourth, and with the fourth and sixth nerve and the trigeminal nerve, they are involved. It is important to note that posterior cavernous involves the whole trigeminal, the middle cavernous sinus involves the ophthalmic and maxillary branch, and the anterior cavernous sinus involve only the maxillary branch. Causes of intracavernous third nerve palsy could be diabetes, in which the pupil is spared. Then there could be pituitary apoplexy, in which there is bleeding in the pituitary adenoma, which cause sudden headache, rapidly worsening visual field defect, double vision, nausea, vomiting, and sometimes presenting with neck rigidity and level of consciousness. Then Tolosa-Hunt syndrome presents with relapsing unilateral painful ophthalmoplegia. Then aneurysm could be the cause, meningioma, metastasis, and cavernous sinus thrombosis. Superior orbital fissure lies at the back of the orbit, and fissure in anterior cavernous sinus contains same structures and a similar presentation. Orbital apex syndrome generally is caused when the optic nerve is involved, and that's how it differs from the superior orbital fissure. But sometimes superior orbital fissure is accompanied by an ipsilateral posterior ischemic optic neuropathy from dissection and occlusion of internal carotid artery, and can be mistaken as orbital apex syndrome. In the intraorbital part of the third nerve, it is divided as superior division and inferior division, and it can present as superior division or inferior division of third nerve palsy, and the causes could be vascular or trauma. A sixth nerve nucleus is located at the level of the pons ventral to the floor of the fourth ventricle. It is important to note that isolated sixth nerve paralysis is never nuclear in origin, because it is in close proximity to the seventh nerve and the PPRF, causing ipsilateral no motor neuron palsy of facial nerve and failure of the horizontal gaze toward the side of the lesion. Fascicular sixth nerve could involve the ventral pons, which is known as Miller-Gubler syndrome, and along with the sixth nerve, there is a seventh nerve, ipsilateral no motor neuron, and contralateral hemiplegia because of the involvement of the pyramidal tract. Foville syndrome involves the dorsal pons, and along with the PPRF, there is fifth, sixth, seventh, and eighth involvement. Bacillus sixth nerve passes upward close to the base of the skull and pierces the dura below the posterior clinoid and angles forward over the tip of the petrous bone. Here's a case example of 40-year-old male who presented with history of headache for 6 months, inability to move the left eye outward with double vision for the last 10 days. ESR was high, ACE levels were high, Montauk's was negative. The MRI was done, and there was diffuse thickening of the left tentorium, suggestive of granular matter inflammatory changes, and the radiologically hypertrophic meningitis was diagnosed. CECT chest abdomen showed bilateral hilar lymphadenopathy, and biopsy revealed non-caseating granuloma. So it was a case of bilateral sixth nerve palsy due to sarcoid-related hypertrophic meningitis. Case 7 was a 34-year-old man presented with horizontal diplopia, sudden onset for 3 months. There was history of preceding trauma and followed by ICU admission. Oculomotility examination showed right sixth nerve palsy, and MRI imaging showed thin vascular loop coursing and impinging over the basilar cistern portion of the right sixth nerve. So it was a basilar sixth nerve. Case 8 is a 48-year-old female presented with severe headache for the last 6 months and boosting of sound. There was transient blurring of vision and diplopia for the last 10 days. Oculomotility examination showed right sixth nerve palsy. There was papilledema. Visual field showed centrocecal scotoma. There was posterior flattening of the globe on MRI, and venography showed stenosis of the sinus. So here the direct sixth nerve was not involved. And a raised intracranial pressure caused the tonic displacement of the brainstem, which stretched the sixth nerves over the petrous part, and here the sixth nerve palsy was a false localizing sign. Other causes could be nasopharyngeal tumor, basal skull fracture, Grady-Negro syndrome. In the intracavernous part, sixth nerve is situated close to the internal carotid artery and is more prone to damage than other cranial nerves. Intracavernous sixth nerve is accompanied by post-ganglionic Horner syndrome. This is the picture showing intracavernous part of the sixth nerve. A word about fourth nerve. It is located at the level of inferior colliculi. It is the only cranial nerve which decussate fully at the anterior medullary velum, and it is the only cranial nerve which arises dorsally. The intracavernous part runs close to the lateral wall of the sinus.
Dr. Shweta, can you conclude? Your 7 minutes are done.
Okay. So I'll just conclude. Cranial nerve involvement depends on the anatomical course of the cranial nerve and the site of the lesion. The localization of cranial nerve lesion could be suspected based on clinical grounds and careful history and examination. Imaging studies play a role in confirming the diagnosis, and more importantly, they give insight into the underlying etiology. Thank you.
Thank you so much, Dr. Shweta. That was a wonderful presentation. Welcome, Dr. Jawaharlal Goel. Any comments as we invite our next speaker, Dr. Subhashini, for her talk on decoding diplopia mystery. You can share your screen, Subhashini.
Yes, sir. Good afternoon, everybody. Hope I'm audible.
Yes, you are.
Yeah, thank you.
So you have to unmute yourself.
Yeah, I did.
Causes of transient obscuration of vision in your cases. Hello, Shweta.
Sorry.
So you need to unmute yourself, Dr. Goel.
Now it's
yes, no.
No?
Yes, audible.
Now, you said that there were transient obscuration of vision. And what is the possible cause for transient obscuration of vision in raised intracranial tension? We are oftenly saying these things. What is the mechanism for this thing? Shweta?
Transient obscuration of vision. I cannot actually tell the reason. I'm looking out.
Anyway, actually, it is because of the enlarging ventricle, which compresses the chiasma or optic nerve. Secondly, it may be because of the optic nerve ischemia also, because transiently when there is a compression, there is ischemia and sudden blurring of vision. And if the chiasma is also pressed, then also there is an obscuration of vision. Okay. Thirdly, it can be because of the uncus herniation, which compresses the cortical, cerebral cortex, especially occipital cortex. So that also causes a transient obscuration of vision. So these should be clear.
Okay.
Okay. Otherwise, your presentation was nice.
Okay.
Of
Thank
course,
you.
the time was short. Okay. Thank you.
Goel, over to you, Subhashini.
Yes, sir. Good afternoon, everybody. Thanks for the opportunity. So, decoding diplopia mystery. Every clinician should be aware of the importance of an appropriate response to the symptom of diplopia. The reason being, the etiology can vary from an uncorrected simple astigmatism to life-threatening intracranial pathologies. Any patient presenting with diplopia should be examined carefully to exclude the possibility of any underlying sinister etiology. So the mechanisms of diplopia: ophthalmic aberrations causing monocular diplopia, ocular misalignment causing binocular diplopia, cerebral polyopia, and functional causes. The value of good history should never be underestimated in the differential diagnosis of diplopia. The first question is the diplopia monocular or binocular? The causes of monocular diplopia are the uncorrected refractive error, corneal disorders, iris trauma, media opacities like cataract, macular disorders, primary or secondary visual cortical disorders causing cerebral polyopia. How would the onset and progression of symptoms? On presentation of any acute oculomotor deficit, one of the most difficult but important decisions to make is whether it is of recent onset or it's due to the decomposition of a long-standing deviation. Some of the best clues can be obtained from the patient's response to specific questions like onset. Most patients with an acute onset diplopia know exactly when the diplopia started, the direction of gaze affected, and the separation of images, etc. If they have an anomalous head posture, they'll be able to, they often have an associated neck pain, and they normally attend for an eye examination immediately within a day or two after the onset of the symptoms. In contrast, patients with long-standing deviations, they find it difficult to specify about the any questions related to the onset of diplopia, and the description of image separations, everything will be very vague. So the anomalous head posture, if present, they may find it uncomfortable to straighten the neck. History of pain, trauma, headache at the onset, and ask about the stability and progression. Any associated symptoms: weakness and fatigue points towards myasthenia. Headache, the differential diagnosis will be intracranial causes, ophthalmoplegic migraine. Any history of vertigo and tinnitus. Previous episodes of poor vision to rule out multiple sclerosis. Previous ocular history, any history of surgery or trauma, prisms or occlusion therapy. If there is any history of prism prescription or hyperopic glasses prescription, that is a sure sign of compromise and of binocular single vision in the past. Medical and family history, vasculopathic risk factors, thyroid status, and muscular dystrophies. So coming to the examination part, Complete ophthalmic examination, including orthoptic assessment, should be done. Review the prescriptions, and monocular tests like monocular occlusion, visual acuity with and without pinhole, Amsler's chart. And coming to the external examination, look at the head posture. Is there any anomalous head posture like face turn or chin elevation or depression like that? And look for facial symmetry, lid position. Is there any ptosis or lid retraction? Check for lid function, lid closure. How will you identify the affected muscle? By Hirschberg test or corneal light reflex test. Cover test. The cover test should be done in 9 cardinal positions with and without refractive correction for both distance and near, and should be done with and without correcting the anomalous head posture. Ocular motility in terms of ductions, versions, divergences, saccades, and smooth pursuits, everything should be tested. And this is how we record the ocular motility clinically. And it's a small video on motility. Here is a young man showing signs of aberrant regeneration of third nerve in the left side. And look for intorsion. And so this is how we document photographically the ocular motility in all, preferably in all cases. And this is a test to check the cyclovertical deviations. This child has a yellow or R pattern, and Parkes 3-step test is being done. So the primary position shows left hypertropia, and the hypertropia seems to get worse on contralateral gaze, that is dextroversion. And it is abolished in contralateral head tilt, but becomes worse in the ipsilateral head tilt. So it's a case of LSO palsy. So examine the near point of convergence. Measurement of angle of deviation is very important by using prism bar cover test or double Maddox raw test. Check the fields of binocular single vision and do a diplopia and Hess charting. Pupillary evaluation is very important. Look for anisocoria and scotopic and photopic conditions. Reaction to light and accommodation should be noted. Check for any light near dissociation or any synkinetic phenomena. I'll skip that video. Is the diplopia due to mechanical restriction or neurogenic etiology? Look for the smooth pursuit movements. Are they smooth and symmetrical with an abrupt stop, or smooth with slow pursuits? If it is with abrupt stop, it indicates a restrictive pathology rather than a neurological etiology. And confirm the restrictive etiology by doing a force reduction test or an electromyography. Is the diplopia caused by central or peripheral neurogenic etiology? So look for, as Dr. Shweta explained, look for hemiparesis, cerebellar signs, or any other central nervous system signs if central etiology is suspected. And do a diplopia charting. A record of separation of diploping images in all the 9 cardinal positions of gaze. And this is just a sample of diplopia charting with a different muscle involvement. And Hess charting is based on foveal projection, based on the principles of Herring's and Sherrington's laws of innervation. It dissociates eyes by complementary colors. And it has to be used only for incompetent strabismus and should not be used alone for assessing incompetent strabismus. The patient must have normal retinal correspondence and central fixation to undergo Hess charting. So how to interpret? The following steps are useful. Which is the abnormal field? The smaller field is always abnormal. Is the field compressed? If compressed, consider mechanical causes. Which muscle is underacting? The greatest negative or inward displaced chart represents a primary underaction. And which muscle is overacting? The muscle with positive or outward displacement indicates an overaction. Is there any deviation in the primary position? So some of the examples of Hess charting: left thyroid, left fourth nerve palsy, right Brown syndrome, bilateral fourth nerve palsy, left orbital floor fracture, left Duane's type 3, right third nerve palsy. So double Maddox test is used for measuring the diagnosing the cyclovertical deviations and also for measuring the same. And look at the fundus picture here. This is an extorted globe. And coming to the causes of binocular diplopia: convergence insufficiency, accommodation spasm, decompensating heterophoria, incomitant strabismus due to neurological etiologies, supranuclear characteristics, which is Q deviation, other features, nuclear, internuclear, infranuclear, and neuromuscular junction pathologies like myasthenia gravis, myogenic etiologies like thyroiditis, lower fracture of flow of orbit, orbital myositis, Brown syndrome, and myopathies. So this, yes, sir.
Can you conclude?
Yes, sir. I'll just rush through some. So I have some examples, clinical examples I have shown. And to summarize, so diplopia evaluation may be daunting without a basic understanding about the mechanisms and anatomy involved in the ocular motility. Systematic approaches need evaluating diplopia can be interesting, uncomplicated, and rewarding. Thank you.
Thank you, Dr. Subhasini, for your wonderful presentation.
Thank you.
Time and running. Now we have to go to the another talk by Dr. Anu Jain. It's neuro-ophthalmic localized encephalopathy versus brainstem stroke. Are you ready? Are you ready, Dr. Anu?
Subhashini, just one question. Some of the patients of nerve palsies, they don't have head posture. The others they have. Is there any reason that some patients they don't have?
Sir, the head posture is sir, head posture is assumed either to have the best binocular single vision in that particular head posture, or to push the other image to the suppression scotoma, so that there is no confusion.
But why some people they have and others they don't have? Both are having palsy.
Probably the other has poor vision or amblyopic.
No, actually the thing is that unless and until the patient gets binocular single vision by head posture, they will never adopt head posture. Head posture, if the gain is there, they will adopt head posture. If they are not able to get binocular single vision by any head position, then they will never have. Secondly, the head is always tilted towards the hypotropia.
Okay.
Yeah, Dr. Anu.
Yeah, good evening, everyone. Am I audible?
Yes.
Yeah, okay. So there may be certain conditions, certain cases which have two main diagnostic possibilities, the lookalike diagnosis. And then one has to have that sharp clinical acumen to be able to recognize those specific distinguishing features between the two conditions. One such scenario is that of Wernicke's encephalopathy versus brainstem stroke. So let us start with going through this case. Here, a 39-year-old primary gravida, she presented to an ophthalmologist with double vision on awakening. She also gave history of not feeling well for about several days, being lethargic, disoriented, and slightly off balance. And she attributed all these symptoms to her severe morning sickness that she had for past 8 weeks. There was no other chronic illness or medication intake. Examination revealed bilateral ptosis, more so on the left side, and there was limitation of gazes in all directions of gaze. Slow upward saccades were noted. There was upbeat nystagmus, as well as small right hyperphoria. Mild ataxia was also noted. So the immediate provisional diagnosis that was made was that of brainstem stroke due to pregnancy-related hypercoagulable state. But then the patient exhibits both horizontal as well as vertical gaze deficits. And the centers for both these conjugate gaze, the horizontal and the vertical, they are in different places. One is in the pons and the vertical one is in the midbrain. So therefore, the patient must have either multiple lesions or there must be an entirely different pathology, a non-structural one. And the presence of confusion, being off balance, there was ataxia, it almost clinches the diagnosis of Wernicke's encephalopathy. So Wernicke's encephalopathy is a neurological syndrome caused by deficiency of thiamine. It usually remains unrecognized, more in so much so that in about 15% of the cases, they are only 15% they are diagnosed before death. It is characterized by a clinical triad of ophthalmoplegia, ataxia, and confusion. Thiamine is an important cofactor for several key enzymes of Krebs cycle and pentose phosphate pathway. So in thiamine deficient state, toxic intermediates, they accumulate. And on the other hand, thiamine deficiency also impairs the conversion of pyruvate to acetyl coenzyme A, which increases lactic acid production. So in a thiamine deficiency state, there's failure of thiamine-dependent energy pathways, and therefore there's inhibition of metabolism in those areas of the brain which have higher metabolic demands. And this all leads to neuronal damage, which leads to brain tissue injury. On the other hand, accumulation of toxic intermediates, that also leads to injured brain tissue. So these brain tissue injury, the lesions, they follow a symmetric distribution among structures that surround the third, fourth, and ventricles and the aqueduct. Most commonly affected structure being mammillary bodies. Lesions in the dorsal
I think it appears that we've lost Dr. Anu here. Dr. Goel, any further comments till she gets reconnected? Because we didn't discuss. So you need to unmute yourself.
I was just listening to it, so I thought that we'll give comments at the end. But
in the other, since we didn't have enough time for Dr. Subhashini's discussion.
Okay, we can go to the next one.
Yeah. So I think we'll wait for Dr. Anu to come back. Let's go to the next talk since we started a little late. Can we invite Dr. Anita Ganger? Can you start your talk, please?
Yes, sir. Very good evening to everyone. I would like to thank DOS for giving me this opportunity. Yes. My slides are visible, sir?
No. Not yet.
No. Yeah.
Yes, now it's visible.
Visible?
No, it is not visible here. It's not visible here.
It's visible now, sir?
Yes.
Yes.
Okay. So very good evening to everyone. Today I'll be discussing the role of OCT in neuro-ophthalmological conditions. I have no financial interest disclosures to be made. So this is just the OCT picture, what we get while doing the OCT, and this is just the basic patient details. This part tells us whether we are examining the macula part or the optic disc part. This is the fundus photo with the thickness overlays. This is the fundus image, the grayscale. These are the slice cut from the temporal to nasal, inferior to superior. These are the normative data with the color codings. So in neuro-ophthalmological conditions, OCT represents a surrogate marker of the neuroaxonal integrity in the afferent visual pathway. It helps us in diagnosing the disease monitoring, and prognosticate the information. Most valuable markers, structural parameters are retinal nerve fiber layer thickness and the ganglion cell layer thickness. In optic neuritis, it can be used as a quantitative tool to monitor the disease and treatment. Initial spike in RNFL thickness due to exoplasmic flow can mask the earliest signs of axonal degeneration. And here comes the role of seeing the GCL layer thickness, where we can see the macular volume and inner ganglion cell layer thickness, thinning of which can further tell us whether the axonal damage already occurred or not. So this is one related study where the evaluation of changes in the retinal nerve fiber layer thickness and visual functions have been studied in the optic neuritis and multiple sclerosis patients. And they concluded that RNFL thickness is reduced in optic neuritis and multiple sclerosis patient with or without optic neuritis. And the pattern was similar to the Caucasian eyes. So I was a part of the study. We evaluated the retinal nerve fiber layer and GCL layer changes on OCT in a very early multiple sclerosis patient and optic neuritis cases. And we concluded that GCL IPL thickness is a more sensitive clinical structural marker than the RNFL in early multiple sclerosis patients, either with or without optic neuritis. And it correlates very well with all the visual parameters better than RNFL. So there is a floor effect with OCT which limits the detection of progressive RNFL ganglion cellular loss above 30 to 50 microns. So it should not be interpreted in isolation. After MS, there are future role of OCT in other neurodegenerative diseases like Parkinsonism, Alzheimer's. Now comes to the NMO spectrum diseases, how we can differentiate between the MS and this. RNFL affected in all the peripapillary quadrants in NMO disease, where even in the earliest phase, whereas in MS, initially the temporal quadrant is involved. Normal RNFL values in the absence of optic neuritis we can see in NMO, whereas in MS, even without the optic neuritis attack, the RNFL thickness is abnormal most of the time. Mean RNFL loss in multiple sclerosis patient is around 20 microns, whereas in NMO, it's much more, 55 to 83 micrometer. So higher prevalence of microcytic macular edema we can see in NMO spectrum diseases. So now comes to the ischemic optic neuropathies. OCT can be used to identify the treatment effects. Thickness of macula, OCT and ganglion cellular is expected to provide a better structural indicator of axonal preservation or loss. And yes, distinctive altitudinal pattern of GCL loss, which corresponds to the altitudinal visual field effect. So there are some examples. This is a patient of multiple sclerosis with optic neuritis in the left eye, and we can see there is a temporal quadrant RNFL thinning. So this was a case of 21-year-old female patient who had optic neuritis in the right eye and showing the RNFL thinning. So here, this was a case of left NAION. In acute stage, as we can see, the RNFL thickening is masking the axonal loss. But if we will see the GCL layer thickness, it is decreased. So it is telling us that yes, axonal damage has occurred. So this was a similar case of left eye NAION 3 years back, which is showing the thinning in the superiotemporal sectors. So now comes to the papilledema. Papilledema changes in the optic disc edema over the period of time can be better quantified by seeing the RNFL thickness. RNFL measured with traditional OCT scan cannot sometimes differentiate whether the disc edema is decreasing due to the reduction in ICP or it is because of the ongoing axonal loss. Here again, then comes the role of GCL thickness. So this was the case, IAH patient with papilledema, which is showing the normal GCL layer thickness. That means it is a better prognosis case that when the edema will go, the prognosis of this patient is good. Whereas the another patient where the RNFL thickness is higher because of papilledema, whereas the GCL is thickness, GCL is thin. So that is, it is a bad prognosis case. So Mark Cooper-Smith et al., they have documented one angle in which they had shown in papilledema patients showing the inward angulation towards the vitreous of the RPE and the basement membrane relative to the peripapillary regions. And this angulations can be seen in sequentially that whether the edema is going or not and this angulation is decreasing or not. So how to differentiate between the papilledema and the optic disc drusen? Thinning of the RNFL and GCL we usually see in the optic disc drusen, contrary to the increased RNFL values in the papilledema. And another thing is a subretinal hyporeflective space between the RPE and choriocapillaries suggestive of the ODD. And for buried optic disc drusen, we can use the enhanced depth and the swept source OCT, which can improve the diagnostic detection. Similarly, in the LHON patients, if the axonal damage is there, which we usually see in the chronic patients and acute, so we can see the thinning, GCL and RNFL thinning, and similarly in the optic atrophy patients. So this is something new, OCT in the pituitary tumors. Here the Chen et al. Have documented that nasal hemiretinal ganglion cellular thinning. Like here, we can see in a pituitary tumor patients even before the visual field defects. So if we are suspecting or we have come across about the patients who have documented pituitary tumor or not documented, but if we are seeing these kind of pictures like hemiretinal thinning of ganglion cellular, we should be suspicious about the tumors because this comes before the visual field defects. So how to avoid artifact? We can see properly the name and age of the patient, signal strength, refractive error should be checked before doing, look for the presence of any rectangular areas of absolute RNFL loss, so which do not match the anatomical distribution. And how we can avoid, we can check for the cyclotorsion, and we can see the local areas with thickness less than 40 mm, which are typically due to the errors in the segmentation. So OCT is a very good investigations nowadays in neuro-ophthalmological conditions till the OCT-A will come into the picture, which will further add up into the information. Still, it is in the research period only. So thank you so much for the kind attention. Thank you.
Thank you, Dr. Anita, for this wonderful talk.
Thank you.
Ask and invite Dr. Goel to present his talk on understanding electrophysiology. Sir, please.
Okay, thank you. My slide is visible?
Not yet, sir.
My slide is visible?
No, sir. It's not visible.
My slide, it's not visible?
Not yet.
Not yet.
Just call the next person and then I will arrange it.
You are visible, that's what I say, not your slide.
गोयल सर, पहले आप स्टॉप शेयरिंग कर लीजिए, उसके बाद जूम को मिनिमाइज कीजिए और बैकग्राउंड में जाकर के अपनी प्रेजेंटेशन प्ले करके वापस ये जूम पर फिर स्क्रीन शेयर कीजिए.
अच्छा, जूम पे वापस आके फिर कर.
पहले जूम मिनिमाइज, पहले स्टॉप कर लीजिए अगर अभी शेयर कर रखी है तो स्क्रीन.
अच्छा.
देन उसके बाद आप बैकग्राउंड में जाकर के अपनी प्रेजेंटेशन को स्टार्ट कीजिए.
एक मिनट, मैं अब स्लाइड शो दोबारा ऑन करता हूँ. Are they visible? No.
Shall we start with the new next talk?
In the meantime, you can start.
Okay. May I invite Dr. Manisha for her talk, please? She's going to talk on VEP.
Yes. Don't you listen? Listen.
Is Sobita ready with her talk, Sobita?
Yes, sir.
Can we start with your talk? Meanwhile, Dr. Jawad and Dr. Manisha would sort out the issues. Dr. Manisha, can I start with...
Yeah, and just a minute. I'm starting.
Should I minimize?
Starting, meanwhile, you can sort it out. Let Sobita complete her talk so that we don't lose time.
Right.
Sir, is my presentation seen?
Yes. You can just make it full screen. Thank you, Sobita.
So good afternoon, everybody. Am I audible, sir?
You are. Yes.
Good afternoon, everybody. I would thank DOS for giving me this opportunity. So I would begin with imaging in cranial nerve palsy and would be discussing under these headings: anatomy, indications, the different sequences required, the imaging findings, and some clinical scenarios. So we were already dealt with the anatomy in detail by the first speaker, but we all know that there's a complexity in the anatomy and function of all 12 pairs of cranial nerves. The nuclei of all the cranial nerves, except the first and second, are located in the brainstem. So just to revise, the third and fourth are from the midbrain, the fifth is from the pons, and the sixth, seventh, and eighth are from the pontomedullary sulcus, and the lower cranial nerves are from the medulla. So however, to relate it with radiological correlation needs the division of these cranial nerve cores into 3 types of lesions, like intraaxial, extraaxial intracranial lesions, or extracranial. This is important because there's always a close relationship between the lesional location and the symptoms. So if it's intraaxial, it will affect the cranial nerve nuclei and the intramedullary fibers. If it's extraaxial intracranial, as it leaves the brainstem and proceeds forwards towards the cavernous sinus. So the cisternal and the intraforaminal cranial nerve fibers, and then the extracranial is the orbital as it supplies the muscles. So this table now shows that we can divide it into 3 areas like CNS coverage, skull base, and face and neck coverage. Since I would be restricting myself to 3rd, 4th, and 6th cranial nerves, which we deal mostly. So here we see the 3rd nerve, it is the brainstem. Sorry, the 3rd nerve is the midbrain, then midbrain tectum is for the 4th nerve, and pons for the 5th nerve, and medullopontine as discussed for the 6th nerve. At skull base, it is the middle skull base, cavernous sinus, and superior orbital fissure, which remains the same for the 3 cranial nerves. But what are the indications for imaging? Young age, associated neurological symptoms, absence of vascular risk factors, presence of multiple cranial nerves involvement. If ischemic palsy does not resolve by 2 to 3 weeks, pupil involvement in a 3rd nerve palsy, or a recurrent palsies. This was a paper on 2017 ENT journal, where they have given guidelines as strong recommendations for imaging or strong recommendations against imaging. Coming on to 3rd nerve, this was recommended against imaging, that in patients greater than 50 years with atherosclerotic risk factors, with pupil function being intact, imaging should not be obtained. However, it is recommended that all the pupil involving 3rd nerve palsies need imaging in form of MRI. I would add it is MRI plus MRA with contrast, whether it is complete or incomplete palsies. In cases of 4th or 6th nerve palsies, even if it's isolated 4th and 6th nerve, so it is optional or recommended to do imaging. In cases of Bell's palsy, if the findings are inconsistent with classical Bell's palsy lesion, then we need to image. So what are the imaging protocols? MRI, as we all know, is the best imaging modality for cranial nerve disorders, because it gives better soft tissue visualization. CT is better for bony lesions, and specifically in cases of trauma, inflammation, or in patients with compromised airways. The protocols has to be adjusted based on the anatomy, and a contrast has to be injected to get a better delineation. But the best way to detect cranial nerve pathology is to compare the size and signal of intensity of the paired nerves. The thumb rule in all ophthalmological cases is compare the same section, both the sides. So this imaging this is a study which gave us what were the sequences. So for brainstem lesions, T2 weighted and DWI. For cisternal segment, it is heavily weighted T2 weighted, which are further modified as steady-state fast precision sequences. And if their segments are surrounded by venous plexus or intraforaminal fibers, it is T1 weighted and FFE sequences. And at the orbital level, it is T1, T2. So a thorough knowledge about cisternal segment is necessary, because here we need to modify our sequences in terms of heavily weighted 1 mm cuts. So this is modified as SSFP because it gives us an augmented visualization of the nerves, and CIS and Fiesta are the sequences which are supposed to be ordered, which is constructive interference in steady state or fast imaging employing steady state. They will give us thinner sections at a shorter imaging time. CIS and Fiesta are similar things, but these are the names given different by the different machines or the vendors. So what planes are needed? For brainstem, it is the axial plane, and for cisternal segment, again, it can be reformatted in any plane. If it is cavernous sinus, and coronal sections will give a better visualization, and if it is orbital, axial, coronal are sufficient. So this is how this in the CIS sequence, the third nerve looks. This is the pons midbrain from where it arises, just above the periaqueductal region. This is the appearance of a Mickey Mouse where we see, and this is the course of the third nerve. The fourth nerve, if we see, it's the posterior midbrain, and this, if we resemble a house, this is the dorsal course of the fourth nerve. This is a Christmas tree appearance, which we remember, and this we can see the sixth nerve appearance in the terms of at the level of the medulla. So cis sequence will tell us about congenital absence and neurovascular compression of cranial nerves. It will appear as dark cranial nerve. Post-contrast T1 images will tell us enhancement of cranial nerves surrounded by the CSF in inflammatory pathologies. T2 weighted flare sequences are also gives us incomplete suppression of and the flow artifacts are overcome, and multiplanar reformation will give us proper correlation about the brainstem vascular structure and skull base foramina. So in third nerve palsies, this is now some examples where we see this is the course of third nerve. Here it is between the posterior cerebral and the superior cerebellar artery. So these are some examples where a 38-year-old female presented with known case of multiple sclerosis and presented with bilateral third nerve palsy on imaging axial T2 flare MRI shows a hyperintensity demyelinating plaque involving the periaqueductal midbrain. Another 53-year-old female presented as right incomplete third nerve palsy with contralateral ataxia, a diffusion weighted, elderly female diffusion weighted shows an acute ischemic infarction, and this would definitely be involving oculomotor nucleus, the red nucleus, a case of Claude syndrome. This is another 68-year-old female with right complete third nerve palsy. A Fiesta image here shows that the third nerve is compressed. Here we can see the third nerve course, but here it cannot be seen. And in MR also, the MRA shows the right posterior communicating artery aneurysm. Now, this is a 20-year-old female who had bilateral asymmetrical ophthalmoplegia, facial pain, ataxia, and bilateral deafness. We can see nodular enhancing lesions along the third, fifth, and eighth nerves. This was a case of neurofibromatosis. This is how the fourth nerve appearance looks in a cis image, just to revise. And it is a DWI image in a 45-year-old male who had vertical diplopia, presenting with posterior midbrain infarct corresponding to the trochlear nucleus, suggestive of recent ischemic lesion. Another 45-year-old female with left hypertropia fitting into left SOP. Now one image shows multiple areas of enhancement here along the tentorium as well as along the posterior infracerebellar hemispheres and enhancing to the superior orbital fissure, which was suggestive of pachymeningitis. In sixth nerve, cranial nerve, as we have seen already, this is the course of the sixth nerve, and the most common lesion where sixth nerve is absent, as we see here, is in the case of DRS. The other lesions where we see here is an adolescent girl of 16 years who presented first with facial palsy, vertigo, and nystagmus. With T2 weighted 3D flare images now shows that focal hyperintensity of the facial nerve and the vestibulocochlear nerves and also the abducens nerve. This is a case of CNS involvement in acute leukemias. This is another case who presented to us a young female with recurrent a non-resolving sixth nerve palsy. In a 30-year-old female, on imaging, we found she had a thrombosed aneurysm of the cavernous segment of the left ICA. This is an example of multiple cranial nerve palsies where the left eye has ptosis, limitation of all the movements, a case of external ophthalmoplegia with decrease of sensations around V1, V2, but hearing was normal, and on imaging, she has enhancement along the cavernous sinus, a lateral wall, and the superior orbital fissure was a case of Tolosa-Hunt syndrome. So the take-home message is MRI, cis, Fiesta, the modality of choice to investigate a cranial nerve disorder. CT is useful to depict calcification or skull lesion in cases of trauma. Add MRI and CTA when painful cranial nerve disorder, and the correlation of clinical history, presentation, and biological tests and imaging interpretation is necessary to localize the lesion. Thank you.
Thank you, Savita. Dr. Jawahar, are we ready? Okay, Dr. Manisha is sorting out their issue with the slides. Let's have a little discussion for the talks. Bashini, would you like to add to what that was meant about imaging in cranial nerve palsy? Would you advise imaging in somebody who is, let's say, 50 years of age with a sixth nerve palsy and with vasculopathic risk factors?
Sir, you're asking me?
Yeah, Subhashini.
Yes, sir. Yes, sir. So, 50-year-old patient with a vasculopathic risk factors with isolated sixth nerve palsy, I would wait. I will not image.
Yeah, absolutely. So the point which Savita mentioned is that when you see any cranial nerve palsy, we are talking about sixth nerve. So first thing to make sure is that you have to make sure that it's an isolated mononeuropathy, that none of the other cranial nerves are involved. And the nerves that you would test in your clinic would be, of course, third and fourth you would have tested, second you would have tested, but the extra nerves that you will test would be 7th nerve, 5th nerve, 8th nerve, and also cerebellar function, because these are the nerves which can be associated. Once you have made sure that these nerves are not involved, and if the age is above 50, you have a vasculopathic risk factors, you probably can wait, but you have to make sure that you get the patient back frequently, so that you make sure that none of the other nerves are getting involved during the follow-up, because there's a possibility that if there's a slow expanding lesion, let's say in cavernous sinus, it can be initially only the 6th nerve, the other nerves can be involved later on. Good. Dr. Goel is, I think, ready with his talk. So I invite Dr. Jawaharlal Goel for his the topic that he's known for, electrophysiology. Sir, all yours.
Unmute. Dr. Rashmin, should I? Hello.
We can hear you, sir, and we can see your screen.
Should I start?
Please, sir. Please, sir.
So, good afternoon, everyone. I will be talking on understanding electrophysiology. So photic stimulate generates two types of potential. Either they are corneofundal, which will be picked up by ERG and EOG, and the scalp potential is measured by VEP. The clinical application includes that it can be used to know the site of lesion, like pigment epithelial lesions. They are affected in C wave in ERG, photoreceptors A wave of ERG, inner retinal layers B wave of ERG, and ganglion cell layers, they are picked up by the pattern ERG, and optic nerves, they are picked up by the VEP. So we are also using electrophysiology to diagnose retrobulbar neuritis, especially when the fundus is normal, and to know the extent of damage in retinal degeneration, toxic and nutritional neuroretinopathy. And we can serially do electrophysiology to know the effect of the treatment. For visual assessment in non-verbal children and unconscious patients, you can use electrophysiology VEP. To prognosticate the visual outcome in vascular retinopathy, like central retinal vein occlusion, diabetic retinopathy, and siderosis bulbi, you can use ERG. The VEP is used in traumatic optic neuropathy to give the prognosis, and before penetrating keratoplasty to know whether the optic nerve is normal. It is also used to diagnose malingering, especially in convicts and patients with claim issues, and because this is the only objective test which you can put in court also as an evidence, and also to know the cause of visual loss in normal looking fundus. We use both ERG and VEP. This is the equipment we are using, and this is the stroboscopic lamp for flash ERG. This is Gans field stimulator, and this is the monitor for pattern stimulus, and this is the computer for amplifier, and this is the oscilloscope for evaluating the visual potentials. And these are the electrodes which are being used. This is surface electrode by silver chloride electrodes. These are LED goggles for children, VEP, and this is ERG jet electrode, which is a contact lens electrode for flash ERG, and this is gold foil electrode for pattern ERG. This is how we place the electrodes for flash ERG. This is the jet electrode, and this is the reference electrode, and this is the ground electrode. So basically, ERG may be flash ERG, in which you may do scotopic ERG by in dark adapted state, and you are using the dim light or blue light where the cones will not fire. So you will get only scotopic ERG rod function. Photopic ERG is done in light adapted conditions with bright light, and cone ERG is done with 30 Hz flicker, means it's a very fast stimulus at which the rods, they will not fire, only the cones will fire. And oscillatory potential is basically the wavelets on the upper ascending limb of the B wave, and this is used for inner retinal ischemia. Pattern ERG and multifocal ERG are the other types of ERG. This is scotopic ERG. As you can see, the wave is very broad and the amplitude is very high. And this is A wave, this is B wave, and this is C wave. And this is photopic ERG, where you can see that the B wave is the amplitude is small and it is a thinner and weak wave as compared to photopic ERG, because scotopic ERG is generated by rods which are 120 lakhs, and photopic ERG is generated by cones which are just 5 lakhs. So that is why the amplitude is small and the waves are thinner. Indications of ERG are retinitis pigmentosa, congenital stationary night blindness, Leber's congenital amaurosis, gyrate atrophy, vascular occlusions, especially in diabetic retinopathy and CRVO, drug toxicity, rod and cone dystrophies, retinal assessment after trauma, and vitamin A deficiency, and melanoma associated retinopathy. So in retinitis pigmentosa, ERG changes, they appear years before changes in the fundus, and B wave is important and is markedly reduced in retinitis pigmentosa. And relatives of RP patients who at the age of 6 years or higher, they have normal ERG, they do not develop retinitis pigmentosa. This is the common questions the parents will ask, whether my child will develop retinitis pigmentosa like me or not. Autosomal recessive carriers, they have normal ERG, but X-linked female carriers, they will have subnormal ERG. This can be used for genetic counseling. So you can see the siderosis bulbi in this eye is markedly attenuated as compared to normal ERG in the other eye. And pattern ERG is response of central retina to pattern stimulus. And the waves, the two important waves are P50. This is a positive wave at 50 millisecond. And this is the N95 wave, negative wave, which is used for ganglion cell function. So P50 is basically affected in macular diseases like central serous retinopathy, macular hole, iridomacular degeneration, or age-related macular degeneration. While N95, this wave is affected in cases of ganglion cell diseases like glaucoma and compressive neuropathy, where the ganglion cell loss is there. Pattern ERG in central serous retinopathy, we had done a project in which we had seen that in CSR, macular photoreceptors, that means the P50 wave is affected in acute stage and which returns to near normal after treatment. This was published in Document of Ophthalmologica. And we had done another study in pattern ERG in compressive chiasmal lesions before and after the removal of the tumors. And if we have seen if both pattern ERG and pattern VEP both are abnormal, it indicates poor prognosis. While normal pattern ERG with abnormal pattern VEP means that the ganglion cells, they are still preserved, and that is associated with better visual outcome. So it prognosticates visual outcome after removal of tumor. So this was also published in Clinical and Experimental Ophthalmology. And we have done a study on pattern ERG in open angle glaucoma also. This is the normal N95 wave. You can see very large wave which gets attenuated in open angle glaucoma. So, but we have seen that the pattern ERG can be used as a diagnostic tool for early detection of glaucoma and can detect patients among glaucoma suspects who are destined to develop glaucoma in future. So if the pattern ERG is abnormal, these patients, they should be followed up very carefully. This was presented in AIUS. In diabetic retinopathy also, we have done a study, and we have seen that with progression in the severity of the diabetic retinopathy, both amplitude of P50 and N95 of pattern ERG, they decrease. This indicates that the pattern ERG is a sensitive parameter in the evaluation of diabetic retinopathy. This was also presented in AIUS OC. And this is another study in which we have done the oscillatory potential also in diabetic retinopathy. You can see in mild to moderate diabetic retinopathy, the oscillatory potential is attenuated. The red one is attenuated as compared to the normal, the other side of the other eye of the patient. Oscillatory potential, we have seen that it markedly affected or disappears in inner retinal ischemic conditions like CRVO and diabetic retinopathy. In diabetic retinopathy, it prognosticates which case from pre-proliferative diabetic retinopathy will progress to proliferative diabetic retinopathy. It also differentiates ischemic from non-ischemic CRVO. In non-ischemic CRVO, this will be oscillatory potential will be normal. So this was also presented in AIOC. And 30 Arts flicker also we have seen that in CRV or ischemic conditions, as you can see here, and the yellow one that is attenuated by approximately half as compared to normal other side, which is non-CRVO. And 30 Arts flicker again is affected in cone dystrophies and macular diseases, rod cone dystrophy and CRVO. And in diabetic retinopathy also 30 Arts flicker is affected. So in lastly, multifocal ERG, here 61 to 103 multifocal hexagonal stimuli are projected onto the retina in a random fashion. And this is what we get. The 61 to 103 ERGs, small ERGs, they are extrapolated by the computer. And these ERGs, and this is the 3D plot of multifocal ERG with a central foveal peak, and this is blind spot. And basically ERG, multifocal ERG gives only central 30-degree retinal evaluation, and basically it evaluates the cones only because the rods, they do not fire at them. In multifocal ERG, this is what we see in age-related macular degeneration. You can see that the peak of the age-related macular degeneration, the 3D plot peak, foveal peak has gone, but surrounding retina is normal. Here you see the waves, they are irregular or flat in the central area, but in the peripheral area, you can see that they are normal. So that happens in age-related macular degeneration. And the same thing happens in CSR. You can see the central flat ERG and the peripheral normal ERGs. And the similar thing happens in the macular hole also. The peak has gone. And in retinitis pigmentosa, it is retinitis pigmentosa, it is the other way around. The central peak is preserved, but the peripheral retinal layers, they are degenerated. So is the electrophysiologic trace array seen here. You can see that this peak is normal. This ERG is normal, while the peripheral area, the ERGs, they are virtually flat. So to summarize, the flash ERG is basically used for retinitis pigmentosa, siderosis, toxic retinopathy, vitamin A deficiency, Leber's congenital amaurosis, congenital stationary night blindness, and unexplained visual loss. Pattern ERG is done in cases of macular diseases, glaucoma, central serous retinopathy, and compressive neuropathy. Oscillatory potential is done in diabetic and ischemic retinopathy. Cone flicker is done in cone dystrophies, diabetic retinopathy, and central retinal vein occlusion. And multifocal ERGs for localized retinal diseases, and EOG, which is rarely used only for one condition, that is Best disease. So ERG is basically a very important tool for functional assessment of retina. Thank you.
So much, Dr. Goel, as crisp and as informative as ever. I think we'll have the next talk, and then we'll have a discussion at the end of it so that we have enough buffer and time. So may I invite Dr. Manisha to deliver her talk on VEP.
Yes, I would. It's not allowing me to share the screen.
Now it's all right?
No.
Try now.
No. Okay. I think I will do. Just a minute. Now you will be able to do it.
मैम हमको अलाउ कर दिया है, आप शेयर स्क्रीन कर सकते हो।
It's not getting, I'm not getting it. My screen. Sir, have you unshared your screen?
Yeah.
Okay.
So, Dr. Jawar, if you have to order, if somebody has to order the electrophysiological test, if they are seeing the patient and they are not very sure whether patient has a visual pathway lesion, patient has a retinal problem, what kind of package they should advise?
Initially, one should advise ERG. If the electrophysiology is available, then first is requirement is ERG. Because if ERG is abnormal, VEP will always be abnormal.
Yeah.
So healthy retina is a must for VEP to be normal. So then, of course, if you are able to see the optic nerve, there is a pallor, then of course you will advise first VEP. But if the optic nerve looks healthy, but the retina is either normal or there is a doubt, then you should always advise the ERG. And secondly, you see whether there is a global retinal problem in the appearance, then you should advise a flash ERG. And if there is only macular stippling or macular lesions they are present, then you should advise pattern ERG. And similarly, if there is a retinopathy, then specifically you have to advise the patients the specific test. For example, in diabetic retinopathy and vascular occlusion in ischemic retina, when there is inner retinal ischemia, then you should advise the advanced test like pattern ERG or oscillatory potential. So because they are basically, they respond to ischemic retina, so they will disappear. Especially oscillatory potential is the first thing to disappear if there is a retinal ischemia. So that quantification should be done. And then especially, as I have mentioned, that non-proliferative diabetic retinopathy, the getting electrophysiology done, which is very important, because if the electrophysiology is impaired in these patients, then they should be followed up closely, because these are the patients who will develop proliferative diabetic retinopathy subsequently. While those patients who have normal electrophysiology, so these patients, they may be followed up leisurely at 3 months to 6 months, because they will not develop a proliferative diabetic retinopathy. So while everyone is after OCT, but to me that OCT gives you the picture after a month or so. It is not immediate. While electrophysiology is instantaneous, because as soon as the vision loss is there, the electrophysiological changes, they will appear.
Thank you. Thank you so much.
Okay.
Thank you.
Thank you.
Dr. Manisha, all yours.
Can you hear? Am I audible?
Yeah.
Yes, you're audible. We can see your screen as well.
Yeah, thank you. I thank, first of all, DOS team for inviting us for this talk, and also Dr. Rashmin and all the eminent faculties, including Dr. J.L. Goyal. He's always there for us for physiology. Thank you so much, sir. So
Thank you. Thank you.
So this is on VEP, different and interesting case scenarios. We all know this is the visual pathway, and visual evoked potentials are nothing but electrophysiological signals which are extracted from the electroencephalogram activity in the visual cortex, macula, and recorded from the overlying scalp. Functional integrity of the central vision at any level of the visual pathway from eye to visual cortex, including the retina-optic nerve, optic radiations, and occipital cortex. So anything goes wrong in this pathway is detected by visual evoked potentials. So we know it's two types, flash and pattern. Flash VEP, it is elicited by a brief flash that subtends a visual field of at least 5 degrees. and it is presented in a dimly illuminated room. It indicates whether the visual cortex is able to perceive any defect. It is useful in when the best visual acuity is less than 6/60 in children, in poor cooperative patients, and in hazy medias. So this is the mini Gans field. Pattern VEP is recorded by using some pattern stimulus displayed on screen, which is usually in the form of a checkerboard. And their pattern on-off phenomena is used, or pattern reversal. Pattern reversal is considered better. So this checkerboard pattern is abruptly exchanged with the diffuse background, which is presented on and off in cases of pattern onset offset type of VEP. It is best suited for the detection of malingering and for use in patients with nystagmus. Pattern reversal VEPs, they are mostly used for the purposes when there is less variable waveforms and the timing, and then the VEP is elicited by other stimuli. Preferred stimulus when the best corrected visual acuity of the patient is a 6/60. It depends upon form sense, hence it's a rough estimate. Black and white check change phase abruptly at a specified number of reversals per second. So this is the machine where we do. So we know what is the latency. It's the time taken for the stimulus to reach the occipital cortex. That is the time interval between stimulus onset and beginning of wave response. Normal latency is up to 110 milliseconds. And in amplitudes, normal value of amplitude is 5 to 10 microvolts. Serial measurements may be useful to monitor the course of the optic nerve. So this is the normal waveform of pattern VEP. These are showing, the screen is now showing the robust pattern. First is the N70, which is the negative wave, and P100 is the wave which is generally got from the macular area, and N35, it is the 135 is the negative wave. So these are good waves shown here. They are normal pattern VEP. Then is the pattern reversal VEP, and the pattern reversal VEP waveform. It consists of N75, P100, and N135 peaks. The P100 is usually a prominent peak that shows relatively little variation between subjects. So this is considered in all the clinical use. The main measurements are of the size and timing of P100 component. Amplitudes can be measured as N75 P100 wave, or P100 or N135, or as the mean of two measures. Waveform of flash VEP, the most robust components of the flash VEP are the N2 90 milliseconds and P2 at 120. And measurement of P2 amplitude made from the positive P2 peak at around 120 milliseconds to the preceding N2 negative peak at around 90 milliseconds. You can see the wave in the screen. Then what are the clinical applications? In optic neuritis, we use the latency of P100 is increased and amplitude is decreased in the acute diseases. Compressive optic neuropathies, traumatic optic neuropathy, and ischemic lesions can be found with this VEP. And measurement of visual acuity in infants, mentally retarded, and aphasic inarticulate patients, we use VEP, and in malingering and hysterical blindness too. Assessment of visual potential in patients with opaque media is very, very useful. In children also, as I said, it is a very important machine for knowing the visual potential of the patient. Useful in unexplained visual losses, and to some extent in amblyopias, where ERG is also done along with it. In cortical blindness and in some toxicity like hydrochlorine toxicity, these are used. So again, this is the waveform of a normal VEP. Nice, good waves are there in this picture. And we see that the P100 is N95 up to 100, 104, which is very normal. And N75 P100 is having very robust waves, and 12 microvolts is the amplitudes in all these right and left waveforms in both the frequencies. The optic neuritis, this is a case with optic neuritis, and the patient presented with recent onset of diminution of vision, both eyes with hyperemic disc, with disc edema on fundus examination. VEP showed normal latencies and reduced amplitudes. We can see very well the amplitudes are very small and the latency is increased. The size of the wave has increased. Then is the traumatic optic neuropathy. Again, we can see the amplitude is affected much more than the latencies, and this is very typical of traumatic optic neuropathies. These are other examples of case 2 and 3. We can see the small waves are there. Traumatic optic neuropathy, we can see that the waves are very small. It is all affected waves. Then is the orbital cellulitis with optic nerve compression. A patient presented to us with orbital cellulitis with RAPD, And we saw that in the right eye, there was decrease in the size of the amplitudes. And the latency was much higher, 130. So this was the case which was detected along with the oculoplastic surgeons. We were telling them that now they should go for this or that by telling them the VEP component of the patient, the potential in the eye. Cortical blindness patient also again is showing the waves are decreased. The size amplitudes are 3.09 microvolts, which is very less. This again goes in favor of cortical blindness at the macular level. Then is the diabetic papillopathy. Again, we can see the very, very less microvolts. The amplitudes are decreased to a great extent in the left eye. Then in the retinitis pigmentosa albicans, again, you can see, here you can see on the screen that 1.52 or 2.28, this is very less microvolts. The amplitude is much decreased. So in retinitis pigmentosa albicans, along with ERG and EOG, sometimes we do VEP in all the cases to know the visual potential, especially in the cases of medical board cases, we have to do this. And latencies are much higher, 130. That's so significant. Then in cases of multiple sclerosis, the latency is much more affected than the amplitudes. And this is where VEP plays its major role in detecting when there are plaques in the MRI. So we can tell in a very early stage that yes, the patient is going to get multiple sclerosis. We all know this is an important disease where VEP is very, very important. Then is the optic atrophy. The latencies here are 115, 120, and the amplitudes, we can see they are very small. There are no robust waves, and the size of the waves are also increased to a larger extent. And this is 2.89 and 2.1. This is the microvolts, and is the amplitude of the disease. So thank you so much. This was just to show how VEP is seen in cases of different diseases. Thank you, Dr. Rashmi, for this kind opportunity. Thank you.
Thank you so much. Thank you, Dr. Manisha. And we do have around 5 to 7 minutes. So we had a bouquet of talks, which was mainly concerned with diplopia, cranial nerve palsies, and imaging in those conditions. And then we had talks on investigations starting from OCT, and then ERG, and then VEP. So Dr. Goel, would you like to first comment on all the talks so far, and then we'll go to the other panelists as well?
The topics, all the topics, they were very nicely covered, and the speakers, surprisingly, they had very good material to present in this conference. And I was very glad to see so many good slides and good case presentations by every speaker. So I must congratulate all the speakers for their preparations. Now, the thing is that in Manisha, in VEP also, one thing is that, as you have already mentioned, that pattern VEP should be done only when the visual acuity is better than 6/60.
Yes.
And flash VEP should be done in all those cases where the vision is very low, when just counting finger. So those patients, they should not be taken up for pattern VEP, otherwise a false reading will be there.
Yes, sir.
Secondly, pattern VEP is much more consistent than flash VEP, as you have also pointed out.
Yes, sir.
Because flash VEP, it gives you just presence or absence of vision.
Yeah.
While a pattern VEP gives you the quantitative assessment of the optic nerve or occipital cortex function. So one more point is that in you have shown in cortical blindness also, the VEP is affected. But in if there is a unilateral posterior cerebral artery thrombosis, we have done VEP in plenty of cases. If there is a supposedly right posterior cerebral artery thrombosis and there is a left hemianopia, then the VEP will be normal. But if cortical blindness occurs when both sides they are affected,
yes.
then only, so in those cases it will be affected. But even in hemianopic hemianopia, in those cases you should use 5 pole VEP rather than single pole VEP. Because instead of a single occipital cortex electrode, active electrode, you use 5. That means if there is a hemianopic condition on one side, so you can differentiate between the two sides. So there will be, the VEP will be affected on the hemianopic side as compared to the other side. So in all post-chiasmatic lesions, you should do this 5-pole VEP instead of single pole.
Right,
so that's what we are doing normally.
Well taken, sir.
Okay. So for global functions, global retinal problems, always order flash VEP, and for central retinal problems, you order either pattern VEP, pattern ERG, or you should order the multifocal ERG, because they give you the central retinal function. So, but only thing is that electrophysiology is the most neglected field in ophthalmology. It's a big scotoma, and that too is absolute. If you ask any glaucoma specialist, what are the electrophysiological changes in glaucoma, nobody will be able to answer. Similarly, you ask any retina specialist, what are the electrophysiological changes in diabetic retinopathy, pre-proliferative, early diabetic retinopathy, they will not be able to answer. But although this is the branch which gives you instantaneous functional derangement will be picked up by electrophysiology, it can never be picked up by any OCT or any other thing, because the structural changes, they will always come later. If there is a visual loss, sudden visual loss, and you do OCT on the 3rd day, 4th day, you will never pick up anything. And if you do electrophysiology, it will give you gross derangement, and that it goes hand in hand with visual acuity. So that the one which should have been the most important is the most neglected branch of science in ophthalmology.
I had one question.
Yeah.
So you are a great contributor towards electrophysiology, sir.
Yeah.
So I'm also doing retina most of the times, but as part of my job, I do this electrophysiology. And so whenever I have problem, you know, I have to call you. So thank you so much.
Sure. You
a
are
torch bearer, actually. Yeah.
Sure. We have done so many projects with the neurosurgery people, with the retina specialists also in our center, and then we have done with the pediatric ophthalmologist also, because ethambutol we have studied both for adults as well as in children. Yes, toxicity and all these electrophysiology was done in those cases, and we had presented those things in the conferences, and also they have been published also.
Thank you so much. All the speakers, they all presented so well, and most importantly, though we got the stage, so is to say the virtual stage 6 minutes late, we have managed to package all the talks and the discussion, and we are now ready to hand it over to Dr. Pradeep Sharma and team for the session.
Hello, Pradeep. Thank you. Nice to see you.
Yeah, nice to see you. And we have to hear you on your mouth organ.
Sure. Next time.
This is pleasant listening. Yeah.
Dr. Goel, you play mouth organ?
Yeah.
You should have brought it here then. At least it could be a change from the conventional talks.
Sure.
Next
time we will do it. Thank you.
Next time we will do it.
Sure.
Don't worry. Also virtual. Okay.
Thank you.
At the same time, Pradeep Sharma sings very well.
Pradeep Sharma, we were in his party when in RP Center. So he used to write songs and we used to play.
Yeah. So I think I would like to invite my co-panelist, Dr. Khurana, is he there? Dr. Ajay Agarwal. Saxena, I didn't see. Dr. Sumit Monga had mentioned that he would be joining late. Jaspreet would be one of the panelists. He's there. I think since Rohit is not there, we might start with Jaspreet. So be ready to share your screen. And then we have Dr. Kamlesh. I think he's also right now not joined. Pradeep Agarwal, I can see his name. Dr. Veena Gupta is there. And Dr. Sumita Agarkar is there. I think you can click on. Yeah, Dr. Veena. So welcome all of you. I think we are going to have a grand session, which is on the advanced strabismus problems. And we have very good speakers. And let's begin with the topics. I think we can have the discussions in the end. How do you want?
Yes, sir. I think we can have discussions in the end, sir.
Okay, as time permits, because
yeah,
we will
because
start
if
with our first speaker and Dr. Jaspreet, because Rohit I don't see, so we can start with.
So first is my name, sir.
Is it? I think what I have is. Can you then revise what is there to me on the WhatsApp?
Yeah,
sir.
First was Rohit and then mine.
Printout is different.
Maybe. No, sir. I think last day they changed the sequence.
Just send me
and
that.
They have shifted my talk to this session. It was a different session earlier.
Okay. Send me on this.
So unfortunately, it's not a good topic to begin because my topic is complications in strabismus surgery.
Okay. So do you want to start with complications? Or you want somebody else to? But
that's okay, sir. If we know
your name doesn't
if we know the complications, we can be careful maybe.
Can I have the revised version? Because
sir?
I don't. Any of you has the revised version? Can you just?
No, the one I
sir,
have
I'll WhatsApp you right now.
Is not in it. So that means it's not revised.
Sir, Dr. Rohit, मैं अभी आपको भेज देता हूँ सर.
हाँ मुझे भेज.
मुझे भी भेजना अंकुर.
Yes sir. Yes sir.
Holly में भेज दो चाहे. Holly में I think all of us will be able to see.
So should I start, sir? In the meanwhile.
Start. In the meantime, we can then check with who are the next speakers because my list seems to be outdated.
That's it.
Okay, sir.
So I think we can all mute ourselves except Dr. Ankur.
Good afternoon, everyone, and I'm thankful to DOS for giving me this opportunity. Respected chair and panelists and all the speakers, I'll be talking on complications of strabismus surgery. As we've already discussed, this is not a good topic to start with, but somehow it is right in the top. So I think we should be knowing what happens sometimes as a complication of strabismus surgery before we plan something for strabismus. So some of the complications may be acceptable as a long-term result, like small under overcorrections, mild DVDs, slight lid fissure anomalies, a little bit of concomitants, conjunctival rednesses, diplopia only in the extreme gaze, or mild Brown syndrome, especially after superior oblique surgery. Some of the issues can be self-limiting, like transient suture reactions, subconjunctival hemorrhages, lid edema, corneal abrasions, or delint, which can be healing promptly. And there could be problems of wrongs, like operating the wrong muscle, wrong eye, wrong surgery in a wrong patient. So we have to be very, very careful to avoid them. We should be carefully checking all the records and ensure that we are operating the right person in the right eye in the right surgery. Now, there can be changes in the palpebral aperture, especially with the recessions and resections. Large recessions can cause widening, while the large resections can cause narrowing of the palpebral aperture. Also, when we do vertical recti surgery, the changes in the lid fissure can be much more than what we can have in the horizontal muscle surgery. So the idea here is, the solution here is to divide and rule. If you are doing an inferior rectus surgery, try and dissect the capsulopalpebral fascia. If you're planning for a superior rectus surgery, the connections between the LPS and the superior rectus should be severed nicely. So this is the case of left lateral rectus palsy, where a large recession of MR has been done along with the VRT. We can see that the alignment is achieved, but we can also see that the widening of palpebral aperture is also there. Now, there can be some suture-related issues like allergic reactions, granuloma, and abscesses. The treatment lies in giving them topical antibiotics and steroids. At times, we require draining the abscess, or surgical excision can be very, very rare. Now, lost muscle can happen in long-standing squints, especially tight rectal muscles. Medial rectus muscle is the most common muscle to be severed, and prevention can be, while passing the sutures, we should not be trying to apply too much of traction, and we should be very, very careful in thin and atrophic muscles. Slip muscle is a slow phenomenon. It is something like a stretched scar A slipped recession can cause overcorrections and a slipped resection can cause undercorrections. But obviously there will be diminished ductions in that particular gaze. So prevention would be to pass sutures 0.5 to 1 millimeter behind the muscle clamp, take long scleral track and use surgeon's knot so that it doesn't slip away. Now, this is the case of 25-year-old female having residual exotropia. We can see there's a lot of difference between fixing right and fixing left. So what we suspect here is probably the left eye medial rectus has been slipped, and also there are diminished ductions in that particular gaze. So the solution here will be to first make the squint comitant and then correct the strabismus. There can be unacceptable over and under corrections. That means when we are intending whatever over and under corrections, they are more than what we are planning for. And they're all inevitable in part of all the surgeons. We can prevent them by careful workup, correct choice of surgery, proper execution of plan. And of course, the experience will help us tackling all these situations. If they are small, then we can plan with prisms and glasses, maybe over and under corrections. And at times when they are large and troublesome, a resurgery may be required. Consecutive, this is a case of consecutive esotropia where we have 30 prism diopters of consecutive esotropia. We go to the old records, we find that she was a case of she was a case of basic IDS with 30 prism diopters of exotropia and a poor stereopsis, and a bilateral LR recession by 7 millimeters have been done in this case. So for me, if I plan a 30 millimeter kind of a 30 prism diopter exotropia, I plan for 7 millimeter recession. It gives me around 28 prism diopters of correction. But here, a 14 millimeter LR has given me approximately 60 prism diopters. So this is almost double. So for a normal esotropia of 30 prism diopters, I would have planned 4.5 to 5 millimeter sessions of bilateral MR. But since here the dose response curve is almost double, so what we plan is just doing one MR of one eye. And this is the post-operative photographs. Thank God we hit the bull. The patient is happy and we are also happy. So such calculations can only be done when we have the availability of the old records, and maybe they are your own patients. Now, anti-segment ischemia can be a dreaded complications. We are not worried about type 1, type 2, and type 3, but yes, type 4 can be a significant problem where we can have corneal edema, heavy flare, hypopyon, pupillary abnormalities, cataract, and retinal changes. They are just because they are there because of the problems in the circulation of the eye, and so we can get away with the reperfusion through the deep collateral circulation. So whenever we are operating a patient who is having a vascular compromise, such patients are more susceptible. So always do not plan, always plan not to do 2 recti in one sitting and no more than 3 recti in a lifetime. If you happen to do more than that, we should be planning for a vessel sparing surgery. Treatment would be topical and systemic steroids. Diplopia can be there when somebody comes out of suppression scotoma and a person is paying a penalty because of having a stereopsis or a simultaneous macular perception. Prevention can be a careful assessment of strabismus and movements, post-op diplopia test, and not tackling obliques when they are not required. Treatment would be patching the one eye, prisms, and resurgery if the diplopia is troublesome. Now, certain complications can even threat to vision, like globe perforation, retinal detachments, vitreous hemorrhages, endophthalmitis, cataract, and lens subluxation. They are all because of mechanical or a microbiological event that occurs because of scleral perforation. So globe perforation, we don't know the exact incidence, but it can cause to other posterior segment complications. With the use of needles and microscopes, the incidence of globe perforation is definitely reduced. So what we should always plan is to use a spatulated needle, avoid deep passage. The tip of the needle should always be visible through the sclera, but always take care in the thin sclera, Marfan's in operated RD or squint patients. A slight giveaway feeling should raise a suspicion. So if you have a inadvertent globe perforation, increase the intraocular pressure by putting a cotton spud so that the hemorrhage does not go into the submacular area. And then we know that where the perforation has occurred, so we can dilate the pupil on table and do a cryo then and there. Obviously, then we can follow up with the retina person also. And extremely unfortunate and rare, but something happens like this, we have to forward this patient to a retina colleague so that they can take care of it properly. Orbital cellulitis can occur because the orbit is surrounded by almost all kinds of paranasal sinuses. So sometimes there can be a slight breach and a microbiological event can occur. Prevention is by using aseptic techniques, and the treatment is by using broad spectrum topical and systemic antibiotics. Now, this is a case of orbital cellulitis following a periosteal anchor in a third nerve patient. But we can see that there's a lot of chemosis, congestion, and orbital cellulitis going in. And what happens in the end is we treat the cellulitis, but the effect of surgery is almost gone. So the complications, they are part and parcel of surgeon's life. elimination is not there statistically. So we can only eliminate by not doing a surgery or not accepting them. And in the end, we should be very, very careful so that we don't land up into these complications. Thank you.
Thank you, Ankur. I think that is a very good thing to start with, because once we are aware of the complications, we can do our jobs much better. So you have highlighted the complications in a very nice manner, in a comprehensive manner. I think we will have the discussions at the end so that we have a fair view of, for a fair chance to each person presenter. I think we can move to Jaspreet, and since I don't have any other panelists on my side, Dr. Ankur, can I request you to kindly monitor the time?
Yes, sir. Yes, I'll do that.
So 1 minute prior to 7 of each, you just give a indication. So Dr.
Yes,
yes. So good afternoon, everyone. What I would be discussing today is a modified Nishida procedure, some kind of a myopexy which has come into vogue recently. I mean, practice more recently. It was there, I mean, in 2003 and 5. So as we know, I mean, there have been multiple transposition procedures, I mean, ranging from full tendon vertical rectus transposition where the muscle is disinserted and transposed. This is just an example of a lateral rectus palsy. So you have the full tendon transposition. Then to make it adjustable, I mean, the cross sword technique was used, I mean, where you can just keep it on, have a slant, take the suture to the opposite sides and have more effect and keep it on adjustable as well. A partial VRT, what we call as the Hamilton procedure, was routinely practiced for 6th nerve palsy, where only a part of it is transposed. And then you have the Jensen procedure, where you split both the lateral rectus and the vertical recti. You split it in the middle and transpose the halves to the lateral rectus. But yes, there are risks involved in these. The original Nishida was again without cutting the muscle. I mean, it was just splitting the muscle and transposing, but then it was modified where it was done without a split. So all the procedures where the muscle is cut from its insertion and transposed involved in interference with the ciliary circulation. However, the advantage is that they are adjustable and can be augmented. So the Nishida procedure, which was developed by Nishida in 2003, involved splitting the muscle and then tying it onto the sclera near the lateral rectus. Originally, what he achieved was a correction of 42 prism diopters, but that was along with medial rectus recession. He then modified the procedure in 2005, where the bite was taken approximately 8 to 10 millimeters behind the insertion of the vertical recti, and it was transposed medially to about 12 millimeters from the limbus without splitting the muscle. So there they achieved a correction of about 50 prism diopters. Of course, again, the medial rectus recession was done here. So the advantages of modified Nishida procedure is it's a no split. There is no tenotomy you're doing. And because of that, there are less adhesions. So the further surgery could be easier. There's a less risk of anterior segment ischemia. There's less chance of vertical insufficiency. And in early post-op period, the scleral suture can be released as well. So the indications are just the same as would be in case of any kind of transposition procedure, except that you can combine it with maybe a recession of the opposite muscle. So it's like 6th nerve palsy, you can have in monocular elevation deficiency, double depressor palsy, a post-fess muscle transaction, or you can have horizontal vertical muscles absence, aplasias. So the published literature is you can say it's scanty. And a few series, I mean, with a fairly large number of patients have described a mean correction of about 50 prism, ranging from 30 prism diopters to 50 prism diopters in patients of 6th nerve palsy, where the modified Nishida procedure was done. Commonly, it has been used in 6th nerve palsy, but you have reports in monocular elevation deficiency, where the amount of correction was about 30 to 35 prism diopters. In post-fess surgeries, I mean, it has been described in patients with 80 to 90 prism diopters. However, it was combined with a lateral rectus recession. So the modifications, you can say it's like a partial Nishida, where superior rectus transposition was done by Yao et al. And this was the muscle was disinserted and transposed, whereas the inferior rectus was just, you can say, like done like a Nishida procedure. Similarly, for the lateral rectus belly transposition, again, they've described this where only the lateral rectus was transposed inferiorly. So, I mean, you can do a lot of modification with this procedure, move around, I mean, play your way with this procedure. So some of the cases, I mean, I would show you is, this is one of the cases of monocular elevation deficiency. Of course, this was just before the COVID era. I mean, so basically what we did was he had a tight IR. So and instead of doing a NAPS procedure, what we did was transpose the medial and the lateral rectus to the superior rectus, and before releasing the after releasing the IR muscle, because the IR was tight. So always, as in any case of MED, you would have to release the tightness, release the IR, do a recession, and then plan accordingly what the Nishida procedure you want to do. And this is another patient. She was a diabetic patient and had a lateral rectus palsy, obviously for quite a duration, had about 50 prism diopters of esotropia. And the MR was tight here. So the MR recession was done along with the Nishida procedure. Now, this is a diabetic patient. You're always at risk of anterior segment ischemia in these patients. So had we disinserted the superior and the inferior, tried a Hamilton procedure, again disinserting the halves and tying it to the lateral rectus, it could have resulted in some kind of complication. But yes, Nishida has its advantages. This is another case of post-FES where the medial rectus was transected. I mean, he had about 60 prism diopters of exotropia. He is awaiting LR recession with the modified Nishida. I mean, we could get his eye straight, but still it's not adducting that much. He needs a lateral rectus recession, and probably in one of these months, we would do that. So you have so many indications like MED, 6 nerve, post-FES, where you can just do this procedure, and it's a less traumatic surgery. And the indications I have discussed, Simon, just 1 minute indications. And modifications are tailored according to the problem and the amount of deviation. As Yao et al. Has showed, you can do just partial Nishida. Important thing is, it requires adequate clearing of the intermuscular attachments of the muscle for a successful outcome. You're just going to pull that muscle. So from the opposite side, the intermuscular septum should be clear. And it can be combined with the third muscle surgery without a significant risk of anterior segment ischemia. Thank you so much.
Thank you, Jaspreet, for highlighting the importance of Nishida's procedure. I think, as he has rightly said, it was introduced long back in 2003, and another its modification was again in 2005. But partly, I think I can take the credit or discredit of promoting it, because I met Dr. Nishida in 2013 in Singapore, and he introduced to me this thing, and he said, this is a good procedure, and I really took it up, and it's very useful procedure. And I think after that, you might have seen a lot of publication from India itself, which have come up in Nishidas. It's such a useful thing that you can use it in combination with the half Hamilsheims on one side. If you find, and this happened to me once, that I lost 1/2 of the inferior rectus. Then I had to supplant it with Nishidas on the inferior rectus. So you can do your own modifications if you need to. We modified little bit Nishidas rather than putting it in middle of the missing muscle and the vertical rectus. I bring it more towards the missing muscle. So if she's on 6th nerve, I put it more closer. Here there is a little more risk of compromising the blood supply, but if you take the intermuscular septum on the nasal side nicely, it works very well and gives you much more yield of the results.
Yes,
so
in your procedure for the adjustable recession also, I mean, you combine it with that, make the Nishida adjustable. I mean,
that's what we had, I think.
Absolutely.
Since you will be handling multiple muscles, do it in one stage or in multiple stages?
So, sir, we are handling the vertical recti in the same time.
No, he said you can combine with lateral rectus surgery also sometimes.
I'm not saying that you combine with lateral rectus. I'm saying if there's a lateral rectus palsy, you will switch it closer to the lateral rectus, but still on the sclera.
There is only vertical muscles.
No bite in the lateral rectus. It is not like Jensen's. And at the outset, let us be very clear, Jensen's procedure is something which I do not like for the reason.
But he once mentioned that you combine it with maybe with medial rectus recession also along with in the lateral rectus palsy. So that means you will be tackling 3 muscles.
Yes.
Will it be safe to tackle 3 muscles at the same time?
The vessels, we are not disinserting the vertical recti, sir.
Oh, they are not disinserted.
They are not disinserted, not split. but there can be little compromise if you are not, separating the intermuscular septum on the nasal side.
Right. That's right.
Now we move on to the next speaker. Do we have Dr. Kamlesh? Otherwise, we have Dr. Pradeep Agarwal to tell us about the management of lost muscle, which is another interesting thing. We hope we shouldn't have it, but if you have it, what can you do?
Good evening, sir. I am audible. My screen not visible, sir?
Yes, it's visible, but make it full screen presentation mode.
Okay, sir. Now it's okay. So, good evening, everyone. Today I'm speaking about the last muscle and its management. So, this is one of the most devastating complications that a skin surgeon can have, and this is the separation of the muscle from its skeletal attachment. And basically it is three types. One is the slip muscle, second one is the last muscle, and the third one is the stretch scar. So before going into the details of the slip last muscle, just few words about the slip muscles. It occurs because of the inadequate suturing of the muscles and resulting in the muscle capsule attached to the sclera, while the muscle itself retracts posteriorly. And it is characterized by the consecutive deviation that happens within the weeks to the month, with the duction limitation that will be the small to medium. If you talk about the management of the slip muscles, you have to retrieve the muscles after proper exposure. If you find the pseudo capsule, then excise the capsule attachment and advance the muscle to the intended site with a non-absorbable suture. Now coming to the last muscles that can occur following any ophthalmic surgical procedure, and most frequently it happens after the squint surgery, retinal detachment surgery, and the pterygium excision surgery. Surgery on the adjacent structure like the endoscopic sinus surgery can give rise to the lost muscles, and definitely it can happen after the trauma. So unlike the slip muscles, most of the time the patient in the last muscle, there will be no direct attachment between the muscles tendon and the globe. Muscle along with its capsule both retract posteriorly into the orbit. The term is little bit incorrect because the location of the muscle we know it is somewhere in the posterior orbit. So the term detached muscles should be used, and I think it is the superior. In contrast to the slip muscle, the patient with the last muscle will come always early within the hours or the days after the surgery with the large consecutive deviations with the large duction limitations. If you talk about the management, then the management depends on the mechanism by which the muscles has been lost and the timing of the recognition and the intervention. So it may be the intraoperative muscle loss, it may be the intraoperative snap or the torn muscle due to the over manipulation, or sometimes it may be delayed loss, or sometimes it may be the trauma, as I told earlier. So let us see one by one. If it is the intraoperative muscle loss, then it should be the retrieved immediately if possible, because at that time they are the newly exposed tissue planes that makes the identification easy, and sometimes you can see the suture knot in the muscles, and with the help of the suture you can make the plane easily. So at that time the retrieval is easy, but mind it, there should be no purposeless exploration that can increase the hemorrhage and the edema. In that case, you can plan the later exploration. How to prevent all these things? You should be careful in identification and the isolation of the rectus muscles. Limit the dissection of the posterior intermuscular septum, muscle capsule, and the muscle pulley. You should use the fine instrument, don't use the rough instrument, so that there may be the damage to the suture material, and just post-operatively at the time of the knotting, the muscles can lose after the breaking of the suture. Few things about the snap and the torn muscles. This can occur during any ophthalmic surgery due to the over manipulation, and this rupture usually happens at the muscle and the tendon junction, like in this picture, due to the manipulation that exceeds the breaking point of the muscles. Mostly it happens in the adult patients, especially in the thyroid eye disease, or if there is the congenital fibrosis of the extraocular muscles. We call it the pull apart with mild traction or the PITS, that is the pull in the two syndromes. Few things about the snap muscles that mostly involves the medial rectus and the inferior rectus. Medial rectus because this muscles doesn't have any adjoining sepia of the oblique muscles, and the muscle rupture occurs well posterior to the muscle insertion into the sclera. So retrieval of the proximal part is little bit more difficult, and after exploration, if the proximal end can be retrieved, then end to end anastomosis of the proximal and the distal segment should be done, like in this picture. If any patient is presenting with the delayed loss of the muscles, although the clinical diagnosis is simple in most cases, but imaging should be helpful in the selected cases to confirm the diagnosis. And definitely the MRI is better for the visualization of the muscles. So you can take the help of the CT scan or the MRI for the localization of the muscles or for the localization of the pseudocapsules. Few things about the traumatic disinsertion. Both the blunt trauma and the penetrating trauma can result into the extraocular muscle detachment from the globe. And you should be differentiate from the muscles paralysis or the restrictive squint due to the muscle entrapment in the orbital fracture. For that, the force junction test and the force generation test should be done. Few things about the traumatic disinsertion. Early exploration should be considered to prevent the contracture of both the detached muscles as well as the antagonist muscles. In case of the concurrent hemorrhage and the edema, you can delay the surgery for the 1 week or the 2 weeks after the proper decrease of the edematous tissue. And one of the most important thing when we try to retrieve the muscles, everybody has the tendency to look towards the global side. But in fact, if you remember the anatomy position, then the muscle is somewhere towards the orbital side. And don't try to pull in the opposite direction, otherwise the muscle will go more behind. So this is the one of the most important thing while you are trying to retrieve the lost muscles. In the case of the late retrieval, you can go for the traditional conjunctival approach by the fornix incision or the limbal approach, whatever you are comfortable. And with the help of the ENT surgeon, you can plan the endoscopic transnasal approach. And if you talk about the outcome, in most cases, the outcome is likely to be alignment in the primary position with the limited function of the involved muscles. And if the muscles cannot be retrieved, then definitely you can think of the transposition procedure, especially now the Nisida procedure or the modified Nisida procedure can be planned as told earlier. Thank you for your kind intention, and thank you, Dr. Pradeep Sharma, and thank you every panelist.
Thank you, Pradeep. Very nicely covered. I think there are most points of that have been covered. It's something which you do not want to have it, but if by chance you have it, you can if you are having the microscope, which I usually suggest people doing it under microscope and good illumination. So we are better off than most Americans who work under the loop, and they have little more problem in looking for the muscle. But as Dr. Pradeep had mentioned, we should look for the towards the periosteum, towards the orbital side, and look for it and use a deep tissue retractor or Barbie retractor on the globe rather than pulling on the muscle to go behind. So that is something which will be there. And if you're under GA, it's better to use muscle relaxant at that time if they have not used, so that the muscle doesn't contract. So that is something which will be helpful. And if it happens on the first post-op day, this is one thing which you'll have to, re-surgery has to be done quick enough, maybe on the second, third day itself. This is one indication of in the complications which you have to do it fast. So now we have the next speaker, Dr. Reena Gupta, and that's another interesting topic, the nystagmus being simplified. So Dr. Reena, for making it simpler for all of us.
Is the screen visible? Am I audible, sir? Yeah.
Good evening, everyone. So nystagmus, we all know, are the involuntary rhythmic oscillations of the eye with at least one slow phase. The waveform can be jerk, it can be pendular. The nystagmus is represented in terms of frequency, the amplitude, the intensity, whether it's a monocular nystagmus, binocular nystagmus, conjugate or disconjugate nystagmus, and what are the factors which affect nystagmus. According to Simmers classification, we have the physiological nystagmus, which is seen in the normal individuals in response to a physiological stimulus, and the pathological nystagmus, which basically includes infantile nystagmus syndrome, FMNS, and Spasman-Newton syndrome. Infantile nystagmus syndrome is the most commonly seen. The onset is within the first 6 months of life. It's a bilateral conjugate horizontal nystagmus in which it can be jerk or it can be pendular, but the accelerating slow phase is the diagnostic point. And these patients, they have nystagmus which dampens on convergence, and also there is a null zone for which the children present with a compensatory head posture. Now, one group is idiopathic, which has a very good visual potential, and the other group have underlying ocular causes or neurological causes. The most common is the albinism, which can be partial albinism, which is known as ocular albinism, or it can be oculocutaneous albinism. These children usually have jerk nystagmus, and they also have iris transillumination defects, foveal hypoplasia, and abnormal crossing of the optic nerves at the chiasma. Fusion maldevelopment nystagmus includes the latent nystagmus and the manifest latent nystagmus. Latent nystagmus, which appears only on occlusion, and manifest latent is, which is the nystagmus is there, but the intensity increases on occlusion. Now, latent nystagmus is a kind of jerk nystagmus where you can see the fast component is always towards the fixing eye. And manifest latent is usually associated with strabismus or other disorders in which the binocular vision is disrupted very early in life because of congenital cataracts, corneal opacities, and anything which improves the fusion improves nystagmus. Then we have the Spasman-Newtons. In Spasman-Newtons is usually seen between the 6 months and 6 years of age. It's a highly asymmetric shimmering nystagmus along with head nodding and torticollis. It's idiopathic and self-limiting. Usually remission is seen up to 2 to 4 years of age. And if it's not there, then neuroimaging is must to rule out optic nerve as well as chiasma gliomas. But this kind of asymmetric nystagmus can also be seen in certain retinal disorders. How do we approach a case of nystagmus? The clinical evaluation starts the moment the baby enters the clinic. Always observe for signs of photophobia, eye rubbing, abnormal head posture, head shaking are there or not. A detailed history has to be taken to rule out the neurological symptoms, and the thorough systemic examination has to be done. Also record the monocular and the binocular visual acuity. Monocular can be done by using the fogging high plus lenses. Abnormal head posture has to be recorded at least for 3 to 5 minutes to rule out any periodic alternating nystagmus. Also, sensory evaluation is must to look for the status of binocularity. Then cycloplegic refraction is very essential, and retinoscopy is best done in the Snell zone to rule out any high refractive errors which may be associated with nystagmus. If there is any strabismus which is associated, detailed orthoptic evaluation has to be done, and this has to be treated before because it improves nystagmus in most of the patients. Complete anterior segment and posterior segment examination to rule out the retinal abnormalities which may be causing nystagmus. Now, what is the indication of doing MRI? If a child comes with late onset nystagmus, or it is a patient of asymmetric nystagmus, vertical nystagmus with neurological symptoms, all these patients have to be or in all these patients, a neuroimaging has to be advised. It is very essential. Now, the patients who have a negative MRI and they present with features like photophobia, night blindness, and we are suspecting some retinal disorders, in those patients, ERG and VEP can be done. OCT has its role to tell us about the morphology of the fovea, especially the foveal hypoplasia. Asymmetric VEP we know is diagnostic for patients with albinism. Now, we need to have very realistic goals for treatment of nystagmus. We need to tell the patient that we would try to improve the visual acuity. If there is any associated refractive error, it has to be treated. Amblyopia has to be treated. Again, strabismus has to be treated first so that the binocularity can be improved. And if the patient has an abnormal head posture, we can always correct the abnormal head posture in these patients. Coming to the treatment options of INS, In the optical section, if the patient has a refractive error, treated with spectacles or contact lenses, or even combinations can be given. Coming to the opticals, contact lenses are preferred over spectacles because it improves the visual acuity as the contact lenses move synchronously. So it is in the visual axis is parallel to the optical correction. And also they have studies which have shown that it stimulates the proprioceptors, which dampen somehow the nystagmus. And prisms induce fusional convergence. And so in patients in which we see that the nystagmus dampens on convergence, especially the idiopathic INS patients, they can be benefited by prescribing 5 to 7 base out prisms in these patients. Another use of prism is that if a patient has an abnormal head posture, we cannot give him prisms for long because it's going to deteriorate the visual acuity. It's a very high power prisms which are needed. But we can do a preoperative prism adaptation test to see whether this patient will benefit from a surgery for abnormal head posture or not. In the same way, we can also see if the patient is going to be benefited for artificial aversion surgery. The pharmacological treatment, a lot of studies have been done, and gabapentin and memantine have been found.
1 minute left, Dr. Reena.
Have been found useful, but there are no established treatment as such. Dr. Hurter and his group found that topical brinzolamide also helps in dampening nystagmus. The indications of surgery in nystagmus is if you want to improve the head posture or you want to dampen the nystagmus. Artificial divergence surgery, like I said, Dr. Hurtel in his paper has said that if you do a bilateral MR recession of 3 mm, you are able to induce convergence in these patients, and you can club it with tenotomy and muscle reattachment surgery of lateral rectus muscle, which is nowadays a lot of people are practicing this. And if the patient has abnormal head posture, in those patients, if their head posture is small, I prefer modified Anderson procedure. But for larger head postures, more than 30 degree, Kestenbaum-Anderson procedure can be done, which can be augmented by 30 or 40%. And also, in patients who have a strabismus associated, always correct the strabismus in the non-fixing eye and AHP in the fixing eye. So in face turns, we usually shift the null zone towards the primary position by inducing the gaze palsy in the preferred gaze. Chin up, chin down, then always shift the eyes towards the chin deviation. Head tilt can be corrected by rotating the eyes in the direction of the head tilt. A word about the acquired nystagmus. This is differentiated from the congenital nystagmus because these patients, usually they have oscillopsia as the main complaint. Like this was a case of upbeat acquired nystagmus who present to us post-stroke. And in this patient, she had a spontaneous recovery because a few sections of the patients can also improve spontaneously. But if they have a persistent vertical oscillopsia, in those patients, baclofen is usually preferred. And this is the various type of acquired nystagmus and the treatment regimes followed. To conclude, nystagmus can result from a variety of conditions. INS can be diagnosed clinically and neurological investigations are unnecessary. Child with ocular and neurological disorders requires electrophysiological, neurological, imaging, and OCT. Clinical proven pharmacological treatments are emerging but not established yet. Treatment plans have to be tailored and the goals have to be realistic. Recurrences are common. Thank you.
Thank you, Dr. Reena, for giving a very comprehensive cover-up of managing nystagmus and with good videos. It was a good presentation.
Thank you.
We will now move on to the next talk by Dr. Sumita Agarkar on adjustable surgery. And I'm sure we'll have a lot of time because we have some speakers missing, it seems. So let's have Dr. Sumita Agarkar. Can you share the screen? Dr. Sumita, are you there?
Yeah, she's there. I can see she was there, ma'am.
Dr. Sumita, can you hear us? In the meantime, if anybody has a question on nystagmus, we can have it, or on the previous topic.
Sir, I had a question for Dr. Ankur Sinha. So I have encountered a few patients in the OPD who've had muscle surgeries done. The incision was over the muscle, and they've come with a vascularized scar, chronic vascularized scar, which is not responding to steroids also. So the cosmetic alignment is fine, but then there's cosmetic disfigurement in the form of redness in both the canthi. So what would you do for such a case?
We just can't do much actually, because they're just made over the muscle, which is not a good site to have an incision, because you'll have a scar of the muscle where the muscle is getting attached, and also there will be a scar of conjunctiva.
Yeah.
So maybe you can try excision of the scar using mitomycin C, but it can actually, be counterproductive.
So would the AMT help in such cases? If we remove the conjunctiva
I
and try an EMT, because
I don't think so that AMT is going to amniotic membrane is going to help much, but maybe mitomycin can help you by giving little bit of antifibrotic agents kind of thing there.
The scar
But then,
and goes from the side conjunctiva to cover up the missing. AMD
that area.
will not.
Okay.
The vascularization can be taken care by simple cautery sometimes.
No,
I
sir,
have
these
had
are
some
old
cases
operated patients.
if the veins, if the vessels are dilated, and of course the scar will continue, you can cauterize those vessels, heat cautery. Perhaps it will give a little better look to the patient.
Okay. Also, sir, if we're prescribing prisms for a consecutive squint, if it's a minimal consecutive, I had a patient in the OPD recently, operated 3 years ago for exotropia, and now has around 6 PD of consecutive ESO only on distance. So when he's becoming better with prisms, but what is the chance of weaning such patients off prisms? Because these consecutive is very, very intermittent and only on distance, but the patient still wants a correction for that.
Anu, does he have diplopia with 6 prisms?
He has, no, sir, he's getting corrected with a prism of 6 PD on distance. So that has been prescribed, but he has diplopia, yes.
So in that case, you should give prisms, but many patients have, let's say they don't have a diplopia, then probably you can just leave them 6 prisms and they may be able to fuse, or with time that gets all right.
So, sir, I wanted to know what are the chances of weaning such patients off prisms in the long term, because this patient is already 4 years post-operative.
Yeah. In this case, what is the age of the patient?
He is around 20-25.
It's little older person.
Yeah.
In these cases, you have to just observe if and reduce the prisms. So
okay.
He is not complaining.
Maybe, yeah. Gradually, you can reduce the prisms.
Okay, sir.
Because the overcorrection in exotropes usually gets settled, and they are.
And up to 10 PD, what we see is commonly tolerated by most patients, but this patient somehow is complaining.
This is a question for all the panelists. Will orthoptic exercises help in this? Convergence exercises or?
No, but here it's a consecutive ESO, she says.
So, ma'am,
yeah.
Sorry, divergence. I meant divergence fusional. Can it be treated? Can it be trained?
And this consecutive is only for distance, not for near.
Okay. In that case, I think you can maybe try without prisms for some time, and it might be okay. Many of them get weaned off by themselves, because in some areas they're having fusion, as you're saying, for near. Then probably I wouldn't have given prisms.
No, sir, this is an old patient operated 4 years ago.
So now 4 years have gone through, and
so he is not.
Patient, so maybe we'll have to
prisms
intervene.
Are
if
helping
the
him.
Patient is actually. Does he have glasses actually to? I mean,
no, sir, no refractive error.
So because then maybe you'll have to kind of intervene somehow.
Simultaneously. How did you give prisms?
Sir, I've given a 3 diopter prism in both the eyes. I've divided the prisms.
But that is working for near also.
No, I've given the glasses only for distance. I've told him to wear them only for distance for now.
Because that's another issue with these type of problems in the near disparity. Yeah. Otherwise, you can do mini retinotomy or.
Yeah.
Okay.
That's what I was about to say, that mini retinotomy or a mini recession, something can be done.
Can we have your talk?
Dr. Sumita, ma'am? Yeah, we're waiting for your talk, ma'am. You are muted,
Thank you,
ma'am.
sir.
Yeah. Can you share your screen? Yeah.
Yes, sir. So I'm going to on adjustable surgery here, and basically, why adjust? Because you have desire for precise results in face of imprecise measurements, and that's where you probably adjustable sutures may help. And of course, it is a little bit of surgeon's personal preference also, because some surgeons absolutely believe in it, and then there are some surgeons who absolutely never do it. So I lie, as usual, somewhere in the middle, and probably there are certain situations where you should, and all strabismus specialists should have this in their armamentarium. Cons are, of course, there is long-term instability of alignment has not been studied very well, and sometimes pain can be an issue. What does evidence say? This is the last big review on data on this in 2013. Again, there is no RCT available to compare adjustable versus non-adjustable. And there is no evidence to reliably say that adjustable suture technique is definitely better over non-adjustable technique. And probably there is a scope of RCT. So those who are in the audience and are young strabismologists probably can look into this as an RCT at some time in their careers. So if you look at the largest study which is available, which compared these two, if you see which had a reasonable follow-up, if you look at the need for re-op and patient satisfaction as outcome measures, re-op rate was definitely low in adjustable sutures versus non-adjustable sutures. So probably that's one reason you would probably prefer to think of adjustable in certain situations. So when do you use this technique? This is the list, comprehensive list of situations where you may need adjustable suture surgery in your armamentarium. There are two basic techniques, a sliding noose or a bow tie technique. And then there is a short noose technique, which is similar to sliding noose technique, which is now increasingly being used because we use fornix incisions and it is easier to do even in young patients or in children, which was a strict no-no a few years back to do adjustable surgery. But now in certain situations, you can use a short noose tags. And I think Dr. Sharma, who uses it pretty frequently, can elaborate on that. I don't do it that often. So this is the way noose technique. So this is a typical patient where you might want to do adjustable surgery because she has already had a squint surgery. He has still a large residual exotropia, and you want to be on point because she will not want surgery. So probably up to this point, if you see in the video, it's like any other regular recession, and you have to probably do the same way the interlocking sutures and clearing this intermuscular septum. And we have used a fornix, we have used incision here, but there could be, you could also use a fornix incision. In this, we are using a limbal incision. So that's how you would tie a noose. The first is a square knot, and then you do 2 and 3 throws, and that's how your noose is done over the suture. So this is very easily can slip over your sutures. In a short tag noose, also the same technique is used, but the noose is much shorter than what we are going to leave here. So coming back to the same patient, same surgery, and as you can see, she's going to tie the noose. This is a surgery done by my colleague, Dr. Kavita, and the first square throw and a second throw and a third throw. And that's how your noose is kind of done. So you bring the muscle all the way up to the insertion and close the to this to your insertion, then pull it back to have desired recession, whatever you want to leave it. As you can see, it slides very easily over your recession. Then you measure and make sure that you leave the muscle where you wish to, and your noose can be close to the stump, and you can leave it there. Again, remeasure, and you can close the conjunctiva if you want. And in the short tag noose technique, it's easy because you can easily put it under the conjunctiva instead of fornix, like which we are using here. And as you can see in the post-operative stage, patient is a little bit ESO, and we need to advance the lateral rectus a bit. And you can see it's very easily, you can do it, pull the back. We leave her with a little bit ESO, what will be the desired position here. And you can just cut the noose and finalize the knot so that you can, and as you can see, you can do it under topical anesthesia easily. And that's how a noose or a short noose can be done using the same. In a bow tie technique, again, you have to, the recession proceeds the way you wish to. And instead of, I'll go down to first, because that's how you will do first square knot, And then second knot is usually a bow tie like this, and you can easily cut it and finalize the knot when you need to finalize it at the time of adjustment. So this bow tie can be easily cut and finalized. So again, here we are using a bow tie technique in this, and as you can see, I passed it through the stump, measured, and instead of after making the first thing, the second thing is like you will tie like a bow tie, leaving it again once you have left it, again you should remeasure, and the extra bits of sutures can be tucked into the fornix. And you can close the conjunctiva and actually access it later when you are going to do the adjustment. So which patients more than 15 years, usually this was the recommendation, but nowadays with short tag nose, you probably could do it in children who are younger than 15 and do the adjustment under ketamine or a small intravenous anesthesia, short anesthesia.
1 minute left, Dr. Sumita.
If child allows you to do applanation, probably he's a good candidate. Anesthesia, all these options are available. However, if you are doing it under local anesthesia, you should probably avoid bupivacaine, which is a longer acting. When to adjust, 24 to 48 hours, but you can have a delayed adjustment also. In fact, last year paper by Dr. Raja Muralidhar has successfully proved that you can do it as delayed as 2 days later, and you could do it under topical with full. Usually you should do adjustment in full optical correction in days. You can have slight other techniques also which we can use. Tandem adjustable, if you're a beginner and you don't want to, you can put one fixed suture and another which can be adjustable, and depending on which you want to adjust, you can cut that suture and pull the muscle up or push it behind. And if you're on point, you can just take away the adjustable suture, but it requires 2 sutures, and probably patient has to pay for the suture, so you need to worry about whether. Practical pearls, while doing adjustable surgery, you should probably put a bucket handle suture near the sclera. It allows you to access the suture tip very easily. It is easier to pull up the muscles rather than push them back. Limbal incision, I find myself, gives a better exposure than fornix, but fornix can be easily done, and in experienced hands, probably fornix works equally well. You should probably have an anesthetist standing by, or at least be aware of the oculocardiac reflex, so that if you are doing it, especially in OPD, vasovagal reflex, and pain can induce a lot of other problems. Conjunctival closure is not required if it's a small recession. However, my one warning will be to do not plan very large recessions on adjustable, because they actually don't work equally well. And I think the maximum length which you can leave it, because these are hangback recessions, maximum length probably is around 7 to 8 millimeters and no more than that, if you are planning for adjustable. So if you have very large splint, probably it's easier to choose the third muscle rather than doing a very large adjustable recession. Thank you very much for your.
Thank you, Dr. Sumita. I think you have highlighted the important points about adjustable surgery. I think in the age that we are living in, that people are more demanding, we should be equipped to do adjustable surgery, even though you may not be doing more than 80% cases would be non-adjustable. But you should have it in your on your side, that whenever you need to. The other thing which you have highlighted nicely is that the limbal incision is the preferred technique, because adjustment is much simpler. But even you can do on the fornix incision, but it is better to have a bucket handle which will help in exposing the fornix incision again at the time of adjustment. So if you have that scleral bite, which will also help in holding the globe, then you can open up your fornix incision easily without using an instrument. So that's another thing. But instead of noose, I prefer to use a bow tie, because I feel it's much easier to tie and untie, and you can do it repeatedly as per the requirement. And we have used it in, whenever the cases are like having diplopia, and we want perfect alignment at the time of the end of the surgery. My preference is usually to adjust after 5 hours of the procedure. I don't know what others do. We'd like to know what is the time of adjustment, because I had seen a comparative study by Dr. Velez group, and it was published by Velez. It was a study done between the cases of Dr. Rosenbaum, who would do 24 hours later, and Dr. Eisenberg, who would do 5 hours or 6 hours later. Both are possible, but it is much easier 5 hours or 6 hours because the adhesions are very little. Even within 24 hours, you'll have some adhesions, and at sometimes you may have a problem in maneuvering the sutures. So you have to be careful, or if what Rajamani Muralidhar she talked about, in that case, you may have to use some sodium hyaluronate or mitomycin C to delay the adhesion. That is possible, but I think it's good enough to adjust after 5 hours. Only thing is that when you're giving a peribulbar block, avoid bupivacaine in your block, because the effect of the anesthesia would last more than 8 to 10 hours if you have bupivacaine. So we can have the other panelists on this now.
Sir, in cases of early adjustables, do you do it under the microscope or as an OPD procedure with loops, or?
Whenever we are doing the adjustable procedure, we are doing it with the loop.
Okay.
And with the flash.
So like I'll differ here. Like most of us are here in the institutes, I guess. So in a private practice, we do it only on the next day because we don't want the person to be in too much of pain. It actually gives a negative impact because the patient is having a lot of pain. Also, it is now what we do is we do it in the OT now. We don't do it outside because it doesn't look nice when you're doing outside. The attendant is watching, or they don't want you to. I mean, you don't want them to be here actually. So what we do is we keep a Snellen's chart in the OT, which is pretty distant, and then we do it. We adjust the things in the OT. So, and then the patient comes out without a patch, so it's okay.
You have the availability of the OT.
I think I do it under microscope, and it's perfectly
Yeah, under
fine.
microscope. That's what I'm saying, under microscope.
Yeah, I'm an institute, but I do it the next day as you do, Ankur.
It's
And it's one practical tip is always save a bit of suture, because you never know you may have to suture the conjunctiva. So it's always good idea to keep a small bit of suture in a safe bottle, which you may have to use in the later in the day or in the evening.
Yeah, at times you may have to kind of, conjunctival suturing can be required. At times it breaks off.
Yeah.
So
I had a question for Dr. Jaspreet. So you described a case where you were planning a LR recession at a later date. You had done a VRT. So in such cases, when you're doing a stage surgery, do you prefer doing a VRT or a Nishidas first and then a recession, or a recession then followed by a VRT?
Actually, this patient I thought may be corrected with the Nishida only. So that's why the session was delayed. Otherwise, in the previous case, like the 6-nerve palsy where the MR was tight, I mean, I put it on an adjustable and did the Nishida along with.
Okay.
I think in that case, you might be seeing the post-junction test first. Because if you have a tight FDT,
that has to be done. Yeah.
You have to do the recession first. And there is no question of delaying it. But if yes, it is maybe an early case in which the FDT is not tight, then you can do just a Nishida without the recession.
Yes.
Also, sir, in few cases of
I
muscle
have one
slips
question for people.
Yeah, let Dr. Anu finish it.
Yes, few cases of lost muscle and all. Few people have described that if they do not find the muscle, they have sutured the muscle with the tenons in that area, whether it be a medial rectus or an inferior rectus. There have been a few presentations in VRSI. They've encountered a muscle split in two in buckling, and they've sutured the tenons and shown very good results on post-op day one. I don't know how it's possible on day one with a good, nice abduction, adduction, but can we do that?
The retina surgeons have described this, and they very often, when they were doing bucklings, they were doing the inferior rectus tear and rupture quite often, because
Yes,
I think their handling is little more quick. So that's why the inferior rectus ruptures were happening, and they used to tie whatever stump is available to the it would work, because it would have an attachment with the Lockwood's ligament indirectly. And that's why
would that be preferred, or should we go in for a VRT at a later stage and ask them to not explore much if they don't find the muscle?
It's better not to do a VRT. You can tie the muscle to what, if you have it. Like in PITS, you have some amount of muscle still with you. Usually 7 to 8 mm distal segment is available. And this you can attach it to the fascia, which would be having an attachment with the Lockwoods. So this is relevant for inferior rectus, I think.
Yes, sir.
So lateral rectus and medial recti, this wouldn't work so nicely.
There have been some Korean presentations for medial rectus also in Retina Congress. I think a European Congress. So that was not a split into two, but yeah, it was it tore, I think, around 5-6 mm from the muscle insertion, the medial rectus also.
What do you do?
I am unable to hear you, sir.
Jaspreet, I think you are asking something.
Yeah.
Dr. Jaspreet?
Yeah, so I was just saying the medial rectus, the reports, some of the reports I found was like when a FES was done and the medial rectus was transected and all, they could find the muscle and suture it back. And that really worked well. That has been described in literature, but yes, if you can't do it, then probably a transposition.
But the question is doing it the same sitting or waiting for some time. That's what Dr. Anu wants to know.
Yeah, I mean, doing a Tenon's insertion, Tenon's suturing at the same time, or if we do not find the muscle, just leave it and then, go in for a VRT at a later date. Because most retina surgeons, if you're in an institute, so like we encountered a muscle split of IR recently and I was called for it. Thankfully, I could relocate the proximal end of the muscle and I could suture it. But in that case, if I couldn't, should I have sutured it to the Tenon's or should I have gone in for a horizontal partial
I think
tendon
stage
split?
1, we should just wait and tie the muscle and then see what happens, because at times you really get, even if say 5 millimeter recession, 5 millimeter, kind of it has gone attached little back, 3 millimeters back, wherever, capsular palpebral fascia is there. So if some part of muscle is attached to sclera somewhere and it is giving you some sort of duction in that particular gauge, why do you want to go for it? So it's better to avoid doing transposition in one go.
No, sir, not transposition in one go.
Stump. If you have 7 to 8 mm of stump, then you catch it. Remember one thing, these are the global fibers which are mostly working. The more proximal one coming from the origin are the orbital fibers.
Yes.
They are mostly giving just a support. The main action which we have for the muscle movements is from the global fibers, which is from the equator onwards to the insertion. So if you have that stump and if you can attach it, mostly the successes are because of that.
Okay, sir. Thank you, sir.
These are the cases which are handled by either the retina surgeons or FES, because they usually end up having the separation or transection more distally. When the squint surgeons have it, they usually have it from the insertion.
Yes, sir. Retina surgeons have split into
posterior, yeah.
Mostly there. We have it split into two in rare cases, like suppose you have a very tight muscle and you try to hook and suddenly it snapped.
Snaps.
But usually then again it might snap from the insertion. In that case, if it is contracted, you may not even be easily able to locate it. Yeah. But whatever you can get it, I think Dr. Pradeep was saying that you can find, if then you should do it.
Yes.
You have good magnification, you can see the fibers, muscle fibers, and whatever you feel like is there, it's better to get hold of it and attach it to at that time. It works. In many cases, it works. But if not, then you can do a VRT on the
one of these patients with FES, yes, I took the help of the oculoplasty surgeon to locate the posterior orbital part and then suture it to the anterior part, and it really worked well,
So that is there. You can, the first shot would be that.
Yeah, thank you.
And I think, sir, sometimes we can take the help of imaging, in case of slipped muscle, in order to locate the muscle. Sometimes imaging really helps to identify whether the muscle has really gone back or we are able to see some remaining fibers or stump. So that helps us in planning, pre-operatively.
Yeah. So if you have the help of the imaging, you can do that. You'll see the contracted muscle as a lump sometimes, and you can.
Yes. Yes.
Quite right.
Also, sir, in cases of patients who have recently been diagnosed with myasthenia or something like that, and they have their SOP has decompensated and they present with diplopia. So how to tackle such patients? Because it's an acute presentation, a decompensating supraoblique palsy with the newly diagnosed myasthenia.
Okay. No, but you're talking about myasthenia having in supraoblique, that is much rare. Only supraoblique.
It's rare, but yeah, so only supraoblique. I had a patient in the OPD recently, and he's on treatment for myasthenia now, but the vertical squint is not very, very evident. Only on cover tests and repeated alternate cover, he manifests a supraoblique palsy, but the diplopia is classic for a SOP. and he has large fusional amplitudes.
So those are
not correcting with prisms.
large fusional amplitudes. They would indicate it was supraoblique palsy, which has
now decompensated because of this.
Okay. So in that case, of course, I mean, if that is the situation, then it will not help with pyridostigmine or steroids because it is not myasthenia. In that case, you might have to do a surgery.
But should we wait for a few months until the systemic condition is stabilized? And
presentation.
Why don't you present this case somewhere in some of the conferences? It's really nice to see, you know, having two etiologies in one point in time.
Sure, sir. I'll make a note of that.
What was the indication of myasthenia? What was the evidence of myasthenia?
Sir, during testing in ophthalmology department itself, ICE test came positive and fatigue test came positive. So he was tested.
ICE test for supraoblique palsy?
No, sir. ICE test in general.
That means there was
he had a presentation of complete ptosis in one eye some 4 years back, which resolved. And then he was not compliant with allopathic medications. He was using some Ayurvedic and all because he said that helped him. So he had 2 episodes of ptosis. One was complete ptosis in unilateral eye. That time he was not tested for myasthenia. He had a repeat episode 1 year back where it was partial ptosis. So then they checked him for myasthenia and it came out to be positive.
Right.
And the myasthenia was detected, sir, I think 6 months back, but the complaints of diplopia started only 1 month ago.
Was it intermittent diplopia or is it?
No, it's not intermittent. It is constant diplopia, which is troubling him a lot. So right now we've just advised him patching, and he has around 12 prism diopters of vertical, along with around 12 prism diopters of horizontal exo.
Did he have any pictures or pictures which show head tilt or something which makes you think it is decompensated?
I did not ask for the pictures, ma'am. I could do that, yeah.
One thing that you can ask.
You could do that.
He has almost 12 prism diopters in the primary gaze, which increases in the left gaze to, it is in 5 prism diopters in the right gaze and 8 in the left gaze. And in tilts, it is increasing and it is large on down gaze.
Dr. Anu, how much is the extortion?
Sir, not yet measured.
So that is another thing which, if you suspect supraoblique palsy, always look for extortion. Otherwise, you might be having inferior rectus or a vertical, which may be masquerading as that.
Part of myasthenia, yeah. Which may
For all you know, there may be 2 different pathologies. They may not be related at all. So I think you should.
Yeah, but
you should isolatedly inform.
Yeah. So you should be testing for extortion and prove that it is a supraoblique palsy on its own, and there is a myasthenia, which is another rider on it.
Okay, sir. So also another interesting case was a child with a traumatic 6th nerve palsy, 3-year-old child. She fell off 2 floors, and she has a 6th nerve palsy now going into ESO. She, of course, is not complaining of diplopia. She is 3 years old. So in such cases, do you go in for a Botox? It's acute phase, 1 month presentation. Do you go in for a Botox in the MR under GA in such cases?
Yeah, I think you can inject Botox in such cases if there is a fresh case of 6th nerve palsy.
Okay, rather than observe. And so would patching be detrimental in such cases for the normal eye?
You have to do patching because you might have otherwise amblyopia. So you would have to do a patching even for 4 hours a day. That would be enough to ensure that he doesn't go into amblyopia.
But sir, if the other eye, the eye which is adducted now due to the early contracture or because of the overaction, if it is not reaching the midline, the LR function is almost -5. So would that lead to any detrimental effects if she's focusing from that eye without any AHP?
No, that's what I'm saying, that if you give Botox at this time and give along with that patching.
Patching along with that. Okay.
So now we
Sumit wanted to develop a contracture so soon.
Maybe it is just the MR overaction, yes, not the contracture.
Yeah, so patching would work rather than taking the patient under GA, giving them Botox. See, observe for a few, maybe a month or so for with patching, how it is, if it stabilizes, comes to it, and probably then Botox, because Botox aim is to prevent a contracture. The amblyopia is being prevented by the patching.
So a few cases have also, a few reports have also
you can ask the
said
patient to kind of patch the better eye when she's watching TV or something.
Yes.
Otherwise, there can be past pointing or something of that sort, especially a child. So that
patching
way
has been
the child
advised for
can be
that
sitting there
patient.
and-
It was
Yeah.
just a 2-week-old presentation. But my point, I've read a few case series where they've reported a better recovery of the LR function after Botox as compared to just observation.
I think
So that is why I was wondering if here the main concern is GA. So
Absolutely.
should we go in for a GA and Botox in this child? It's a 3-year-old child.
you require a short GA for this. I think Dr. Keith McNear published a lot of work on this, and along with Dr. Spencer, who was the neuroanatomist, and they have studied the muscles in these cases. They say that in children, in infants particularly, if you inject Botox, the results are much more longer lasting.
Okay.
Thank you, sir. Is different. So we can have the presentation from Dr. Sumit Monga now.
Yeah.
Thank you. Thank you, sir, and thanks for the patience, and apologies again, to be late.
Can you share your screen?
Yeah, I'll just do that, sir. Yeah, good evening, everyone. And just to start with, something interesting. We have a customization of everything now. Everything available. So why not actually for strabismus surgery also? So as you all know that we have these common situations of large angle deviations. Large angle, by large angle I mean more than 60 prism diopters. So when you have, that generally my protocol is, to go for 3 muscle surgeries directly rather than, just waiting and see and landing up with a residual deviation. And the same has also been reported in the literature in various studies where if you had 3 muscle surgeries, the most of the studies had reasonably good results. And of course, when you have surgery that is done for restoration of the deviation and the vision is poor, or the patient actually is interested in only one eye surgery, then this muscle transplantation has also been shown to be effective. I'll just come to this in a while. So similarly, we have the same for exodeviations also. When you have large angle deviations, the 3 muscle surgeries, if done appropriately, they can have good results. Just one case where a person had amblyopia in one of the eyes and was interested in only one of the surgeries, and in fact, had led to a lot of psychological issues. What we did was really resected the medial rectus of the left eye and just put it cut and paste of the to the other lateral rectus when it was recessed also. So extraocular muscle transplantation was done, and I would not say had a very good result, but a reasonable result. 20 prism diopters, residual deviation from 80, and subsequently as he healed, we had 16 prism diopters, and that led the parents and the person was very happy, and they just sent this note also. So for patterns, actually, we have to identify that what exactly are the issues. So along with esodiviation, we have a pattern here. We have the superior oblique overaction also, and there is some DVD also. So if we have to actually have a good result, you have to actually address all of that. So customized surgery, which not only deals with the exodeviation. The patient has come to you with the deviation. The patient does not understand that there are so many components to it. But if you actually do this, then you can actually get a decent result also just with a non-adjustable procedure also. Like another case where we had a large angle deviation and a vertical deviation on cover test. And as you can see, there's a large vertical deviation in the left case, the lever version, which is basically because of the inferior oblique overaction, and there is a superior oblique underaction of the right eye also. So this was basically a superior oblique palsy, which had a less fusional amplitude, and somehow, it has drifted into exodeviation over a period of time. The intermittent has become a constant deviation. So when you actually have these multiple components, you just decipher all these components and do a customized surgery. So 3 muscle surgery for the exodeviation here and a superior oblique tuck along with the inferior oblique weakening actually give us a decent result. Similarly, for the DVDs, we know that we have all these gamut of procedures. A large angle DVD with the person already had uveal colobomas in the eyes, so vision was not the aim. The aim was basically restoration of the looks. So we actually combined the superior rectus recession along with inferior oblique transposition, and we got a good result. And the patient had poor vision in the left eye, obviously. So this another young lady, with a combination of escodeviation and a hypotropia of one of the eyes. And we remember to check the axial length. Obviously, she was a high myope. And this is her MRI scans with elongated globes and hardly any space, in the orbit, and the medialization of the muscles here. And what we basically needed to restore the position of the extraocular muscles, and that's what we did. Just a bilateral loop myopexy was done in both the eyes, and we had a decent result. Another patient of high myopia with exotropia and hypertropia. In fact, we have a series, published of such cases where we have a large angle, deviation, both exo and the vertical deviations. So you identify all the components, what exactly is the deviation, and just a customized adjustment, handling of that particular deviation gives you decent results. So what we found out was that in the exotropia combined with the large high myopia, we don't really see displacement of muscles much. The muscles are actually in their normal position, and you have to just customize your surgery according to the deviation involved. So a lady, an international patient, if you see carefully, she has a large adduction deficit, in the right eye. And this was because, because she had trauma, and this medial rectus had got incarcerated in the medial wall fracture that she had, and that's what was causing the thing. So we took help of our oculoplasty surgeon, who basically repaired the orbital fracture. We freed the medial rectus and just waited in the first sitting, just without any specific procedure. She had a little improvement, I would say, in the first procedure, and probably we could do more with the vertical rectus transposition. The adduction also improved marginally, but it was gross improvement from what we had early, from the first step. Then in just a recent case in lockdown, with all the limitations that we have in handling strabismus, a young lady again, had 2 procedures elsewhere. And one of the common problems that we face is you don't have the records. The lady had a discharged lip, but there were no surgical details, mentioned there. So surgery was done at 4 years, and another was done at 15 years. And if you see carefully, what is happening is she has a large angle exodeviation. She had a head turn also, and she had a lost medial rectus. Fortunately, the scan was there, with her, but this was a little old. She had come from outstation, and she was desperate. And our oculoplasty, sir.
Yeah. Try to.
So the last case. So our oculoplasty surgeon was also down with COVID. So I just kind of took up the challenge and, thought I'll just brush up my oculoplasty, the surgical spaces, everything. And I just, went ahead. Very interesting. She actually had a FDT which was tight, understandably, because there was some 5-6 years back she had the previous procedure. So there was a pseudotendon that I identified, traced it back. I was fortunate enough that I could really have the MR, retrieved it and anchored it to the sclera. And a big role of I would say the string test and the spring back tests in this, because if you have a 60 prism diopters of exodeviation, what exactly do you do? So I just freed the adhesions around the lateral rectus, and the spring back test told me that, do not touch the lateral rectus. And I just went with that instinct. And this is what, I just got, on the first post-op day. A little ESO, I would say, but I think she would improve. But more importantly, you can see the adduction, which wasn't there, almost -4 adduction, improved. And this is what it is. And we're just awaiting the follow-up. She's back to her home and she'll just come in a while. So complex strabismus can reasonably be tackled by carefully eliciting all the components, and we have to tackle each component, and it requires a careful planning. Thank you so much.
Thank you, Dr. Sumit. I think as you have shown, basically strabismus is always an interesting subject from this point of view, that we need to individualize each patient's surgery. We have to observe, confirm, infer, plan, and execute, as I say, the OCP, OCIPE, and individualize it for that particular patient. And this is much more so for the paralytic strabismus or restrictive strabismus, which are much more challenging. Dr. Deemer has recently, one of the cases which you presented was the sagging eye syndrome. Dr. Deemer has nicely given a lecture in which he has tried to differentiate 3 types of these which are associated. One is a sagging eye, the other is a heavy eye syndrome, and the third is a wobbly eye syndrome. So the sagging eye is one in which it's mostly because of mild myopic degeneration, but even in aging patients, because of the degeneration of the intramuscular septum between the superior rectus and the lateral rectus. The lateral rectus tends to sag down, and that is why there is overaction of the medial rectus, even though there is no paresis as such of the lateral rectus. In such cases, he's suggesting that even if you just hitch up the lateral rectus up, it will work along with your recession resection. Sometimes even MR recession may not be required. You need to hitch up the lateral rectus. In the heavy eye syndrome, the superior rectus gets nasalized, and even the inferior rectus is nasalized. In these cases, it is paramount to do the loop myopexy as advocated by Yokoyama. The wobbly eye syndromes are the most difficult. They are usually with very high myopes, maybe -20 diopters or so. The eyeball is such large that the orbit is not enough for them, and you cannot move them. It's a structural problem. So these cases, sometimes I have had a problem. One is because of high myopia. You can also have because of a congenital colubomatous cyst, which is or a staphyloma. So I mean, I took up that case thinking that it's a strabismus. I did the FDT, it wouldn't move. When I looked at the muscles were all in position. It was basically because of a staphyloma. So if you do an imaging or an orbital scan in these cases, it would help you prior to the surgery. Then in such cases, any surgery will not work because it's a structural problem. You need to probably do something to decompress orbit.
Right. Thank you, sir. Just one point. You mentioned about the high myop cases. Any experience of Nishidas, like that?
See, basically, the Yokoyama procedure is in a way similar to Nishida's. What he's doing is shifting the superior rectus and the lateral rectus and hitching both of them to the superior temporal quadrant. So it is in a way half Nishida, in which lateral rectus is also being hitched up. The superior rectus part is like half Nishida, which is being brought into that. So all these procedures, the Yokoyama procedure or the Yamada procedure or the Nishida procedures, if you see in the Japanese literature, they are all mixing into one another. These are like a spectrum. Yeah.
And just one query about lost muscle. I just want to take your opinion. See, if you have a lost muscle and you are retrieving it and attaching it, you don't know really how much it will correct. So in these large angle deviations, do you also go for lateral rectus? Like in this case, she had previous surgeries. I anticipate, I don't have the surgical details, but it must be resected. So do you actually go for multiple procedure like the other eye also? You plan in the same sitting, or you just?
I think before you joined, we were discussing this aspect. Dr. Ankur was also asking the same thing, and we were talking about this, that it's better to go stage wise. In such a case, rather than doing the Nishidas in such cases in the first go, it's better if you got the muscle, even if you think it is not fully or only a few of the fibers are there, it's better to hitch it at that time and hope for the best. and then only plan, because you don't want to have an overcorrection or an unnecessary surgery in that case.
Sure.
Yeah,
Thank
so
you, sir.
just one point I want to make related to the muscle transplantations. Actually, they give miraculous results, Dr. Sumit, and we have also seen that large angle exodeviations can easily be corrected. But the only thing we feel that we have to see the long-term follow-ups, because that tissue is supposed to, it's expected that it will become fibrotic, will remain as a spacer. But I think we should see the long-term follow-up of these cases, that how the transplanted muscle actually behaves, you know. And it would be interesting. That's what we are planning, that we are kind of looking at the imaging. That's what's happening, and the follow-up of the cases. That's what's happening to the tissue over there. So yeah.
Rebecca, there are a lot of studies. I mean, in fact, the first study was the injury where the muscles were repaired.
Okay.
So definitely they go into fibrosis.
Yes.
They have fibrotic cords eventually. So they have shown, it's a very old article which is published. So I also read it before I started doing transplant. But what happens is, you do these surgeries, you have -1 to -2 of limitation of adduction in that particular case. So if it is done for a large ESO, the eye will not come in properly fully.
Okay.
But they are to be done only in the patients who refuse the other eye surgery in all possible
Absolutely,
ways.
yes.
So that's a big problem. And in the private practice, if the patient is not coming back to you after 1 year or 2 years, you feel that he's okay.
Okay, right.
Another thing which you have to remember is these procedures are mostly proven to be successful in esotropias, where you are doing a larger amount of lateral rectus resection, and which is available for the middle rectus to be lengthened. But the reverse is not true, because in that case, equitable surgeries, you will do middle rectus 6 and lateral rectus you want 9, you won't have it.
Right.
It doesn't work for that. So it's usually going to work for a esotropia, where the lateral rectus resection is usually larger. So
Right. Transplant the tissues.
If a 9mm segment has been taken and you put it in place of and make it work, it will be naturally much efficient.
So we published this in JPOS. I mean, it didn't really work in exos.
That's what I'm saying. So
the muscle stump is smaller, as sir has already mentioned. Like for LR, you get around 7 millimeters of muscle stump.
Yes.
So
but
MR, what will you get?
Resection, which was used, right? You resected middle rectus and stitched it to the lateral rectus. Did you?
Yes.
So that's why the result was not as he was expecting. He had an undercorrection. So this is always going to be there. To my mind, I am not very much enthusiastic about this transplantation. I feel that if I have to do a larger recession, I do a hemi hangback. What I mean by hemi hangback is that suppose I have to do even a 25mm of lateral rectus recession in a third nerve palsy. I can do that. What I do is I would do stitch it around 18 mm from the insertion and a 5mm hangback.
Right.
Never let the muscle hang more than 7 mm. So you can do a hemi hangback. You can have the sutures passed in the sclera at 15 or 18 mm and let the rest hang back, and it gives good results. So you don't have to really put a muscle which may shred off or may get fibrosed, whatever. I mean, I feel it works even without that.
But I mean, another study, I mean, in JPOS, probably a few cases, 1 or 2 cases in exotropia, they've shown good results with 70-80 prism diopters with muscle transplantation. So it's so conflicting, I mean.
But I'm telling you, you can do, there are some studies from China which have shown that even for 70 prisms of ESO and exos, they have done large muscle recessions without transplantation, without muscle transplantation. So they have done like 12mm of lateral rectus recession and 9mm of resection of middle rectus, as we do for Anderson's procedure. So that is also another option. For very large, very tight lateral rectus, you can go in third nerve palsy, for example, there is a 70 or 80 prisms of third nerve palsy. We have done lateral rectus recession of 12, 15, 18, 25 millimeters. As long as the FDT is tight, we need to recess it further, and it yields good results. Sometimes we have to do periosteal fixation if even that 18 or 25 is not going to work. So I think we are almost up with the time. If there is any specific question we can have, otherwise we would like to.
Yeah, just a comment about the resurgery, like Dr. Sumit Monga was saying. I mean, we didn't have the records and all before MRI. I think the ASOCT is a really good tool. I mean, UBM is still cumbersome. The ASOCT really gives you a good amount of, you can say, your imaging on where the muscle actually is. If you can't see it for a particular, up till a particular limit, you know that it's gone beyond that. So you can just plan it accordingly. And I think my colleague here, Savleen, is doing a wonderful job. I mean, the imaging, what she does is just too good. I mean, I can rely. I send her so many patients that for resurgery, and we are just collecting those cases and seeing them intraoperatively, whether that correlates with the with these imaging or not.
Quite right, Jaspreet. I think ASOCT is an handful tool, but always it doesn't work. Many times you are going to be misled also. And you may feel that there is on ASOCT there is something, and when you go there you find it was just the fascia or just the sheath is there and the muscle fibers are not there.
Agreed. So, we're just studying how
Dr. Sovita presented this similar paper yesterday where the ASOCT was done in cases of resurgeries. So they could find that no, not Sovita, I think Gunjan presented, Gunjan Saluja, sir.
Okay.
So you only operated those cases, you and Swati, I guess. So the difference was, yeah, she presented that case in another strabismus session. The difference was only 1 to 1.5 millimeters.
Yeah, but these are the
she showed
which we have done is in the anterior part of the equator, anterior to the equator.
Yeah. Anterior to the equator.
It is limited. I mean, we do not slip muscles and all. When we have something slipped beyond equator, usually we are going to be in problem. We have to do our digging.
But then you know it's gone beyond. At least you know
gone beyond, yeah.
So thanks a lot for a very lively discussion that we have had for each speaker who has done a wonderful job, and there have been listeners like me. Thank you all.
Thank you, sir. Thank you, everyone.
Thank you.
Thank you, sir. Thank you.